patients who admit in our IP patients. In ADS patients, they are more prone to go into delirium, and also if we even treat the delirium per se, we should correct the electrolyte imbalances so the patient will come to full health. And also it's mandatory to do a prerequisite check when the patient gets admitted in your hospital. So routine checks should be done so as to tackle the imbalances of serum electrolytes. And we should also say the importance of alcohol cessation or reducing the substance use. Thank you.
Yes, any questions from the floor? Dr. Kalyan, was there any significantly raised single electrolyte was there in your study?
Combinedly we saw, sir.
Yeah.
Mostly the chloride levels are very much low. In our study, chloride was significantly very low, like more than the lower baseline also. It was 96. We took normal range from 100 to 100 milliequivalents. But most of the people with ADS were getting 96, around 96, 97, 98, which was not even touching the lower normal levels of chloride. And sodium, potassium were also in the baseline normal, but majority of them were below the normal. Yes, people who are having low electrolytes in the below the normal level have prolonged deliriums, and they are having many they are having extended confusion after treating the delirium also. They are very much severe confusion which was not subsiding after the de-addiction therapy also. In many patients who are not after the correction, they became all right. Everything was set.
Thank you.
Thank you. IP and OP patients. No, sir. We included all other illnesses. Actually, there is a tertiary care center where we get many people who are addicted to alcohol. We get every day we will be seeing around 10 to 20 cases of withdrawals. So many people are like males and females are equally consume alcohol in daily basis. Normal patient. Like we evaluated that if they are drinking occasionally also we took. Only the patient who are above 18 without any comorbidities also we took the controls. Like equally we matched with the gender match also. Thank you, sir.
Thank you.
Rajana.
Rajana. Please come forward so that you don't get distracted.
Request all the presenting postgraduates to come forward.
ఇంకా ముందు వైట్కి రా.
Good morning, everyone. Myself, Dr. Srikar. I am from Mamata Medical College, Khammam, and today's my presentation is on anxiety, depression, and its impact on quality of life in postnatal population. Introduction. Postpartum is a period after parturition of baby, which usually lasts for about 6 to 8 weeks of period until the mother returns to her pre-pregnant state. Psychiatric illness are most common during postpartum period and may influence the quality and degree of functional impairment. Almost 10% pregnant women globally suffers from one or the other psychiatric illness, primarily due to the depression. Postpartum anxiety illness are also most common and includes panic attacks, intense anxiety, about not getting enough sleep, obsessive worry about the baby's health or safety, and intrusive thought or mental image of hurting baby. Depression and anxiety may lead to lower quality of life among perinatal period. There are very few studies on quality of life and its association with the depression and anxiety in India. Our present study is to evaluate relation between anxiety, depression and quality of life among postnatal mothers. Aims and objectives. My aim is to study the prevalence of anxiety and depression among the postpartum females and their quality of life, and to assess the association between anxiety and depression and its impact on quality of life among postpartum females. It is a cross-section study which is done with 236 postpartum women, and it is done in Mamata General Hospital, Khammam. My duration is from September to April 2024. Inclusion criteria. The mothers who have delivered babies in the last 6 to 8 weeks, which is postpartum period, and patients who are aged 18 to 30 years, and also mothers who have given the consent for the study. Mothers who have been previously diagnosed with psychiatric illness and medical comorbidities, and mothers who have lost the child due to abortion or childbirth complications or any deformities. Mothers who did not give consent for the study are excluded. And the study was done under the approval of ethical committee. The tools I used is Edinburgh Postnatal Depression Scale, Perinatal Anxiety Screening Scale, and WHO Quality of Life Brief Scale. Data were analyzed using statistical package for social sciences SPSS form software, and the descriptive statistics including mean and frequency distributions were calculated for categorical data. Associations between identified with the student t-test and Mann-Whitney u-test for the quantitative data. Pearson correlation coefficient were also used to examine the association between the Edinburgh Post-Depression Scale and the anxiety score and WHO Quality of Life Brief Scale. Coming to results, out of 250 participants, only 236 agreed and completed the assessment, producing a response rate of 94.4%. Majority of the people are 21 to 24 years of age, belonging to a Hindu religion, and most of them are from rural background, and 36% are illiterates, and 32% have completed the schooling. Patients who have previous abortions are 40, which is 16%. Coming to the prevalence of depression, the mild to moderate depression are 27%, and severe depression is 23%, which scores more than 13 in the Edinburgh Post-Depression Scale. And the prevalence of anxiety is 7%, which are severe, and 30.
It will go down in any anxiety, any depression. Postnatal. Yeah, please go on. Postnatal period is a very important period. Our quality of life going down will bring down the quality of life of the baby. Okay, that's it.
That was very good. And sharply looking at the time also, we have done it really good. Thank you.
We now have Dr. Sneha Pipiri presenting us a cross-sectional comparative study on sexual attitudes and sexual myths among males and females of the first year medical students of Tertiary Care Teaching Institute in Hyderabad.
Good morning everyone, myself I'm Dr. Sneha, and my study is on the cross-sectional and comparative study of sexual attitudes and sexual myths among males and females of first year MBBS students. Introduction: sexual attitude refers to attitude one has towards sexuality or sexual behaviors, which could be either liberal or conservative. Sexuality is a complex and multifaceted aspect of human life that encompasses sexual orientation, sexual behavior, gender identity, sexual health and emotional and physical bonds that individuals form with others. It is influenced by biological, psychological, social and cultural factors. Sexual attitudes among undergraduates have garnered significant academic attention due due to their implications for public health, educational policy, and societal norms. Understanding these attitudes is crucial for addressing issues such as sexual health, education, consent, and sexual violence prevention on college campuses. Studies have shown that there is a wide range of sexual attitudes among undergraduates, from conservative to liberal perspectives. First-year medical students, due to their developmental stage and transitional nature of college life, are particularly susceptible to forming and perpetuating sexual myths. The college environment often exposes students to new social norms and peer influences that can shape their sexual attitudes. With emerging westernization, there is changing attitude towards sexuality. Although young people's knowledge and awareness about sexual and reproductive health is increasing, much of this knowledge remains superficial and riddled with myths, misperceptions, and sense of vulnerability. Gender discrimination coupled with stigma about discussing sex and sexuality issues with young people further contributes to risk-taking behavior amongst youth, thus influencing their sexual and reproductive health. Sexual myths are pervasive and often misleading beliefs about sexuality that can significantly influence the attitudes and behaviors of medical students. These myths can shape how students perceive their own sexual experiences and those of their peers, often leading to misconceptions and hinder healthy sexual development and decision making. Researchers indicate that sexual myths among undergraduates stem from a variety of sources including cultural norms, media portrayals, peer influences, and inadequate sex education. These sexual myths can have serious consequences such as increased rate of sexually transmitted infections, unintended pregnancies, and unhealthy relationship dynamics. For example, misconceptions about the effectiveness of contraception methods or risks associated with certain sexual activities can lead to unsafe practices. My aims of the study are to assess and compare sexual attitudes and sexual myths among males and females of first-year MBBS students. Objectives to study socio-demographic data, to study and compare sexual attitudes among males and females, and to study and compare sexual myths among males and females. Study tools are brief sexual attitude scale, sexual myth scale, modified to Pushkami scale, intake performer, consent form. Study design, it's a cross-sectional and comparative study. Sampling is convenient sampling and sample size is 50 males and 50 females. Period of study is 3 months. Inclusion criteria are medical students studying first year MBBS and are willing to participate in the study by giving informed consent. And first year medical students who are unmarried. Exclusion criteria, students not willing to give the consent for the study. Methodology, the data was collected after taking informed consent of the participants in online format from 100 first year medical students. Brief sexual attitude scale, sexual checklist, and modified to Pushkami scale were included in the Google form, and data was collected and analyzed using SPSS software. This shows us table of showing the socio-demographic data, in which majority of them were from urban background and nuclear family. Most of them were day scholars and belonged to upper socioeconomic class. This is a table showing brief sexual attitudes comparing male and females. This study compares sexual attitudes among males and females. Females scored higher than males in some skills of permissiveness and instrumentality. Males are more permissive and instrumental, which can be due to cultural norms, peer influence, high testosterone, media representation, psychological factors like self-esteem, validation, greater acceptance, and casual relationships when compared to females. Lower scores obtained from the subscale of permissiveness signify that respondent has a casual sex life and attitude toward this life and shows a liberal manipulative attitude towards sex. No significant difference was found in the subscales of birth control and communion. In a study, Henrik et al. Performed an evaluation with original sexual attitude scale and stated that there is no significant difference in the subscale of birth control in terms of gender, and men were more permissive and instrumental when compared to women, which was parallel to the study. In the same study, no significant difference was determined in the subscale of communion in terms of gender, which is also in parallel with our study. In a study conducted at Gall et al. In France, reported that men were more permissive than women. As a consequence of this study and other studies being conducted in the US, France, and China and Turkey supported that men were more permissive. However, more number of studies are not sufficient to interpret the results of birth control, communion, and instrumentality. This is a table showing sexual myths among males and females, which is not significant. These are the sexual myths among males, and these are the sexual myths among females, and these are sexual myths among both males and females. Sexual myth is an information belief that one holds with no support of relevant scientific evidence. This study describes the status of sexual myths among males and females of first-year MBBS students. The study compared sexual myths among males and females, which showed no significant difference. Masturbation is a sign of mental weakness, is found to the most prevalent sexual myth among males, Although some studies suggest that individuals with previous sexual experience could have less sexual myths, some contradict it. Yasin reported that sexual experience and having sexual partner decreases the prevalence of sexual myths among women, but most myths persist despite sexual experiences. Masturbation causes impotency in men and rigidity in women is another prevalent sexual myth among males and females, which is parallel to the study by Teja Bhargavi et al. Sexually active women have larger breasts is another prevalent myth among female medical students. One of the major possible factors for myths are lack of communication and exposure. Sexuality could be a subjective concept, its meaning could differ for each individual. The culture, upbringing, religion and practices could play a role in the beliefs and myths that humans form. Exposure to reliable information regarding human sex health through sex education is a direct answer to debug the myths one forms and prevent further one forming. Conclusion: the result of the study indicates males are more permissive and instrumental and presence of sexual myths among males and females. Males showing liberal attitudes and females, this trend can be due to a combination of biological, psychological, social and cultural factors. The presence of sexual myths among females and males shows that significant gap in sex education and awareness. These myths are often perpetuated by cultural norms, media portrayals and inadequate education system. This contributes to misunderstanding and misconceptions about sexual health and behavior. Implications of the study provides a broader understanding of gender influences on sexual attitudes and myths. The study emphasizes the critical need for targeted educational strategies to address and rectify gender disparities. Universities play a vital role in the effort by providing accurate information, creating supportive resources and encouraging conversations about the sexual health. Limitations: participants may provide responses that are perceived as socially acceptable rather than reflecting their true attitudes or beliefs about sexuality, particularly on sensitive topics like sexual attitudes and myths. Small sample size is another limitation. These are the scales.
Only a suggestion was that your presentation was, it can improve. The presentation can be better, and you can make, instead of reading the whole thing, you could have highlighted a few things and you could have made, because we also can read you, right? That was one thing. And it would be good, just an extension of this thing, it would be good if you could compare the myth percentage and their anxiety, at least anxiety or other things. Because usually the children who have more of these myths tend to be more anxious, socially isolated, social anxiety, all these things. So if you could have used one scale in that, it would have added more quality to your paper, right? But otherwise, overall a good presentation.
Basically, the topic itself is a very brave topic. I appreciate you for taking that. The point is, you have been rushing it so fast, I could not process a lot of things. Yes, that was a good one.
a chance to ask you something else.
Thank you. Any questions from the audience? There are no questions, then I think. Thank you.
Next we have Dr. Punvani Rashmi presenting us impact of internet usage on self-esteem.
morning everyone. Myself Dr. Rashmi. I am presenting the impact of internet use on self-esteem. The internet use is one of the most important part of our present day-to-day society, and excessive use has its impact on day-to-day life. So withdrawal symptoms when not engaged, a diminished social life, adverse work, academic performances, and the consequences which are in other substance use disorder we are finding. So it's present in internet addictions also, and it is considered growing across the world as one of the most addictive disorders. So it is known to affect many behavioral aspects, and of late self-esteem is one of the self-esteem of a person is also getting impacted in it. So among the 50 studies conducted in India across the 19 states, it shown overall prevalence is 40.7% based on the young's internet addiction test scales cutoff scores. So internet addiction is an umbrella term that refers to a compulsive need to spend a great deal of time on internet and to point of a socio-occupational dysfunction of a person. The main objective of this study is to explore the internet use among the people and patients, to study the percentage of people who have internet addiction, to study relation of internet addiction and self-esteem in normal controls and in patient diagnosed as a bipolar disorder. So the inclusion and exclusion criteria. So a normal control, inclusion is person who are above 18 years, cooperative for interview, give consent for participation in study, and exclusion is person who are below 18 years of age and who have some psychiatric illness or substance use in normal control group. In case group, the inclusion is matches a DSM-5 bipolar affective disorder criteria, and exclusion is any medical comorbidities. So the methodology was 6 participants were taken, consecutive convenient sampling was done, and under which the 30 were control, 30 were a case group. So in 30 control group there was GHQ 12 scale was given, and the cutoff score less than 15, which are fall under a normal category, and the 30 case group was taken in which the from OP and IP basis, and the DSM-5 bipolar affective disorder criteria was matched. And both of them were given a Young's internet addiction test and Rosenberg self-esteem scale applied. Okay, so the total 60 participants were there, and the socio-demographic data was collected, and this internet addiction test of Young and Rosenberg self-esteem was applied. So the internet addiction test of Young scale, it is given by a Dr. Kimberly Young, and it consists of 20 item scales, in which there will be 0, 1, 2, 3, 4 like scoring will be there, like 0 will be a never, 1 will be a rarely, 2 will be a often, 3 will frequently, 4 is always, and so this, and there are 20 items were there, and there were a mild scoring was from 20 to 49 points, a moderate scoring was from 50 to 79 points, and severe was from 80 to 100 points. In Rosenberg self-esteem esteem scale, that contains 10 items, and the total score was from 0 to 30. This contains 10 questions, upon which have selected strongly agree, agree, disagree, strongly disagree, and score below 15 was a low self-esteem, 15 to 29 was a normal, 15 to 25 was a normal, and greater than 25 was a high self-esteem. So results, from this, the socio-demographic 60 participants were there. Among them, the age range was 18 to 60 years, but the mean age group was 25 to 40, and the 22 were male, 38 were female. So we have found that in a control group, the 8 persons have a mild internet use, 19 had a moderate use, and 3 has a severe internet addiction. A case group among them, there are 5 were having a mild internet addiction, 21 were falling in a moderate range, and 4 were in a severe. In Rosenberg self-esteem, among the control group, among the 30 participants, there were 4 were having a low self-esteem, 11 were having a normal, and 5 were having a high self-esteem. In a case group, we found that there were 18 were having a low self-esteem, 9 were having a normal self-esteem, and 3 were having a higher self-esteem. Chi-square test was applied for a control group and case group, which was found to be a 30.36 and 27.9 at 0.05 significance rate. So in the control group, as we told, like 8 was having a mild, 19 were having a moderate addiction, 3 were having a severe. In case group, 5 were having a mild, 21 having a moderate, and 4 were having a severe internet addiction. So the self-esteem were compared. So among the normal people, among the control group, the 46.6% people were having a low, 36.6% having a normal, and 16.6% have a high self-esteem. In a case group, 60% had a low, 30% has a normal, and 10% has a high self-esteem. In a case group. So as we can see in this picture that the internet use has a great impact on self-esteem in a normal person and person with bipolar affective disorder. In this study, we observed that in control group, 26.6% has mild, 63.3% has moderate, and 10% has severe internet addiction in a control group, which is a normal population. Among them, 46.6% has low self-esteem, 36.6% has normal, and 16.6% has a high self-esteem. So in this study, we have observed that in a case group, what was the finding in a case group? So case group has 16.6% mild, 70% has moderate internet addiction, and 13.3% has severe internet addiction. Among them, 60% had low, 30% has normal, and 10% has high self-esteem. So the conclusion, due to the small sample set, definitive conclusion cannot be met, but based on the result we have observed, there is internet use has a great impact on person's self-esteem. In this study, we found that 46.6% had low self-esteem in a normal population, which is a control group, and 60% had a low self-esteem in case group. So limitations of my study, a small sample size, so result cannot be generalized to population. This was observational study, so in case of group duration of disease, its impact and further progression on internet addiction could not be established. These are my references. Thank you.
Good presentation. Yeah, again the same problem. I think girls have this obsession to keep reading the whole thing. Right? You need to catch up with that. And what is mean? Can mean have a range? Your age had a range. Mean age has range.
No,
it should be one. Which mean, median, and mode are one thing. You can have a standard deviation. So I think many things like that I can point out, but please check for your stats properly. And a good attempt. Thank you.
So I think there is a lot of scope for improvement in this. Any questions from the audience? Okay, so there are no questions from the audience. Thank you for the presentation.
Sir, thank you.
Thank you. Now I request Dr. George Reddy sir and Dr. Vishal sir to felicitate the chairpersons. We request all the residents who are presenting award paper to come forward and be ready.
I request all the award paper presenters to come and copy first.
late GBC Taramaya Krishna Leela PG Award onto the dais, Dr. Sudharani Ma'am and Dr. Anita Ma'am. I request Dr. Ramani and Dr. Niveda to felicitate. Dr. Sudharani Ma'am has received her MBBS from Kurnool Medical College and MD from Osmania Medical College, is currently a professor of psychiatry at Osmania Medical College, has 11 publications in various journals and 15 presentations at various conferences. Welcome you, Ma'am. Dr. Anita Ma'am is a professor at Institute of Mental Health, Hyderabad, has received her MD from Institute of Mental Health, Hyderabad, has 15 years of teaching experience and is currently a treasurer of Indian Psychiatric Society, Telangana State Branch. She is a recipient of Kodugu Ramanna Chinna Reddy Gold Medal Award for award paper in consultant category for 2018 and 2022. She has around 15 publications and is involved in various public awareness activities. She has worked as HPS Vice President from August 2022 to August 2023. We welcome you, Ma'am.
Good morning, everybody. So I welcome all the participants to be ready with their presentations. The time allotted is 6 minutes for the presentation and 4 minutes for the questions. So I welcome you all and 8 minutes. Yes, no, you got 6. Sorry, small correction. 7 minutes for presentation, 3 minutes for questions. So I wish you all the best. Okay, I welcome you all to start the program.
Shall I call upon the stage Dr. V. Renuka? You can start your presentation.
Good morning, honorable delegates. This is Dr. Renuka, a second year postgraduate from Malarati Institute, and my guide is Dr. Anand Sir, Professor and HOD of Malarati Institute. Today I am going to present a study on association between alcohol decisional balance, craving, interoceptive awareness in alcohol use disorder, which is a cross-sectional study. So, coming to the introduction, according to the 2018 report from the WHO in 2016, the harmful use of alcohol resulted in 3 million deaths, or 5.3% of all deaths, predominantly among men. The National Mental Health Survey of India 2015-16 found the prevalence of alcohol use disorder to be 9% in adult men. In India, the alcohol attributable fraction of all cause deaths was about 5.4%. Coming to the important components in the alcohol, so craving, which is a strong desire or urge to use alcohol, which is an emotional state of an individual to seek and motivated to seek and use of alcohol. So interoception refers to the perception of all major systems involved in bodily homeostasis like hunger, thirst, sexual drive, itch, etc. So decisional balance involves the consideration of set of possible options and the consequences of each options, like from ranges from desirable to undesirable effects like pros and cons, and that will assess the net value of the potential behavior of the individual. So there are only few studies examining the combined influence of the above factors in alcohol use disorder, which is an impetus to undertake this study. So aims and objective, this is a cross-sectional study which aims to compare the craving, interoception, decisional balance in alcohol use disorder. And the objectives, in order to assess the correlation between the Penn alcohol craving scale, multidimensional assessment of interoceptive awareness, alcohol decisional balance skills, and socio-demographic variables in alcohol use disorder. Coming to the methodology. So we have gathered around 20 people, both male and female, with alcohol use disorder diagnosed according to DSM-5 criteria, and who visited outpatient and inpatient to the Malarati Institute, to the psychiatry and various other departments, and who fit the eligibility criteria and given the consent, and we have taken the institutional ethical committee approved the study. So inclusion criteria. So patients diagnosed with alcohol use disorder and the patient aged between 18 and 70 years of age, both males and females who has given the written consent to to participate in the study and no previous history of severe mental illness. So exclusion criteria, we excluded the severe medical illnesses and alcohol-related delirium, psychotic disorder, hallucinatory, delusional disorders and mood disorders. Any concurrent substance use other than alcohol, and any surgical interventions like pain and discomfort, and patients who with the language impairment or mental retardation and who could not able to understand the questionnaires and who refused to give the consent, we have excluded them. So instruments used are the DSM-5 textual revision criteria, and for the social demographic data, Kupuswamy scale, updated version 2019, alcohol use disorder identification test, pen alcohol craving scale, and the multidimensional assessment of interoceptive awareness and alcohol decisional balance scale. So which includes pros and cons. So pros who are motivated to quit alcohol, cons who continue to drink the alcohol. So this is a sample size calculation. So we have used the calculation T is equals to difference between the two independent means by sample population under root 1 by n1 plus n2. Here the sample size is 20 in number, allocation ratio is n2 by n1 which is 1, and the alpha error which is a false positive 0.05, and the power is 0. Parametric assessment, so we have assessed the association between the variables by Spearman's rank correlation and the scatter plot to depict them in a graphical form. And in the RHO values and level of significance are included in two groups of alcohol decisional balance like pros and cons, and here we included the level of significance with p-value less than 0.05. So result, coming to the first table, so it depicts the descriptives of the variables like age, sex, socio-economic status, and audit which is alcohol use disorder identification test, and the decisional outcome. So in this group, the majority of the individuals like harmful to moderate use shows around 95%, and among them male shows the predominance of 80%, and the decisional outcome shows the who are quit to or who continue to drink alcohol or cons, so they shows around 70% predominance. So coming to the table 2, it depicts the test of normality of the variables divided into two groups on decisional balance scale. So the variables are like age, audit, and the PAC scale, and the multidimensional interoceptive awareness components like noticing, not distracting, not awareing, attention regulation, emotional awareness, self-regulation, body listening, and trusting. So for this, we have grouped into pros and cons for each variable, and we have employed the Shapiro-Zwick test. So in this, all the components shows non-significant. Only the components like emotional awareness in the cons group and trusting in the pros group shows a significance. So this shows that suggesting that null hypothesis is accepted, there is no deviation from the normality. And the Spearman rank correlation and scatter plot, as I said before, that was represented in the graphical form in the cons and pros group. So in the cons group, this is a graph one which shows the scatter plot between alcohol decisional balance and pen alcohol craving scale with a confidence interval of 95%. So this shows the significant positive correlation between the persons who continue to drink alcohol will experience the higher levels of craving. It shows a positive correlation. Then coming to the graph 2 and graph 3, in the cons group, we have taken the significant component of interoceptive awareness like body listening and trusting. So in this, there is a significant of 95% confidence interval. This shows that there is a negative correlation between decisional balance and interoceptive awareness of body listening and trusting. So this shows that the individuals with deficits in the interoceptive awareness parts like body listening and trusting will continue to drink the alcohol. So in the pros group, so graph 4 which shows who are motivated to quit alcohol. So there is a positive correlation between these who are more motivated to quit alcohol and the craving. So there is a positive correlation. And the graph 5 and graph 6. So in this, the self-regulation and emotional awareness components of interoceptive awareness are scatter plotted with decisional balance. So who are individuals who motivated to quit alcohol, they have higher levels of interoceptive awareness, bodily sensations. So coming to the discussion. So we have observed the male predominance in the study sample which aligns with the global trends as per WHO, shows a higher prevalence of alcohol use disorder among men. So a majority of the participants exhibited harmful, moderate to severe alcohol use. So here
your time is up. Your time is up. Any questions from the audience? This is an award paper, so I request the audience to actively put your questions. can conclude. We'll give you 1 minute extra.
So, we have seen 70% of people in cons groups. So, individuals more in tune with their body sensations are less likely to continue drinking. And in the pros group, individuals who are more motivated to quit drinking experience lower levels of craving, and they are more aware of their emotions and able to regulate them. So, the strength of the study, so here the sample size was small and it follows a normal distribution. We have administered the non-parametric correlation, and there is no deviation from the normality. Limitation, it is a cross-sectional design. There are some factors like cultural factors, social norms, personal experiences which influence the scaling ratings. And in conclusion, this study contributes to the understanding of the every component like craving, interoception and decisional balance, in emphasizing the need for comprehensive assessment and interventions during these interconnected factors. So by addressing these factors concurrently, clinician can develop more effective strategies for the AUD management. These are my references. Thank you.
Yeah, she finished her presentation. I request the audience to put the questions. So, can I ask some questions? Like, what is your reference? Is there any study with the same, like, decision making and...
There are only few studies related to these factors, which are influencing the alcoholic decision making. The decision making, how the body sensations of their awareness of their body sensations influencing the decisional outcome of those individuals, and about the craving. So all these factors are interconnected, ma'am. There are some studies related to this, ma'am. So we have taken and we got the results similar to those studies.
So, but your sample is 20,
yeah,
right?
Yeah.
And you have divided into mild, moderate and severe alcohol dependence.
Yes,
and some variables are like single digits.
Yes, ma'am.
Like cons and pros group, only 6 individuals are there. So do you think it is statistically giving significant results when single digit numbers you have taken and categorized 20 into different subgroups?
But we got the results, ma'am. There is no deviation from the normality.
No, can we project that 20 individuals breaking down into subgroups, single digit individuals, then extrapolating them? How can we, draw conclusions from such a less sample? Alcohol dependence is a very vast, it's very common. So why can't you take a bigger sample?
We have to assess the scales, and so it took time, ma'am, for everything. So so we have included only those, ma'am, but we got the results, ma'am, which shows similar results.
That is a limitation in your study.
Yes, ma'am. Yeah, I have included that also in the limitation part.
Okay. I think we'll... Okay, you can go now.
Thank you.
Thank you. It's a good presentation. Next, we would like to call Dr. Ashna Alex. You can present within 8 minutes and 2 minutes for discussion.
Good morning, everyone. Today I am here to introduce this research paper entitled Attitudes of Interns Towards Mental Illness and Psychiatry, a study from Tertiary Care Hospital. So these are the details of the authors. The prevalence of psychiatric disorders in India is rising, with a total of 14.9 per thousand population. There is a significant shortage of psychiatrists. There are only 0.75 psychiatrists per lakh population, but the discernible number is 3 per lakh. And the medical graduates are reluctant to pursue psychiatry due to misconceptions and stigma. Undergraduate medical education in India allocates only 1.4% of the total time to psychiatry compared to Denmark's 240 hours and USA's 60 hours. So, as a future, doctors in all departments have a pivotal role in identifying mental health issues and delivering quality care in future. These negative attitudes amongst doctors towards mental illness are of great concern, as it may affect the way they deliver care towards these patients in future. Addressing these attitudes is crucial as they may result in inadequate referrals, insufficient information, and patients feeling devalued, thus impacting the quality of mental health care. So, aim of the research is to study the attitude of interns towards various aspects of psychiatry before and after attending postings in tertiary care hospital. And objectives being to determine the attitude of interns towards various aspects of psychiatry, to determine if there is any association between socio-demographic factors and attitudes of interns towards various aspects of psychiatry, to determine if there is any improvement in attitudes after attending psychiatry postings. So this is a cross-sectional comparative study done in interns posted in psychiatry as part of their CRRI program, done in Institution of Mental Health, Hyderabad, with a study duration of 4 months. And the study tools are intake performer including socio-demographic data, ATP-30 scale, modified Kupusamy scale. The inclusion criteria are interns posted to psychiatry as part of their compulsory rotatory internship training period and attended postings regularly, and the interns who gave informed consent for the study. And the study was initiated after approval from the Institutional Ethics Committee of Osmania Medical College. Study was undertaken on interns who attended psychiatry postings for 2 weeks as part of the CRI program, and interns meeting the inclusion criteria completed an intake performer, attitude towards psychiatry scale, and modified Kupusamy scale on the first day. Socio-demographic data was collected using the intake performer. ATP-30 scale was administered on the first and last days of the posting to assess interns' attitude towards various aspects of psychiatry, which are psychiatric patients and illnesses, psychiatrists and psychiatry, psychiatric knowledge and treatment, psychiatric treatment, and hospitals. This is the review of literature. Overall, there is a negative to neutral attitudes are seen in medical students towards psychiatry. It also depends on the year in which we are doing this study. Interns mostly showed neutral attitudes, and second years have neutral to negative attitudes. And the results, a total of 100 students were participated in the study, and out of which 52% were females. The mean age of participant was 23 plus or minus 1.37, and all of the participants were from Telangana state. All students attended 2-week psychiatry postings, which included outpatient department, inpatient ward rounds, case presentations, weekly 2 times CCTs, and a teaching program in the afternoon. And they were also exposed to forensic psychiatry patients' personality and IQ assessment from clinical psychologists. So in the table 1, status showed a positive attitude, and the association between attitude and the socioeconomic status was statistically significant. All study subjects were doing internship unmarried. And this second table shows the ATP scores of study participants in both total and domain-wise change. First one, attitude of towards psychiatric patients and illnesses. The initial pre-posting was 16.2 and after posting is 16.3, and the total p-value is 0.00. Like that, the total ATP score also changed. It is a significant change. And the third one, it shows the response of interns who had psychiatrist as a relative and who has psychiatric illness, and who has a first degree relative with psychiatric illness. They scored slightly better on the total scores, but it was not statistically significant. And this is a table showing significant improvement in attitude of study subjects after attending posting on individual items under each domains. For example, the domain 1, the question was if we listen to them, psychiatric patients are just as human as other people. Before posting, 77% agreed. After posting, subjects have already undergone undergraduate posting in 7th semester. Then significant improvement in ATP scores is found in all 4 domains after posting. And the study found similar mean total ATP scores for both genders. Previous studies on gender difference in attitude towards psychiatry showed mixed responses, where some in which females have more positive attitudes while others report the opposite. Students with personal or family psychiatric illness or psychiatrist as a relative had higher ATP scores, though it was not statistically significant. It is also aligning with the previous studies. The students from middle and low socioeconomic status had less favorable attitude towards compared to the higher income groups. This also aligns with the previous studies done on socioeconomic influence on attitude towards psychiatry. So in a conclusion, we can say that a structured 2-week psychiatric posting significantly enhances medical interns' attitude towards psychiatry across all 4 domains, and socioeconomic status was the only factor significantly associated with the attitude. The limitation of this study was sample size was small and it's a cross-sectional study, so cause-effect relationship cannot be established. Overall, the study underscores the effectiveness of psychiatry postings in enhancing medical interns' attitude towards psychiatry, which is crucial for fostering a positive outlook towards the field among future medical professionals. These are my references, and this is the ATP 30 scale, this is modified Kupusami scale, this is intake performer, ethics committee approval certificate, and the certificate which I obtained to use the scale in my study. Thank you everyone.
Thank you, Asna. She finished her presentation before time now. So there is more time for questioning. Any questions from audience?
Was the sampling method?
It's a convenient sampling.
Does it really reflect the fixed ratio of the interns?
I didn't get the question, sir.
Fixed ratio of the interns, because they are presently 52 and 48.
Yeah.
In reality, the ratio is not 52 and 48.
Yeah, but we didn't take the entire batch. We couldn't take the entire batch because we done the study for 4 months, and we will not get the entire batch rotation in 4 months.
It doesn't reflect the reality. We would have taken the stratified sample so that it reflects real ratio of interns.
Yeah, sir, but we could have taken the stratified sample, but in our setting, IMS interns comes according to the posting. So we could only take the people who are coming to our posting. That is why we chose convenient sampling. That could have been better. Thank you, sir.
Any other questions? So one question: did you had any integrated program for interns after they come to you, or just like that you have taken?
Whatever we are already.
You focused any training or awareness program to the interns?
No, ma'am. We wanted to see what is the change that is happening with the current scenario in the hospital or the curriculum.
Without any extra efforts.
Yeah, yes, ma'am.
So that means we have to implement extra efforts to create more awareness.
Yeah, if you are implementing extra efforts to create more awareness, more mentorship programs, or like more awareness programs or guest lectures, we can improve these attitudes even more.
Okay, thank you.
So 2 weeks posting is enough according to your study, or do you need extra posting, extra hours of teaching in psychiatry?
Ma'am, according to our study and according to the review of literature, we have seen if we increase more hours in even giving psychiatric teaching hours in pre and paraclinical years, and increase this 2 weeks to 4 weeks like exclusively for psychiatry, we can improve the attitude of future doctors towards our specialty.
How? Like just increasing the duration, or any other extra efforts are needed to improve the attitude?
I think introducing the psychiatry as a subject in pre and paraclinical years itself, first and second year itself, can break down the stigma with which they are coming into the medical field. And after that, in third and fourth year, if we include more posting hours in 5th, 6th, and 7th, 8th semesters, the studies have already shown that when the doctors are interacting with patients, or they're getting to know how psychiatry works, their attitude is changing. So with this we can change.
Okay, thank you.
Thank you.
One question. Does your study have an answer for the questions raised by the chairperson? Does the objectives or the methodology, does it reflect anything? You are giving an answer to the chairperson question, but is any substantial evidence in that? Because we are discussing the research work, not a thing which you can just imagine and think and tell.
No, sir. What ma'am asked is, what are the suggestions that I have towards this, and what my study is, what is the current scenario that is happening. So with the current 2 weeks posting itself, there is a significant change. So by doing all this, we can improve the change, like increase the change in attitude.
Are there any studies that compared with less posting, 2 weeks posting compared to 6 weeks posting like that in literature?
So there is a study done in Northern Kerala, Claude Prasad KN, in which they have studied the attitudes done in psychiatric interns before posting and after posting, just like this. Because in increasing the curriculum is difficult, we have to take approval from MCI, so or NMC now. So it is not done in India. In outside they have done it. which includes in it. So there are questions like psychiatric patients are less human compared to other people, like that. So that to change in all this.
So for this question, you are supposed to say, my study is not relevant to this question. You don't have any evidence to say this, right?
Okay.
Because you are presenting a research, evidence is required. Without evidence, you should not give any answer. In your study, there is no evidence for that. There is no comparison of 2 weeks or 4 weeks, etc. Either in the objectives, not in the methodology. Right? You should not give assumptions in research works.
Okay, sir. We compared first, before and after posting. So with that, I gave. And thank you, sir, for the input.
Sai Srija.
Good morning everyone, myself Dr. Sai Srija. I am here to present the paper titled A Study of the Attitude of Medical Students Towards Psychiatry in a Private Medical College in Northern Telangana. Significance of the study spans in 5 dimensions. Impact on the future psychiatry practice. It can build the psychiatric workforce. Quality of patient care can be improved. Reduce the stigma surrounding the mental illness and mental health. Curriculum development in medical students and research and policy making. Aims and objectives to assess the social demographic variables in medical students, to assess the attitude of medical students towards psychiatry, to study the correlation between social demographic variables, exposure to psychiatry and attitude towards psychiatry failing. Methodology. An institution-based cross-sectional descriptive study with a survey research design was employed. Study convenient sampling method was used. My sample size is 400 and the study was conducted using a self-structured questionnaire distributed as a Google form through a social network in May 2024, and the study setting is done in Prathima Institute of Medical Sciences, Karimnagar, Telangana. Students aged between 18 to 60 years were included in the study. Students doing their MBBS, post-graduation or internship in the private medical college in Northern Telangana were included, and the students who were not consenting to participate in the study were excluded. Tools and scales used were informed consent form, composite semi-structured social demographic proforma, the mental illness clinician's attitude scale version 4. Coming to statistical analysis, values are expressed as frequency, percentages and means, and data were entered and analyzed using Microsoft Excel 2017 and SPSS 29.0. Descriptive and inferential statistical analysis were conducted. T-test was carried out to know the difference between the means of 2 groups. ANOVA test was used to analyze the difference between the groups, and a p-value of less than 0.05 is considered to be significant. Coming to the results, majority of my subjects were females and the mean MICA score is found to be significantly high in male. Age of the subjects, majority were 18 to 22 year group, and the mean MICA score is found to be highest in 18 to 22 year group. Majority of my subjects were undergraduates and the mean MICA score is significantly high in undergraduates. Majority of the undergraduates were third year MBBS students. Majority of the postgraduates were second year MBBS, second year postgraduates. Majority of my subjects were from upper middle socioeconomic status, and the mean MICA score was found to be significantly high in lower socioeconomic status. Majority of my subjects belong to urban background, and the mean MICA score is found to be highest in the rural background. Majority of my subjects come from a nuclear family, and the mean MICA score is found to be highest in joint families. Coming to marital status of the subjects, majority were single. Majority of my subjects follow in the Hindu religion, and and the mean Mika score is highest in Muslim religion. Exposure to psychiatry is present in 32% of subjects, and 68% did not have exposure to psychiatry. Students who doesn't have a psychiatrist in the family or friends or majority, and the mean Mika score is highest in those who do not have a psychiatrist in their family or friends. And the students who have known a person with mental health issues in family or friends were in minority, and the mean Mika score is found to be highest in those students who have a person with mental health issues. Coming to discussion, significantly more negative attitude is found in male gender, students in their undergraduation, lower socioeconomic status, rural background. Students who are related to psychiatry through family or friends show significantly more positive attitudes towards psychiatry than those without. Undergraduate students showed similarly more negative attitudes as those consulting doctors with less years of experience in one study, and no significant difference was found in attitude towards psychiatry based on marital status, knowing a person with mental illness, which is contrast to one study. In our study, exposure to psychiatry had no significant difference in attitudes, which is contrast to one study. Western research also shown psychiatry rotations positively influence medical students' attitude towards individuals with mental illness. Conclusion: catch them young. It is important to understand the role of various factors in shaping the attitudes of medical students towards psychiatry. According to our study, factors such as gender, socioeconomic status, domicile, level of graduation, and the relations with psychiatrists through family or friends influence significantly on the attitudes. It is evident in our study that 32% of the participants had no exposure to psychiatry at all. Raising awareness about psychiatry and mental health disorders among medical students is crucial to address their negative attitudes by implementing strategies like incorporating mental health education into their curriculum, guest lectures and seminars by experts, psychiatrists and psychologists, and mandatory clinical rotations in psychiatry, and interdisciplinary collaboration, that is especially psychiatry with other medical departments. Student-led initiatives like focused awareness campaigns, promoting self-care and mental well-being among medical students themselves. Recommendations: limited data exists on how medical education in India impacts attitude towards mentally ill individuals and psychiatry among students. Therefore, we recommend a prospective study on changes in the attitudes of medical students towards psychiatry and psychiatric illnesses following an intervention by educating students on the topic. These are my references. Thank you.
I request the audience to ask any questions.
Age criteria you have taken as 18 to 70, 60. There should be some basis for that. What is the basis?
Thank you for your question, sir. So, considering first year MBBS students, like minimum age would be 18 years, and have also included postgraduate students. So I thought maybe they may go up to 60 years when they have got a seat later.
Is there any restriction that entry level is beyond particular age is not allowed for education purposes?
No, sir. No such thing is there.
That is the reason you are putting it.
Yes.
So you are supposed to take from the past what is the usual age group of these people and then consider the age group. There should be some consideration for that. Up to 60, nobody will be in the post-graduation. Even senior residency is not allowed beyond 45 years.
Yes.
Right? So there are some restrictions, not absolute restrictions are not there, there are some restrictions. So consider only those things. And one of the findings is 32% are not no exposure.
Yes.
And this study is done only recently.
Yes, sir.
Yeah.
It's a cross-sectional study,
Right.
sir, in May 2020.
So how do you say that 32% are not exposed? Because it's compulsory posting is there during undergraduation, internship,
Yes,
and
sir.
even post-graduation. Some of the other specialties like general medicine, they are supposed to have psychiatry posting. So So how do you say that 32% are not exposed to psychiatry? What is the criteria?
This is the main issue in the medical students. Though they have been allotted or given postings, they are not attending it, sir. That is the main issue.
What is the novelty in your study? It's already proved time and again that more you expose, the more there will be attitude change. So what is the novelty? What do you want to prove from this study? Because the you have concentrated much on the social demographic profile. Yeah.
We have seen that lower socioeconomic status and rural backgrounds have a negative attitude, ma'am. So we can understand how their perceptions towards psychiatry are formed based on the student's background. So it reflects back to the society.
Second thing is, you said some percentage of doctors were not exposed and some percentage have exposed. So did you compare like exposed doctors with non-exposed doctors and the changes in attitude? Did you compare that?
Yes, ma'am. I have applied this mental illness clinicians attitude scale, and we have seen that there was a difference. In those who are exposed to psychiatry, they had
sure.
In those who are having exposure to psychiatry, the MICA score is less, ma'am. So that indicates they have positive attitude compared to those who have not been to psychiatric course or no exposure is there. They have high MICA score.
Did you exclude postgraduates in psychiatry?
We have included psychiatric postgraduates.
Then it's a bias, no? Usually postgraduates in psychiatry, they have a positive attitude, that's why they have chosen that subject. So there is a difference between postgraduates of other branches and postgraduates of psychiatry. You could have excluded PGs of psychiatry or else a comparison you could have done.
We have tried to interpret in between the departmental thing, like who had a more negative attitude and who has, but we couldn't get to an analysis as told by a statistician, ma'am. But we have found positive attitudes in psychiatry residents, obviously, and more negative attitudes in radiology residents, ma'am. But as told by statisticians, we could not include that. It is not proper.
Why did you choose Google Forms instead of direct interview?
The issue is they are not coming to postings, ma'am. So I have to reach to their class representatives and ask them to distribute in your WhatsApp group. And so I have to.
Okay, thank you, doctor.
Thank you, ma'am.
Yeah. Next, we'll call Dr. Preeti onto the stage.
Good morning, everyone. My title is to study family and intimate partner violence in female patients with major mental illnesses. I'm Dr. TSPSYCON-2024. I'm second year postgraduate from Institute of Mental Health, Hyderabad. Coming to the introduction, intimate partner violence refers to behavior by an intimate partner or ex-partner that causes physical, sexual, or psychological harm, including physical aggression, sexual coercion, psychological abuse, and controlling behaviors. Major mental illness or severe mental illness is a mental, behavioral, or emotional disorder resulting in serious functional impairment which substantially interferes with or limits one or more major life activities. Worldwide, 1/3 of women aged between 15 to 49 years who have been in relationship report that they have been subjected to some form of physical and or sexual violence by their intimate partner. The aim is to study family violence and intimate partner violence in female patients with major mental illnesses. The objectives are to compare family control, psychological violence, physical violence, and sexual violence. The inclusion criteria are female patients aged 18 years and above, with present and past intimate partners, with schizophrenia, bipolar affective
disorder, major depressive disorders, diagnosed according to ICD-10 criteria, and were willing to give written informed consent to participate in the study. The exclusion criteria are female patients with intellectual disability, with organic psychiatric disorders, with substance use disorders, with serious medical illnesses who are not cooperative. The methodology is, after obtaining institution ethical committee approval, study was initiated on 100 female patients under remission, selected according to study criteria at Institute of Mental Health, OMC Hyderabad. Selected subjects have been administered CGIS, IFPCS, which is Indian Family Violence and Control Scale, modified Kuppaswamy scale. All statistical data was meticulously analyzed using SPSS version 27.0. The results showed women between ages of 30 to 40 experienced maximum violence, and the mean age of violence was 34.7 years. These tables show the socio-demographic parameters of the participants, which included age, education, occupation, marital status, family history of mental illness, age of onset of illness, and duration of illness. The highlights are the mean age of study population is 35.7 years. 58% of the study population were unskilled workers. 50% of the study population were living in nuclear families. 51% of the study population belonged to low socioeconomic status, and 69% of participants were diagnosed with schizophrenia. The mean age of onset of illness was 28.4 years. The mean duration of illness was 7.45 years. 69% of patients had schizophrenia, and 27% of patients had mood disorders. This is the table which shows violence in the various domains, which is control, psychological, physical, and sexual violence. And the table shows that 46% of the participants experienced control violence, 43% experienced psychological violence, 57% experienced physical violence, and 25% experienced sexual violence. This table shows that the cumulative percentage of family and intimate partner violence experienced was 43% in the study population. This table shows the mean of all the subcategories of violence. The highest being control violence, which with the mean of 38.15, and the lowest in sexual violence with the mean of 12.03. This table shows the age, compares the age with severity of illness. It says that among participants between 31 to 40 years of age, 19% and 25% had mild and moderate illness respectively. This table shows occupation against the severity of illness. It states that 15% and 23% of unemployed participants had mild and moderate mental illness respectively. Coming to the discussion part, lifetime prevalence of intimate partner violence is 22% according to a study done by Shruti Nair et al. In 2020. It states that the psychological violence was more common. Emotional violence was the most commonly reported form in a study done at Ethiopia. Overall, 43% participants experienced violence, out of which 46% in the area of control, 43% in the area of psychological violence, and 43 and 25% in areas of physical and sexual violence, with mean of control violence being 31.15 and 12.03 being mean for sexual violence in this particular study. People with mental disorders are at increased risk of violence. Out of 100 females in the study, 69% are diagnosed with schizophrenia, indirectly mentioning the need to look for violence in the group due to increased vulnerability according to previous studies. Lifetime prevalence of physical or sexual assault in women with schizophrenia is 20.7%, which is about 9 times the risk of those without serious mental illnesses. Physical violence has been third most commonly reported violence, with mean of 21.38, followed by mean for sexual violence being 12.03. In the study, the lower rate may be due to the cultural beliefs, which usually places undue stigmatization towards women and limits the reporting of such cases. Sexual assault is a severe form of intimate partner violence, and women with schizophrenia are at increased risk. It is noteworthy that those who reported a history of sexual and physical abuse also reported verbal abuse. This seems to suggest that women who report sexual assault and physical abuse may suffer from all of the forms of intimate partner violence and precipitate serious fatal consequences. Hence, with the current prevalence of intimate partner violence in women with major mental illnesses, it is reasonable to inquire, assess intimate partner violence during routine clinical contacts and assess such patients to voice out their suffering and assist them to meet their unmet needs. Coming to limitations, owing to the small sample size and study being conducted in tertiary care center, results cannot be generalized. It was difficult to administer Indian family violence and control scale to unmarried women and women with a live-in partner and those who were not legally married. Possible cognitive deficits due to major mental illness in the study population would have led to underreporting of violence in any form, along with increasing age of the study population. The future directions would be addressing IPV in view of mental health of women with major mental illnesses needs a multifaceted approach which includes access and availability, integrated care models, preventive and early intervention strategies, trauma-informed care, social support systems. Owing to high prevalence rate of intimate partner violence, there is a rising need to inquire into intimate partner violence in all mentally ill women during routine clinical examination. Further research including larger population is needed to guide direction of action and establish protocols. Conclusion: assessing intimate partner violence in women with major mental illness is crucial due to its association with mental health problems, somatic problems, and also suicidal behavior. IPV should be included in the comprehensive care of women with major mental illnesses, assessed at regular interval, including both inpatient and long-term outpatient care. Future research should explore this further. Thank you.
Thank you, Preeti. We completed it on time. Now I request audience to question or any questions.
So you are saying that there is high risk of intimate partner violence in mentally ill, but you didn't have any control group. How can you conclude that it is high?
Ma'am, we looked at the previous researches, ma'am. Said it was more when compared to the regular public, regular females who didn't have any mental illnesses.
General population.
Yes, ma'am.
But you didn't include anyone in the study, no? You don't have a control group.
No, ma'am.
So that is one limitation.
Yes, ma'am.
So you have specific scales like directing towards intimate partner.
Yes.
So why did you choose Indian family violence scale instead of intimate partner violence scale?
Ma'am, this has been published in 2016, ma'am. Previously, whatever scales were there, it was not like generalized to the Indian population. So this was a recent scale, and there was also a recent study which was done in NIMHANS, which took up this scale. So we thought we can also, because it has been generalized to the Indian population, we thought we could use it in our study, ma'am.
So that is for whole family violence, no? Not for intimate partner violence.
Yes, ma'am.
Can you project the scale and show?
Ma'am, I don't have it here, ma'am, on the PPT, but it has, it is a 63-item scale, ma'am. It has 4 subscales, which measures violence in control area, psychological area, physical and sexual violence, ma'am. And it is like measures both family violence. It is like measure violence in all the 4 subcategories which the woman faces by her intimate partner and also the marital family, ma'am.
Okay, did you compare the group, schizophrenia group with the depression group and found out any differences between them?
69%, but with the limited study population we had, which was 100%, which was 100, we had around 69% of patients who were diagnosed with schizophrenia and 27% who were diagnosed with
Any difference between the violence between the 2 groups?
Yes, ma'am. Yes,
comparing those 2
Yes, ma'am, it was there. But the statistician was not ready with the thing, so I couldn't check that.
Okay, thank you.
Thank you.
If there are no more questions, we will call Nabanita Mandal.
Is there any role of coping mechanism in balancing the scalpel of stress? This is the topic of my presentation today. I would like to start with a quote from Sigmund Freud that unexpressed emotions will never die, and if they are buried alive, they will come forth in uglier ways in later life. So this implies the huge impact stress has on our lives. Recent statistics in India showed a startling spurt in the number of suicide among medical students. As per the data given by by National Medical Commission, more than 37,000 medical students have expressed to be suffering from mental health ailments, and a minimum of 122 medical students committed suicide in the past 5 years. Still, these shocking figures might just be the tip of the iceberg we are seeing. The relationship between academic stress and suicidal ideation has been well documented in the past literature, and medical students generally pointed to 3 key areas of stress factors, that is academic pressures, social issues and financial problems. But since there is no medication available to prevent suicide even in identified victims of suicidal ideation, coping strategies for stress is very German. The list of untimely deaths in medical community has alarmed even the highest body of health and education of India, but despite all the measures taken up, the newspapers of Telangana as well as whole of India continues to brim up with the news of suicide every day and now, which definitely indicates a lacuna in the ground data and the policies being implemented. The rationale of a study can be well depicted by these pictures, which shows the top headlines of recent newspapers, which showed a numerous number of suicides happening in medical students, which included both undergraduates and postgraduates. Our study aims to provide a ground data of this region of prevalence of stress, sources of stressors in the medical students. The aims and objectives of our study was to study the relationship between perceived stress, source of stress, suicidal ideation and moderating role of coping mechanism among medical students. What we see in the newspaper is the tip of the iceberg, and what we need to evaluate is the submerged part below. Ours was a cross-sectional study done among 535 medical students over a period of 1 year in Government Medical College, Nizamabad. So this is the flowchart of our study, where written informed consent was taken from the participants. The scales applied were perceived stress scale, source of stress questionnaire, scale of suicide ideation and brief cope scale. The data from the samples were analyzed using SPSS 28 version, chi-square test and Pearson correlation was used to check the association between the variables. So these were the scales used. The results showed that out of 533 medical students, 303 were male and 233 were females. The majority belonged to the Hindu religion. About 8.6% were studying in the post-graduation and rest were undergraduates. 88.2% were hostelites and rest were day scholars. The perceived stress scale showed that about 42% were stressed with a mean perceived stress score of 29.28. Association of perceived stress with socio-demographic variables showed a positive significant correlation with where it showed that females had higher stress than males, postgraduates more than undergraduates and hostelites more than day scholars. The source of stress were assessed in 3 categories, that is academic stressor, psychosocial stressors and health-related stressor, where it was seen that as per the frequency of occurrence, the frequency of examination, performance in examination, academic curriculum, high parental expectations, sleeping difficulties and quality of food in the mess had higher in the frequency. And in terms of severity, performance in examination and high parental examination has the highest severity. Inability to socialize with peers and lack of personal interest in medicine. Which was similar to a study done by C.T. Ramareddy in a Pakistan medical school, where the overall mean was 30.84. Correlation of perceived stress with gender and level of education and accommodation showed a positive correlation, which was analogous to the study done by C.T. Ramareddy, where gender was seen to be positively correlated. Most of the study, including our current study, showed that the major stressors were from the academic related stressors, which might be due to the humongous and difficult medical curriculum irrespective of latitude and longitude and the structure of medical examination system. In our study, the mean suicide ideation score was seen to be 12.13 and the suicide ideation was present in about 9.9% students, which was analogous to the study done by Sana Safi, where also positive correlation between suicidal ideation and stress was found with a correlation factor of 0.42. The most common coping strategies used were active coping, acceptance, positive reframing, and planning. It was encouraging to find that in our study, substance abuse was the least commonly used strategy, which might be due to the strict rules and regulations in the hostel, or though underreporting could not be rolled out. In conclusion, I would like to say that we have found that a substantial number of medical students was found to experience a high amount of perceived stress, and the stressors were mostly related to academics and psychosocial concerns. So this indicates a need for stress management programs in all the medical colleges. Maladaptive coping strategies were seen to be more prevalent among the stressed populations, which indicates that we need to conduct workshops on stress management and use of effective coping strategies to help the students to cope up with stressors not only in their academic and professional arena but also to help them in their personal lives. The limitations of the study was we used self-report instruments, and the study was done only in a single college, and it was a cross-sectional study, so no follow-up could be done. My future directives will be to establish a well-balanced academic environment and a curriculum. Implementation of EdCom module, which is a new strategy taken up by Medical Council of India, might be helpful, and programs for stress management should be conducted in all the medical colleges. These were my references. I acknowledge all my professors for their contribution in the presentation. I'd like to end with the Gen Z meme that what doesn't kill you doesn't make you stronger anymore. It gives you a lot of unhealthy coping mechanisms. Thank you.
I request the audience to pose questions.
Why you have chosen study? There is a lot of evidence already available.
Sir, actually most of the studies did correlation with perceived stress and suicidal ideation. But whether coping strategies had a major role to play, that was not evident. And also we have seen recently many suicides in this region of the in our colleges also. So to provide a ground data from this region or this college.
Lot of coping studies are also available. Many studies are available already with coping also. Not a number of studies are there. Maybe intervention studies would be better. What is specific to your college? Anything you have found?
Sir, the coping strategies used were only maladaptive coping strategies were more in the stressed population, sir. But still, like the mean score was higher, but the adaptive strategies were more, strategies used were more, sir, in both the students.
Compared to other population in your study, in your college, any specific, major specific things?
Not much difference was found, sir. It was mostly analogous to other studies.
Any questions? What do you mean by active coping?
considered as passive?
This suicidal ideation you have taken since past how many days you have collected it?
1 month.
From the past 1 month. There are no further queries. I think we can end the presentation. Yeah, that's we are going to then with that we'll finish Dr. Sitaramaya Krishnalila PG award session. Thank you.
Our next session is on understanding internet, mobile and phone addiction. We are privileged to have our chairpersons, Dr. R. Satish Babu sir and Dr. J. Jagannath sir with us today. Let's welcome to the stage to share their valuable insights. Dr. G. Jagannath sir, he has completed his MBBS and DPM from Osmania Medical College. He has been practicing psychiatry since 33 years. He earlier worked in Sangarani Collieries, Kottagudam for 7 years. He is the founder, director in Asha Hapural, Hyderabad. He is working as a consultant at Asha Hospital and psychiatrist in charge of Asha Jyoti Rehabilitation Center. He is the past president of IPST. He is also the past general secretary of Earthswide IPS AP State Brand. Dr. Satish Babu sir is the professor of psychiatry from Amata Medical College, Khammam. He is the past president, Combined AP Psychiatric Society. Past national representative to India for International Association for Suicide Prevention. He is the president of Telangana Private Psychiatric Hospital and Nursing Home Association. Welcome, you. We are handing over the procedure to our chairpersons.
Now, I request Dr. TSPSYCON-2024 sir to come on to the dais. Internet, mobile and phone addictions. As we all know, anything that is involving computers and internet is cyberspace. It's a double-edged sword. With that, we can get a lot of information and communication very easily. And at the same time, we can have the behavioral addictions also. The ease and convenience and anonymity of cyberspace are having an unimaginable impact on human behavior. Cyberspace is contributing to sociological and psychological changes across every age group. With the rapid advancement and use of information and communication technology in all spheres of life, internet pathologies have become a concern for researchers, clinicians, and public. Young et al. Has divided these addictions to cyber sexual addiction, cyber relationship addiction, net compulsions, information overload, and computer addictions. And some has divided into generalized internet addiction and specific internet addiction. But further, there has been a lot of consensus at the level of conceptualization whether internet-based addiction should be placed in the category of impulse control behavior or obsessive compulsive disorder or behavioral addiction. So this is a very important problem, present burning topic in every place, even from the villages. According to some studies, internet addiction is around 6%. This was done in 35 nations in 7 regions, 7 world regions. But I think the more internet users are in India when compared to other countries. So this is a very important topic. Now I hand over to Dr. Jagannath sir to introduce him.
Thank you, Dr. Satish. It's my privilege to introduce Dr. TSPSYCON-2024, popularly known as Dr. TSPSYCON-2024. He's the Professor Emeritus in Psychiatry and Chief Coordinator in Psychosexual Medicine, Department of Psychiatry, JSS Medical College in Mysore. He's the immediate past General Secretary of Indian Psychiatric Society. He was the past editor of the Journal of Psychosexual Health. He was the president-elect of South Asian Societies for Sexual Medicine to International Society for Sexual Medicine. Formerly President, Indian Association for Geriatric Mental Health. Formerly the editor of Indian Journal of Psychiatry. And he was the co-chair of Psychiatry and Homosexuality section of WPA. And he has a vast publications, almost to the extent of 354. He had authored almost 28 chapters in various books. The most important contributions is he was awarded 26 times the various orations, and he has won the awards, including the famous Marfatia D.L. and Rao Oration Awards, the ANSIPs. He was president of Karnataka Sexual Sciences Academy. Dr. T.S. Rao doesn't require any introduction as such, but for the youngsters who do not know him, I just wanted to give a brief introduction about him. And it is our privilege to chair this particular session. And whenever the sessions are started, Dr. T.S. Rao is successful. Thank you. Now I request Dr. T.S. Rao to start.
Good morning. I want some response. At the outset, let me thank Telangana State Branch, which I almost feel quite homely, for the simple reason that almost almost everyone in this particular branch is known to be so closely and associated. We have also seen a lot of programs being conducted by Telangana, maybe possibly one of the best branches. Earlier we used to talk about Karnataka. Now Telangana is one of the major contenders and working out to be one of the best branch for so many programs in almost all spheres being actually held. Usually my presentation will be the last presentation that I have seen in many programs. They have chosen for the first session itself only indicates the high libido these people have. They start the day with sex and end the day with sex. So it's quite interesting. I was thinking that my presentation is on sexual addiction disorder. Only yesterday evening while looking into the program, I realized it is actually the internet, mobile and basically called porn addiction. In the morning I try to sit and try to modify it so that maybe little plus minus as possible how I actually will move. But all said and done, the concepts which are related to sexual addiction disorder are equally applicable to some of these things. We are all used to study schizophrenia, depression, alcoholism and things like that. But you younger generation people are likely to come across the newer type of disorders, how actually to understand these things, how actually to help, more particularly the parents who come with such an amount of anxiety related to the children, something actually you have to get familiar with. So what I believe is this will be one of the sensitizing sessions that these are all the newer type of disorders likely to come up in a very big way in the coming future. Names like internet, mobile, phone, almost all of them have a very close relationship with each other. Some of the concepts, if I try to explain for the internet, is equally applicable for the mobile and even for the phone related problems. So my presentation would actually try to look into some important concepts which may be actually necessary to be looked into. Historically, if we try to look at, even at the time of Darwin, we are told that we really don't know much about sexuality. And even today, the very recent literature, if you try to look at, they also specifically say that we don't know much. When you are using the word addiction, at one particular point, people had suggested that it is a derogatory terminology. We should be knocking it off. But now it has come back again, addiction, psychiatry, and a lot many other things in a way, with the realization that there are these concepts can be understood from a scientific point of view also. A time was there when we used to talk about only about alcohol, other drugs as addictions. And then a lot of other concepts are actually can be addictive came into being, and one or two areas where a lot of confusion was there was the food and sex. When actually one can put certain limits and what actually one can do. So one of the important aspect is actually the terminology, behavioral excesses. What it actually means is, it is there, but some people use it frequently, in fact involved with this to an extent that it can create problem in many aspects of their life. So when we are using the word, we are all well aware, salience, tolerance, withdrawal symptoms, conflict, relapse, these are all part and parcel of any diagnosis for any addiction what we have to make. But when we are trying to talk about what we call as behavior addictions, in fact, this was one of the book published by, and when I was the editor for Indian of Psychiatry, related to a whole range of behavioral problems which could be addictions. And few of those things are like, say, food consumption, shopping and spending, exercise. This slide is not fitting properly. Work. There are some people, in fact, they work from morning till evening with such an amount of involvement. Tanning, gambling, romantic pursuits, sexual pursuits. So, any number of these type of things are actually have been documented, which actually creates quite a bit of difficulty. The terminology came into being what is called as problematic sexuality, and 2 points which actually makes that this particular problem is problematic is when there is loss of control. The other one is actually it is accompanied by adverse consequences and personal distress. Half of this one slide and half of the other slide is actually running. It doesn't really matter. Sex can be done whatever way. This is one of the advantages. So we can understand what actually we are trying to tell. So it is the Patrick Kahns who specifically mentioned that sexual addiction is an extremely important concept and it is there. A lot of work has happened, a lot of concepts have come into being. Sexual addiction, whether it is a disorder, none of the classification systems have at present this particular terminology. One concept that came into being, which was presented as one of the things which should be included in DSM-5 was hypersexuality terminology. But this was not taken up mainly because there were a whole range of issues were there actually when and how actually this particular limitation can be made. When to say that something is actually hypersexual. This is present, but not having a diagnostic label. This is where actually we stand. When you are trying to talk about sexual addiction and a few of these things like internet, mobile, and what we basically call porn, there are about 3 levels what people, scientists talk about. One is that is a relatively victimless sexual behavior such as excessive masturbation, consensual sexual activity, and use of pornography. At a very minor level, this is present in many of the societies and in many of the age groups also. The second level actually they qualify for another category what is called as exhibitionism, voyeurism, and many other such paraphilias. And the third one is actually where incest, rape, and so many other such, in fact, legally not permissible activity people get into. That means there are 3 levels at which actually, in fact, one person may start at some point, may progress actually to the next level. Patterns and themes, what actually seen in almost any of these 3 things, what we are going to talk today. In fact, fantasy sex, seductive, anonymous, paying, trading, voyeuristic, exhibitionistic, intrusive. In fact, such many terminologies which are there in actually use that it almost becomes difficult what actually to exclude. And as a beginning, when we are using the word like say internet addiction disorder, this also involves what called excessive use of a computer for various reasons. Whether you are talking about gaming and shopping and things like that, pornography is also part of it. So any one concept, if you try to look into means it has tentacles almost all the other things. So this is the first concept what you should remember. When you are using this internet addiction terminology, everybody knows about internet. Everybody uses internet, and everybody is concerned about almost what is actually happening every minute, time to time. But we are all used to either WhatsApp or internet and a whole lot of these things. We are almost always involved in a very big way. In fact, news spreads very fast. More than actually the print media, the internet is one of the major common source. And when we are trying to talk about internet addiction, there are many things one can elaborate in a great detail. To simplify, one is actually the cyber sexual addiction. This is one aspect. Cyber relationship addiction. What are the issues involved with that? And the third one is actually repeatedly, constantly involved with the net, from morning till night or you all through the night. So these are the 3 common things which actually where the research work actually has happened. Why this is actually, if you try to look at, when we have to deal with another person, there are a lot of inhibition and stress automatically out of comparison. But internet provides the speed, accessibility and infinity variety of information. In fact, it is there on the fingertips. During COVID time, you have a lot of terminologies like information overload. That is one of the things. You want to get away from stress means turn the radio, this thing, TV to the wall side and sit and watch. These are all a few of the common things what people use today. Don't go for different websites and all, what actually medical people are telling and what actually the government is telling. Please listen to them. So you must have heard of, in fact, how actually this was creating difficulty. We are also have seen what we call fantasy and fact, which is associated. It is very commonly seen that in Indian context also this has become extremely common. Between ages 18 and 30, they feel anxious like part of me is missing without their smartphones. 96% of Indian youngsters check social media the first thing every morning. 70% claim they can't live without emails and social media being looked into. 97% of the response from India said they have a Facebook account, 70% saying that they log into the network almost daily. What it says is that this particular problem is extremely common, and we have traveled many countries. No country the data is as cheaper and as easily available as in our country. There are many countries which is actually not, for example, I was in Dubai where WhatsApp is not allowed at all. There are many countries where you have to pay by the amount of money. But in our country, it is so cheap, and if you try to look at second largest mobile phone base, possibly now we have already come to the highest number. This is actually one of the very recent report that we have beaten even China and we have come to the #1 position. Third largest internet user base. Again, this is actually this particular concept also has changed. It is growing very, very fast, and possibly few of the things what have been actually announced in another few months and maybe by the year end, we will be having total change. Already 5G and the other things have come, and it is actually going to improve in a very big way. There are plenty of Indian studies. One study actually we out, and almost everything has documented that this problem is extremely common. Anywhere between 20 to 40% of the people, particularly educated, young, they are involved with this particular problem. Once actually they get into, in fact I still have one or two people, a lady who came and told, in fact I used to say that why you are actually involved with this particular watching mobile or internet all the time. She was introduced and taught how actually to do it. Now she just cannot get out of it actually. In fact, husband says, in fact, I just documented, showed her actually how actually to do, and she has got stuck with so much. This is actually the problem. What actually happens is, once actually stuck means, it is almost very difficult to get out of it. And this term internet addiction disorder was coined by the New York scientist Johann Goldberg, and we are all well aware there are different terminologies which are actually, in fact, internet addiction disorder, pathological internet use, compulsive internet use, few of these type of things. Almost in all these conditions, one important point is I seem to have lost control. I just cannot, in fact, without this, I feel very restless. Almost like fish out of the water or whatever analogy is actually what we can. Many people, we have come across patients and relatives coming and telling that even when we want to sleep, in fact, this fellow won't sleep, covers himself and he watches, and what are the types of difficulties and other related things, what actually happening with this particular thing. And what actually it does is, we are supposed to sleep for at least about, say, 8 hours per day. Even when we are aware that 6 o'clock I am having a presentation, then we will be, in fact, busy with my internet and other related things till 2 a.m. in the night. And these are the times what actually it produces fatigue, prolonged use, aches, pains, and many of those type of things. Somebody is married and dating, parent-child relationships, each one of them actually gets into difficulty. And false temporary feeling of security, of calm and self-worth and accomplishment, power and control over certain things, but all said and done, they all appear to be the sham actually activities. It gives an opportunity to express your fantasies, neglected desires, and chance to be totally someone. What we see in the internet, or in fact ourselves, there is actually something extraordinary, great man, Superman and all that, but we are actually not so. And going out of the way, doing. In fact, very recently just admitted and discharged a young girl of around 22 years. She was admitted to engineering college. She discontinued because she was very anxious, nervous and all that. But then, last about 3 months, she's frequently chatting and getting involved with a lot of things, in about 3 to 4 sexual encounters. Parents were very anxious, and when we actually realized this was nothing but hypomania which has to be treated. Depression, mania, in fact, how they used to present earlier. Now their presentation pattern is actually something totally different. So, we have to be aware what actually precisely happening. What are the harmful effects? One, actually, this cyber widow concept. What it means is, if you have a TV in the bedroom, or take mobile to the bedroom, or laptop to the bedroom, in fact, the partner gets lost. Actually, that what is actually happening. Husband is there, but he is not there. Wife is there, but he is not there. In fact, we have in psychiatry, there are some ladies groups there. But I have seen many of them chatting somewhere around 1:30 to 2:30, 3 o'clock. And I was talking to one person and she was telling about all my activities related to contacting people and friends and all starts at 1 o'clock or 2 o'clock when everybody has slept. No, you got the point. Earlier, wives used to complain that husband is not coming to the bedroom. He is sitting and watching TV. No, husbands are telling that wife is not coming. She is busy with something else actually. No, you got the point. Ultimately, in fact, they are there but they are not there. This cyber widow concept, cyber affairs. Somehow what actually I am missing, in fact, I can get it there, I can fantasize, I can live that particular fantasy, is one of the most important point which actually makes people addicted. I skipped that particular years. What actually has been documented is constant and continuous use of what we basically call, welcome to our president. I am very happy that I am on the stage to welcome you. So brain gets affected functionality wise in a significant way. This is what actually people have documented. Internet changes our brain permanently. What actually can happen at different levels, in fact the whole documented literature is there. Inability to form relationship, inability to have what we call quality relationship, inability to express emotions, and many of the other related what we're also going to talk a little later about bond. So all of these things are actually literally lost. Comorbidities, one has to almost always keep it in mind. Starting from alcohol abuse, ADHD, anxiety, depressions to a lot of other personality disorders would be part and parcel of it. One should be keeping an eye on each of these things. How actually one can go about, there are different states are available. And what is this Young's internet addiction scale? This has totally about 8 items. Any 5 are positive. In fact, this particular individual needs attention, proper evaluation and treatment. This is actually one of the items. From psychiatrist's point of view, we are comfortable. In fact, when this impulse difficult to control, treatment with SSRIs and few with other antidepressants and all of that. But what actually one has to do is actually how this particular problem can be prevented. So there are a whole lot of concepts that I come what we call as the digital hygiene. Create a corner for your gadgets when you go to sleep. Keep the television remote and mobile phone out of the bedroom. Keep away from laptops and mobile phone at least an hour before you go to sleep. In fact, related to this particular concept, you should not look into related to the type of stimulation that can happen to our retina, and actually it triggers a whole range of concepts where melatonin secretion and other things get disturbed in a very big way. This is another concept which actually has been reported related to the girls. The girls are reaching menarche much earlier than actually, in fact, what was there for much longer time in the society is attributed to the fact that there is a high degree of sexualization and a lot many other related things that happen. So the whole process gets affected. Time management. In fact, this is actually how actually you go about urgent, important, not urgent but important, and urgent but not important, not urgent. How actually it can plan. I am not going to too many details. other places with online counseling and other related things. In fact, the people are trying to help. Same method, which is actually the process which is creating problem, the same process has been utilized for treatment also. Gaming is another area where this is actually the gambling and gaming, in fact, have been included as diagnostic categories. But all said and done, advantages, disadvantages. In fact, I was treating one of the cases where parents were absolutely very unhappy with this particular fellow spending so much of time with games. There were a whole lot of competitions and all like that, and recently he's supposed to have won certain prizes and awards actually related to this game. You got the point. Earlier, in fact, parents never used to allow the children to go and play. There used to be difficulty. In fact, you have to sit and read and prepare for this exam, that exam, a whole lot of things. In fact, people are doing extremely well as a cricketer, footballer, and a whole lot of other things. So where actually put the line and how constructively and precisely this particular thing that can be brought about is one of the areas. So take home point is, internet addiction is real and is already around us. People get addicted to it without even realizing it. Brain maturity continues till third decade, and whatever you do is going to have an impact on the brain. Be careful what you think and do. Internet gaming are potentially useful and readily available mental health tools in certain situations, but people can be addicted. Pornography and sexuality is another area where a whole lot of work has happened, and possibly, if you try to look at the work which has happened here is actually applicable to the other things what I had mentioned earlier. The literature here has been replicated in that particular area. In fact, much of the work has happened this way. Some things are better than sex, and some things are worse, but there is nothing exactly like it. Whether somebody is taking alcohol, whether somebody is taking opioids, whether somebody is using porn, all the centers which actually stimulate, which actually bring about pleasure, which actually the person seeks, they are almost same. In fact, to go one step ahead, the sex center, what we talk about is nothing but, in fact, the same complex which actually deals with our addiction and such other related problems. So when you are using the pornography and erotica, these are the two terms people repeatedly ask about. Erotica will come later. Porn refers to the whole graphic to write, means writing about prostitutes. Sexually explicit representation, which has the function and intention of sexually arousing audience, is actually one of the common themes. So the primary purpose of pornography is actually for titillation purposes and for arousal. And when we are trying to talk about erotica, this is where two people are in inverted comma relationship, and where both the people are equally important. In pornography, one person actually, in fact, is enjoying, the other person actually not enjoying. Even natural situation also, you might have noticed that ladies actually close their eyes. Have you seen that any romantic situation? One of the comments is actually they don't want to see man enjoying, so they close off their eyes. But whole physiology itself is such a way that, in fact, unless they close their eyes, they concentrate. The erotic, in fact, what we basically call, genus structures and all, actually they cannot reach the peak. In our country, it has been given actually one of the very divine status, and almost majority of the temples and not many other areas being importance given, which actually is one of the very well accepted was fact. And the Kama Sutra, in fact, we have contributed to the world, and that is actually, I hope, beside the important it is. Pornography, when you are trying to talk about any kind of material aiming at creating, enhancing sexual feelings, thoughts in the recipient, at the same time containing explicit exposure and or descriptions of genitals and clear explicit sexual acts. 1X, XX, XXX and all, in fact, people talk about it in various contexts. Each one has what we basically call certain specific meaning. The exposure of the genitals directly, in fact, is what put up to that what called XXX. Porn consumption, is it recent development? Absolutely not. Even in our country, this Bobby and this particular concept is actually prevalent for a long time. Web is actually one of the most common area people started visiting many years ago. Out of top 1 million websites, almost nearly half were related to the sex related. From 2009 to 2013, all web searches were for erotic content. The world's most popular porn site is Live Jasmine, has 32 million visitors per month. Various studies measuring internet traffic claims pornographic traffic to be almost anywhere between 4 to 30%. So it's extremely common. The sad truth is about that a lot of people get involved, and this creates quite a bit of difficulty. And when it came to India, in fact, a lot of mistakes have happened actually. In fact, this is one of the just news item that Patna junction goes to you after the free Wi-Fi. Everywhere you want to introduce and all that. That means advantages, there are certain disadvantages, both are there. One of the concept actually people talk about is actually good or bad, and it all depends upon the individual's knowledge, capacity to control, and what actually he can learn out of this particular thing. Why actually it is considered bad is that pornography leads to consumers to objectifying, unrealistic sexual expectations, relationship problems, loss of interest in sex, porn addiction, whether it is actually almost paraphilia, loss of interest in sex. I'll come 1 or 2 minutes later when I'm actually dealing a little more elaborately on that. Does pornography treat women as object? This is actually one of the feminists repeatedly emphasize that this is actually the main problem related to pornography. And pornography, whether it leads to aggression. If you try to look at few of the review articles, this is actually has helped, this is actually has created problems. Both the ways actually people have documented the findings. Sexual aggression as one of the contributory factors for certain specific situations, but these are all anecdotal findings. Contributory factors, in fact, one of the most common problem actually people have reported is actually the relationship gets into difficulty because what is actually capable of introducing fantasy and actually people trying to act real with that particular thing can lead to quite a bit of difficulty. This is so sexist attitude, desensitization, and leading to crime. They are actually the facts in certain situations which actually has been documented. Sexual crime in India, is it influenced by pornography? There are at least about 2-3 review articles are there which speak about there is no connection to another article which says there is a strong connection. So the findings which are actually, what is the way actually the material has been analyzed, this is actually one of the reasons why actually we get 2 different types of opinions. Negative connotations because it tends to deprave and corrupt those who produce and consume it. It degrades women by portraying them as sexual slaves or subservient or inferior to men. Harmful to children if they consume it or use. Violates women's, in fact, individuals' civil rights and freedom of expression. Unrealistic expectations are added to this. People believe that it actually increases self-confidence, exotic scenes, pornographic filter, and communication because he is in his own virtual world. He may feel actually something extraordinary. Porn addiction, whether they are actually paraphilias. There is for and against, again, this particular concept. When we are using the word of hypersexuality, this excessive use of commonly understandable behavior patterns. So, it should not fall under what we call as the paraphilias. Pornography and obscenity, in fact, there is a whole lot of debate related to this, whether it is so. It all depends upon how conservative and how liberal one actually that. But in Indian context, according to the law in India, anything that is lascivious and appears to prudent interest or if its effect on individuals to deprave and corrupt, in fact, they are considered as obscene. And one can be, in fact, hold up in a whole lot of this. Porn stars, they are so popular. In fact, the amount of money they get as for acting in a whole lot of this thing is actually something extraordinary. To make a film popular, in fact, they are all actually included. In fact, the Sunny Leon, in fact, is as good as anybody has heard of any other Virat Kohli and all that. Maybe as good as. She says, in fact, this is accepted, not accepted, individual concept related to that. But the type of problem what actually is producing in our children is actually something extraordinary. Now, there are a lot of movies in general to OTT and other related things. So much of explicitness has come that it has become almost very difficult. The children are actually put into a whole lot of difficulty. I still remember one of this girl about somewhere around 8 years or 7-8 years. She was brought in with severe anxiety and a whole lot of symptomatology. When we went into the details, in fact, she had received in the mobile one of the sexually explicit scene following which actually, in fact, she had become very upset, which she has to be treated for a pretty length of time to get her out of it. What we are trying to tell is that boundary is only for adults and all what we may talk about, but it can be misused in so many ways. 18 plus, this may be one of the very common. In fact, that's the age itself. In fact, many people have documented that we start. And many of our regular films also, in fact, they are no way less than what we basically call, talk about pornography. Adolescence is the age at which children stop asking questions because they know all the answers. But what actually answers they know, whether it is actually true and whether it is actually applicable equally are not very difficult to answer. And there was one of the other internet sex education and other related things, the positive aspects, how this can be utilized and all like that too. In fact, the type of difficulties. Coming to the sex life, there is a whole lot of things one can talk about. Whether there is something like positive, yes it is. In fact, somebody is well aware of for and talk about. But many of the times, it can lead to quite a bit of difficulty. The issue is, when we get married, we get bored because the same partner, in fact, it's a difficult story, in fact, men are almost seek variety and this Coolidge effect, you might have heard of. There was 30th president of USA while going into one of the bonds, they come across an individual who explains that this particular rooster can screw almost 100 chicks per day. When the lady president's party is there in the front, she says, tell this to president. When the president's party comes there, he says, Madam wanted me to tell me this. President has only one question. Whether this fellow screws the same chick or different chicks. No, you got the point. So the whole story here is, people seek variety. Each sex, each climax, each orgasm, each fantasy is different. And without that, actually sometimes people can run a bit difficult. One case very recently I had was, this particular person, I always imagine Aishwarya Rai having sex. Sometime back he told his wife that unless I imagine Aishwarya Rai, I don't get aroused. In fact, from that time onwards she has stopped having sex with him because her complaint is that you have treated me all along as a prostitute, not as wife. You should go and have sex with some other person, I am not with me. No, you got the point. How actually each one of these type of things in each case works out to be very difficult. You need a good fantasy to boost arousal enough to climax. Extremely important. Men can, in fact I can close my eyes, I can think of about 1,000 ladies. Not very difficult. But you ask a woman to actually fantasize, she thinks about husband wearing lungi, husband wearing pant, husband wearing shorts and husband wearing this. You cannot get aroused. You got the point too. That particular boost is necessary. And this is one of the reasons why there is a wide difference between the libido and a lot many other things what we talk about, male and female. Inhibitory female sexuality is actually the theme. And that is one of the reasons why it is attributed to this fantasy. And this is one of the, this is from clips of North America. It speaks that as far as the women are concerned, only about 5 to 10% actually fantasize they can get aroused. In intercourse situations, only around 25 to 30%. And it is the touch and touch alone. So, there is a wide difference between how fantasy actually operates. Unfortunately, when you see porn, the average size of a man's erect penis is about 5.8. Naturally means average size for a male porn star is about 8 inches long. 85% of the female porn stars have breast implants. 100% of the pictures of porn centrifuges have been enhanced. Man wants woman that particular way. Women want men this particular way. Now you got the point. That's why the whole lot of difficulty and each one actually finding it difficult. One of this engineer who came from Norway, he was working there and then the parents wanted him to settle down here. He got married about a year ago and now it is going for divorce. Her point is, in fact she has not come for consultation. What he says is, her point is, what she has seen in the, what we call internet, doesn't match with this particular fellows. I am missing something. No, you got the point. Hypothetically speaking, virtually in fact, this is the way actually the people believe. And after watching porn, some men get so excited that they ejaculate early. And one of the things what happens is, if you are able to get aroused, released, and actually things working out, that becomes one of the easiest. So for example, the pornography becomes the easiest. Masturbation second common. The third one, how many minutes are there? 5 minutes. So, the relationship gets affected in very big way. When you put, in fact, sex is almost like launching the missile. If you go with that idea, you are likely to land up with a difficulty when actually performing. As I was trying to talk earlier about, starting from minimal, say masturbation and pornography to exhibitionism, victimization, a lot of things. And porn-free zone means, in fact, thinking about using porn, assessing porn, using porn as a sexual outlet. All these things, in fact, were actually progressive. First phase, addiction. Second phase, escalation. Third phase, desensitization. Fourth phase, acting out sexually. That's where the difficulties can come about. Each of these phases, what I was trying to talk about it in the earlier talk, it may look like totally innocuous and something simple, but to get the same type of effect, what we basically call in drug terminology, like prophylaxis we may talk about, or the tolerance, to get the same effect, one has to use a little higher or stronger one, or with the same usage, in fact, the effect it actually produces is actually less, equally applicable in this first phase. Second phase, escalation, because one way or other, in fact, he tries to improve it. Third phase, desensitization, because of which again he has to enhance. And the fourth phase, acting out, basically happens. So one has to keep it in mind, all these things. The reaction sequence, starting from very simple to how actually it can go. People have documented, and the terminology, the porn trap, that has actually come into. Brain gets affected in very significant way. This is what actually has been documented. How one can go about, in fact, to stop getting away from this, you have to put up effort. And the type of difficulty it can produce, if you are well aware, it actually can make you understand why actually you should be avoided. Serial killers, the partner in pain, being in the dark, shock recovery, emotional wounds it produces, and trying to cope with. These are the few things actually people have. The negative consequence of using pornography, the whole lot of things actually I am easily irritated and depressed to, in fact, relationship gets affected, has been documented. Spiritually speaking, in fact, it can be quite problematic. And what people have documented is it is almost like a black hole, addiction interaction. Substances, processes, core effect states and relationships. Almost all of these areas get affected. It is actually a black hole. It is a matter of first of beginning and then following through. And treatment, when we are trying to talk about pharmacological, non-pharmacological, whole lot of treatment techniques are available. There are 6 basic action steps. Tell someone, take help, get involved in the treatment program, create a porn-free environment, establish 24-hour support and accountability, take care of your physical and emotional health, start healing your sexuality. These are the few things we have told that how one can actually come out. We all watch porn. We don't acknowledge it. Porn exists in a parallel universe, a shadowy other world. When you force anything into the shadows and underground, you make it a lot easier for the things to happen, and that's where, in fact, the type of difficulty that comes. As psychiatrists, this has to be taken seriously, and we are all well aware. Individual counseling, couple counseling, and a whole lot of other treatment techniques. And what are the other positive relationship building methodologies? Engaging in courtship, talking with the partner, expanding the sensory awareness, see your partner with the new eyes, increase your touch vocabulary, explore the realm of sexual pleasure, involve your heart in sex. So these are the few things. I'm running a little faster mainly because they're already indicating that time is up that way. So one of this particular idea is how to get the best out of the relationship. And one of the points what I almost always say is, you treat your wife as a girlfriend, that would be one of the, how actually the process they were about 3-4 slides, but they're actually not going forward. In short, what I can convey is, these are the newer type of problems which are there in a small way at one particular time we thought. It is already there in a very big way. And in the coming days, these are the problems for which actually people are going to seek your help. We have to be sensitized ourselves, sensitize the population, and see that what best effort can be made to help these individuals. Thank you very, very much for wonderful opportunity.
Thank you very much, sir. Recent presentation. covered everything in spite of your, you said that you were asked to talk only about section of this thing, but everything is covered very well. Sir, before going to this thing, I would like to ask you a question. After this COVID, most of the students are exposed to the online classes, so they got the smartphones. So most of the parents now they come that at the age of 8, 9, 10 years also they got the cell phones. So most of them are now addicted to cell phone. And as you said, one mother came to me just a few days back, and she said when she was going to the bathroom, she saw a light going under the bed sheet. Then she saw her daughter is chatting with someone else at midnight around 1 o'clock. So this is going on since a long time, and even they got addicted to the phone also earlier also people, and they are threatening when they said just take away the cell phone, make available the availability of the cell to just limit the phone time. They are threatening the parents that they will commit suicide if they don't use cell phone. That is the way. So I don't know how you are going to encounter that problem.
A time was there when, of course, cell phone was not allowed inside the classroom. Now classroom has gone inside the cell phone. So this is the reality, and each individual case has to be read in a specific fashion. One important point will be how children are supposed to be brought up. That book was there. I told her, I am supposed to read it, why you are reading? She told me, I am checking whether you are doing it already. I got the point. These are difficult problems.
Now session is open for questions.
Good morning, sir. Sir, basically the first step that we do in pornography addiction, I think, is detoxification. And I find it extremely difficult given the accessibility of porn and all. Usually the issues that we face in married couples that we see, cases of pornography disturbing their sexual life. There are cases, there is so much of disturbance that happens. Detoxification that we try to do, so whatever amount of effort we put in, it is ultimately, I feel, very, very extreme high failure rate. So how are you actually dealing in your issues?
See, you are asking me the question. We were using inverted comma pornography as a treatment technique sometimes. See, for arousal, couples seeing it together, and a lot of, in fact, good pornography in the sense that there are a lot of things which can actually teach different techniques. That's one, two. Once this particular issue becomes a habit to addiction, it is very difficult to treat. So the motivation and a lot many other factors are extremely important because it has already affected his relationship. Compared to handling, say for example, handling smoking is more difficult than handling alcohol problem. You are aware of it? But one of the famous statements, I myself have confronted so many times. So that means again and again we get into pornography, masturbation. These are the two things. They are very difficult to be handled because they are the very easy way out, and no other person necessary to be involved. So there are some cases where motivation is lacking and they are not willing to. They are quite difficult, and failure rate is actually high. But all said and done, effort should almost always be put, and these are some individual cases where it might happen and where awareness has come and it has actually affected the life and all of that. People actually change. This is also there. Both the things are possible. Again, as we are as you were mentioning earlier, it is individualization of the treatment for either a couple or individual.
Thank you, sir.
Sometimes drugs and other things also may be necessary. Particularly SSRIs and other related drugs have been used quite effectively in some of these cases to control the impulse.
Sir, I mean, when we are using medications, what happens is it totally if you are using SSRI, the heart should.
I agree with you, but the point is judiciously combining some of these things People have worked it out.
Role of naltrexone in this addiction, internet addiction.
Nobody has to hearing that is one of the things one must try.
Thank you, sir.
There are no further questions. We close the session, please. Thank you.
Thank you, sir, for that enlightening lecture. Now I request Dr. M. Umashankar sir and Dr. Sridhar Raju sir to felicitate the speakers and the chairpersons.
Thank you, Vishal, for giving me this opportunity.
There is a small change in our schedule because of delay in arrival of our delegates. Proceeding to the next part of the program, now we have lecture on leadership qualities in psychiatry by Dr. Lakshmikant Rathi sir, who is the president of Indian Psychiatric Society. Now, I would like to call our chairpersons Dr. K. Bhagyareddy sir and Dr. Pramod Kumar Oduganti sir onto the stage. Dr. Bhagyareddy sir, senior consultant psychiatrist, Karimnagar, alumnus of Usmania Medical College, worked as registrar, King's College, London. Started first psychiatry hospital in Telangana outside Hyderabad. Provided his contributions as past president, Indian Psychiatric Society, Andhra Pradesh, and as past president, Karimnagar Psychiatric Society. Dr. Pramod Kumar Oduganti sir, MD Psychiatry from Usmania Medical College, IMH, Hyderabad. Jobs held a civil assistant surgeon from 1986 to 1992 in government of Andhra Pradesh. Next, served as assistant professor of psychiatry 1992 to 1999, Usmania Medical College, Hyderabad. Associate professor of psychiatry 1999 to 2000 and professor and head of the department of psychiatry in Kurnool Medical College, Kurnool from 2002 to 2009. Professor and head of the department of psychiatry in Usmania Medical College and worked as superintendent Institute of Mental Health, Hyderabad. Professor and head of the department of psychiatry, Mallareddy Medical College for Women, Suraram, Hyderabad. Nodal officer, Andhra Pradesh
morning, everybody. I think everybody is so fresh and anxious, and also very much alert after the lecture of Satyan Rao. Because there is no meeting, no conference, except without Satyan Rao's their emotional lecture, emotional I can call it, or erosion, whatever. So thank you very much, Dr. Satyan Rao, for having here, visiting us and giving this. And the very next man, after the very famous, and I'm very glad and proud to have one of our national president, Dr. Lakshmikant Rathi here. He's a very dynamic person, very much of outgoing and very hardworking, and he's a consultant psychiatrist in Amaravati, not Andhra Pradesh, Amaravati, Maharashtra. He's a very known to have very social work and all these things. But the very point of today's program, today's topic, Dr. Rathi has taken up the leadership qualities in psychiatry. What way it is connected? Leadership and psychiatry. Psychiatry as such, it is a personality molding, and personality checking out, part of a specialty of medical science, and which is unique in its own way. A couple of decades ago, when we were undergraduates, the very name of psychiatry was not much known and not much of sort of specialty after the graduation. But nowadays, psychiatry is the thing that has happened. One who takes the psychiatry is a unique man now. Has got a lot of demand for that. Because the very person who tries to choose psychiatry as a specialty must be a leader, and he has got the leadership qualities. The leadership qualities within the leadership qualities in our own sphere of our knowledge is much more paramount important than the other specialties of psychiatry. And it is a basic thing. You have to have so many qualities within you. You have a good listener, a good sympathizer, good authentication of the facts, and resilience. That's the most important thing to have. You need and treat psychiatry like a specialty. As a matter of fact, the psychiatrists evolved. There are so many of our own very much Indian, Dr. Deepak Bakker as the national president for the Royal College of Psychiatrists, and our own Dr. Rai Abraham, and Dr. Prasad Rao, and there are so many of our own people have their leadership, and all Chandrasekhar, and all the recognition figures and all. Lakshmikant Rathi is a very much of a person who leads, has got a quality of leadership to lead the whole country psychiatrists here, and he is very much here. And our own youngsters, also the second generation of people have come up. The youngest of the next generation, Dr. George, Vishal, and all these people also coming up with their good leadership qualities in psychiatry. And now with all these few words, now I request Dr. Lakshmikant Rathi, the very person, he's an executive member of South Psychiatric Federation. And he's a founder president of Vedanta Psychiatric in Amaravati Psychiatric Association, and also practices privately owned Govardhana Hospital, Amaravati, since last 22 years, and lifetime achievements aware with the IMA and Lions Club International, facilitated by ex-President of India, Srimati Pratibha Patil, for his medical social work. It is very much of a great honor for this thing, and we are all proud of that. He conducted not only mental health and awareness camps, goes a lot of international conventions and conferences, and he's very much here, and we are very much lucky to have all the way he has come from Amravati over to our Nizamabad. And he's now the rest of the thing. He's really a leader in himself. He has got leadership qualities, and he's going to explain to us what is the leadership qualities in psychiatry. Thank you very much.
Thank you, Chairperson, and a very good morning to you all. Good morning.
Good morning, sir.
My listening is poor. Good morning.
Good morning, sir.
Thank you very much for this alertness. Leadership quality is not important in psychiatry. Leadership quality is important in life. Whatever field you are working, whether you're a doctor, a psychiatrist, a neurophysician, neurosurgeon, lawyer, architect, if you have got a leadership qualities in your personality, the success will touch your feet again and again. Otherwise not. So it is very, I would like to people to settle down, please. I am a person who speaks in flow. So all the people, please take your seats. I will request the organizers to kindly do this. Because any movement unnecessarily disturbs my flow, please. And thank you very much. So leadership quality is very important, as I have told you. Now, first I will be telling you what is these leadership qualities are there, how they can be acquired, and then I will be telling you how they are applied to the psychiatry or as a consulting psychiatrist also. So what is leadership? Effective leadership is the cornerstone of success in any organization, from guiding teams to driving innovation. Strong leaders inspire others, navigate challenges, and cultivate a culture of growth and achievement. What is leadership again? If anybody wants to define with the leadership, I will define it like this. Art of inspiring and guiding others towards a common goal. It involves strategic vision, effective communication, and the ability to motivate and empower teams. A strong leader can navigate challenges, foster collaboration, and drive meaningful changes within an organization. Now, this small video will tell you what is the difference between a leader and the masses. How a leader directs his team, changes the plans to achieve the goal, the target which he has given to his team.
Where's the light? It just moved. Then what do I do? We'll be stuck here forever.
Do not panic. Do not panic. We are trained professionals. Now stay calm. We are going around the leaf.
Around the leaf? I don't think we can do that.
Oh, nonsense. This is nothing compared to the twig of 93. That's it. That's it. Good. You're doing great. There you go. There you go. Watch my eyes. Don't look away. And here's the line again.
Thank you. Thank you, Mr. Soil.
Good job, everybody.
Oh my, there's quite a gap, Mr. Soil. Shouldn't we tell the Queen?
I don't think we need to involve the Queen in this. She's got enough on her plate already. Training her daughter.
Oh yes, Princess Anna, the poor deep.
This is any organization leader, anything here. Suppose I am working at present as the president of IPS, there are hurdles and obstacles are going to come. A leader should have a potential and quality to surpass those obstacles and those speed pickers and take the organization or take his group to the success, whatever targets and goals he has given. Can I please also be effective leader? Can I get a cordless mic, please? Because I am not able to.
Pouch.
And can I get a characteristic of an effective leader, vision and strategic thinking. A leader must have got a vision. If some of your senior members are sitting here, TSS and all these people, when I was contesting for the vice president of the IPS, I have given the vision that what I would like to do after becoming a president. Vision, if a Prime Minister Modi is the president of Prime Minister of the country, he has a vision that what he wants to do for the country. So any leader has to have, please, why are you? And inspirational communication is another ingredient. They communicate with passion, empathy, clarity, and motivating and empowering their team. You must have seen people that they are, again here we can give the example about Prime Minister is an influencer. You must be able to motivate the people, and art of communication can only do this. This communication has to be very clear. Communication skills itself is a very strong topic, but your communication has to be very clear, transparent, simple words so that people can understand it. Communication is very important. You sit in OPD, see a patient, how you communicate with your patient is very important. How you take the history, because I have no hesitation in saying I am practicing since last 4.2 decades. People have stopped or probably have forgotten taking proper histories, clinical examinations and all. We are too much becoming dependent on the investigations. But communicating with the patient with a humble and simple fashion, and this is very important. Your communication has to be very strong and very clear. Then only you can this. Adaptability and resilience are again another these ingredients. You must be ready to adapt to the situation whenever it is required. There are leadership styles. Autocratic leader, it takes the decisions himself and checks that these decisions are taken. Democratic leader concerns his team, discusses with them everything, and then he takes a decision. This is a good style of functioning of a leadership. Transformational leader plays as a role model. He himself has got so much of emotional intelligence that big people who were these big politicians, whether it's Hitler or anything, if you go across, whether it was Mahatma Gandhi, they acted as a role model, and they were the transformational leader because they had a very high level of emotional intelligence. What is emotional intelligence? That will be coming in my next slide when I go to it. One more style is there, laser-free. Laser-free leader, they leave it to the team. They don't direct anything, they don't control anything. They say just whatever you want to do, you can do it. And that laser-free leadership is like that. Now, developing leadership skill, what is required? Continuous learning, especially the PG students who are sitting here. Your learning is very important. I always say, this is your educational period. This will never come back to you. You will get a lot of time for seeing mobile, seeing TVs, doing parties, doing love affairs. But this educational period will never come back to you. If you want to become a successful psychiatrist, which you want to become because you are joined for that, then you have to have a continuous learning. Because I always say the future is yours. Future is yours because mental health awareness is increasing by leaps and bounds, and definitely you will be treating much more patients than what we are going to treat. Mentoring and coaching, your teachers are there, many HODs are there, Vishal is there, Fanikant is there, Minas is there. These are the people who teach you, mentor you in your hospitals and do this. Hands-on experience. Anybody who was a class monitor amongst you who can raise his hands? There are few hands only 4 hands. Never leave any opportunity where you can become a leader, maybe of a macro group, because that will develop leadership qualities in you which will help it. The people who were class monitor would have definitely been today a good leader because they were attracted towards leadership and they did it. This is very important. Whether you get a chance of becoming a president of a Lions Club organization or anything, you never miss it because that will definitely develop better medical leadership qualities in you. Self-reflection, hands-on experience, self-reflection and feedback is very important. I always say you must give time for yourself. You give time to your family, you give time to your friends, you give time to your society, but you never give time to yourself. Introspect yourself every day before sleeping, 15 to 20 minutes. How was my today's day? How can I make it better? And how was my last day where I made some mistakes? This is very important. Empowering and motivating. Always empower the teams. Suppose I am the president of the IPS, I have made various teams, membership committees or any mini-R committees. Then definitely I must empower them to take their decisions rather than controlling them, and I must motivate them also. I would like to give George is here, Dr. D. Yes, please rise on your seat. He is the membership committee chairperson and he has given a maximum number from the Telangana till now. A big round of applause for him. This is a leader's job to motivate the people who are appointed when they are doing good work. Decision making and problem solving are again the key ingredients of a leader, because One thing I tell always, you must take decisions. You must never remain indecisive in life. Whether you have taken a right decision or wrong decision, time will tell. But take a decision. Tata has also written in his biography that you take a decision and then try to prove that you have taken a right decision. That is the quality of a good leader. So always take a decision in your life. Ethical leadership means integrity and transparency, very important. Fairness and equity, you must be fair to all. Everybody is equal. Once you become a leader, everybody is equal to you, so you should be fair and equal to all. Accountability and responsibility should be there. A leader must take the accountability and responsibility. Suppose I am the president of Indian Psychiatry Society today, whatever success I will be achieving in this year will be the success of my team. But if any lacunas are there, if their shortcomings are there, then definitely as a leader I will be responsible for that. That will be my accountability. So leader must take accountability of this. Adaptability, building resilience. This last one is very important. Conflict resolution. Many complex, sudden hurdles, sudden problems will come up with. You must, a strong leader, possess emotional intelligence to navigate complex interpersonal dynamics, mediate conflicts, and bring diverse perspectives together to find solutions. This is very important. The future of leadership, digital transformation. Again, this is very important for you youngsters. WhatsApp was not there, Facebook was not there, Instagram was not there. AI has come. So many on for 100 years are coming because we utilize only 10% of the brain till we die. That science says, I am not saying. So 90% of the brain we don't utilize. But there are few people who utilize their brain to the best of their capacity and they innovate. So newer and newer technologies will be coming. So you youngsters have to remain prepared and at pace with these technologies. Because the patient and the relatives will be asking you many questions which were not asked to us when we were there. Because so much of knowledge and so much of these things were not available. Inclusive leadership, take everybody in confidence, sustainable practices. As a leader, I should not start in a practice which cannot be continued in any organization. That is very important. Agility and resilience is again this. Now this will be showing how to remain still motivated. A video which will tell you. Sound ko thoda kam kar dena. In the jungle, which animal I heard in the jungle which animal is the tallest? I heard you say giraffe. In the jungle, which animal is the wisest? I heard you say fox. In the jungle, which animal is the fastest? I heard you say cheetahs. Among all these wonderful qualities mentioned, where is the lion in the picture? Yet you say lion is the king of the jungle even without any of these qualities. Why? Because lion is courageous. Lion is very bold. The lion is becoming successful. This is very important. Examiner asked, why? Now, shift towards complexities. We are shifting towards complexities. Running a nursing home is much more difficult. I am seeing since the last 42 years I am practicing. So many permissions, so many things are required which were not required previously. So complexities are going to increase and increase because new and new rules and regulations are going to come when you will be practicing in your era. So you will have to deal with all those complexity and current as this. This way evolving complexity of medical practice and leadership will definitely increase. Now, Freud's perspective on leadership was also there. What was it? Leadership driven by group dynamics and identification process, effective ties between leaders and the group, strong emotional bonds between leaders and the group foster identification and loyalty. Trust and fairness in leadership relationship foster a sense of loyalty and cohesion within the group, enhancing overall commitment and performance. This slide is very important. Just imprint it in your eyes, heart, soul, brain, wherever you can do it. Empathy is the most important thing in life. You must have empathized with the persons or people around you and try to feel their pain, their agony, their sorrow, their success in making opportunities, building worth and commitment, and fostering empowerment and decision-making opportunities in the leadership. You have to dream before your dreams come true. Abdul Kalam sir has told this. Anything you want to become a successful parents, mother, wife, husband, engineer, architect, doctor, lawyer, whatever you want to become the president of the, you have to dream it before. Suppose if you don't dream, suppose I would have not dreamed that I want to become the president of Indian Psychiatric Society, I would have not become. Definitely I would have tried for that. Dreaming is very important, and this young generation I would like to tell, go on dreaming, because unless and until you dream, you will never try to achieve that dream. The dreaming sapne dekhna is very zaruri. This is very important. So you do it whenever all these things, because all the innovations, all the inventions, what Abdul Kalam sir has also done as scientist, is dreaming. Can we go to the moon? Yes. How? Then brain starts storming how we can go to the moon. But first, you have to dream that you want to go to the moon. That's important. Supportive leadership builds trust, promotes teamwork, encourages commitment. That is a supportive leadership. Everywhere you must be having these meetings in your departments and all this, where you discuss all the things and all this. Or in the hospital. This is the emotional intelligence I was talking of. As a leader, what you should have. Self-awareness, control on yourself, decision-making capacity, and understanding the perspectives of this. I'm not going into the much details of each and every slide because of a lack of time. Next day will be strong communication. As I told you, the communication is very important. I've given you a few examples of this. The communication skills are very important for becoming a good leader. Innovation distinguishes between leader and a follower. A leader always thinks out of box. And when leader thinks out of box, then you are become an innovative person. All the people who have made innovations, they were the people who were thinking out of box, whether it was Steve Jobs or anybody else. There are so many in the history, we can name so many in history. So this is, and leadership is what? Leadership is not making followers. Leadership is making a new leaders. That is also one aspect of leadership. Persuasion is very important. With the people or students or anything. Suppose I have given some job to somebody, I will have to persuade with him. That where is it? I will have to give the deadline of things. Suppose is here, we have taken an IPS calendar, I don't know, and kept in your clinics also. Thousands and lakhs of copies can be distributed. Now this is the public awareness program this year we have taken. And it will be coming in all the regional languages till this tenure will end. Leadership is about persuasion and not power. Leaders evaluate circumstances thoroughly, assess the situation comprehensively before deciding, ensuring all the necessary aspects are considered. Reliance on essential information, leaders base decisions on vital and relevant information, enhancing the quality and impact of their choices. Training future leaders. Medical practice will continue to be a kinetic process. It is never stagnant. Medical science, whether you are working anywhere, CT scan was not there, MRI was not there, it is a kinetic process. More and more machines will come. You will have to remain updated. Doctors are required to possess a very more extensive skill set today than they did a generation ago. I myself told you, so much skills were not required when I started my practice on 7th of February 1982, running a 25 nursing home, which still I run. But today, it requires much more of this, much more knowledge, much more keeping pace. Many drugs were not there when hundreds of drugs have came. And for what we are taking all these PGCMEs and conferences and updating our knowledge, this is all, and this will have to continue at a better pace. Undoubtedly, physicians or psychiatrists in future will have increased obligations to interact with the public, the lay press and the media with both the written as well as the spoken words. Preparing the future leadership in psychiatry. For the 21st century, psychiatrists' communication skills will be paramount. They must not enter their practice unprepared. There is a voice now. There is a voice now in Western countries in this practice also that leadership should be taught and should be a part of the curriculum only. We learn so many things, but unless and until we are labeled, we learn how to implement it, how to practice it, how to do it in a practical life. I think that knowledge is not that valuable as much if you know how it is to be implemented. Leadership is an acquired talent requiring a constant learning process to adapt to the latest developments. There are many debates, many times the leaders are born, but I tell you, it is an acquired talent. Anybody sitting in this front in any chair can become a leader, provided he works hard towards that. Programs of executive education and further training should be continuously completed to ensure excellence in psychiatric leadership. Now, these are one of the last lines of this. All the psychiatrists, as a psychiatrist, we all are leaders in our way. Let us embrace our responsibilities and fulfill our role with wisdom, humanity, courage, determination for the welfare of the mentally. That's what I wanted to present. Thank you very much. My best wishes to you all to become a good psychiatrist, to become a successful psychiatrist, and become a successful citizen of this country. Thank you very much for the patient listening. Thank you very much.
Thank you very much, Dr. Rathi. So, very good, informative, and very well learned for the youngsters here sitting. And as you said, the very word itself, leadership itself is a very sort of promoting word and very promising word. And all the psychiatrists and budding psychiatrists and future psychiatrists are going to have this kind of leadership. I wish everybody will be like it. And there is so many leaders sitting in front of us. Dr. TSPSYCON is going to be another next president of IBS. I think he's one of our leaders and a very well-known person. And also, politically speaking, Dr. Mahesh Kumar Gaur, and I forgot your name, sir. Bhupati Reddy Saab, and he's a doctor also. Yeah, he was orthopedic doctor. He was my colleague when we were doing for Telangana station in the beginning. And I like that. So leadership qualities are inbuilt in everybody. So thank you very much, Dr. Rathi. You have been with us and you have enlightened us. Thank you very much.
Thank you, sir, for proudly insightful discourse. Now I request Dr. Chandrasekhar, sir, Senior Psychiatrist, Asha Hospital, and Dr. P. Kishan, sir, onto the dais to felicitate the speaker and the chairpersons. I also invite Dr. Midhat, sir, onto the stage.
मुदाकरातमोदकं सदा मुक्तिसाधकं कलाधरावतं सकं विलासि लोकरक्षकं मुदाकरातमोदकं सदा मुक्तिसाधकं कलाधरावतं सकं विलासि लोकरक्षकम् अनायकैकनायकं विनाशिते भदैत्यकं नदाशुभाशुनाशकं नमामि तं विनायकम् अनायकैकनायकं विनाशिते भदैत्यकं नदाशुभाशुनाशकं नमामि तं विनायकम् नमामि तं विनायकम् नतेतरातिभीकरं नमोदितार्कभास्वरं नमत्सुरारिनिर्जरं नताधिकापदुद्धरं नतेतरातिभीकरं नमोदितार्कभास्वरं नमत्सुरारिनिर्जरं नताधिकापदुद्धरं सुरेश्वरं निधीश्वरं गणेश्वरं गणेश्वरं महेश्वरं तमाश्रये परात्परं निरन्तरम् सुरेश्वरं निधीश्वरं गणेश्वरं गणेश्वरं महेश्वरं तमाश्रये परात्परं निरन्तरम् परात्परं निरन्तरम् पञ्चरत्नमादरेण योन्मनं प्रजल्पति प्रभातके हृदि स्मरं गणेश्वरं गणेश पञ्चरत्नमादरेण योन्मनं प्रजल्पति प्रभातके हृदि स्मरं गणेश्वरं अरोगतामदोषतां सुसाहितीं सुपुत्रतां समाहितायुरष्टभूतिमभ्युपैति सोचिरा रोगतामदोषतां सुसाहितीं सुपुत्रतां समाहितायुरष्टभूतिमभ्युपैति सोचिरा अभ्युपैति सोचिरा
The inaugural function will start in another 2 minutes.
హాయ్ బ్రో అనిల్ బ్రో చాలా రోజుల తర్వాత అంత మంచిదన్న మస్తు రోజుల తర్వాత కలిసి మీటింగ్ కలిసి ప్రెజర్ అనుకుంటాను అది వేసుకున్నాము రైట్ ఫస్ట్ కింద పెట్టి మన కేబుల్ ఎవరికి డిస్టర్బ్ అవ్వకుండా ఎన్నికలు పెట్టారు ఈ కేబుల్ కూడా నాకు డౌన్ చేసి కేబుల్ మూవ్ అవుతుంటారు కదా ఇప్పుడు తక్కువ మాట రేట్ ఇస్తుంది అది ఉన్నది లైట్ ఉన్నది లైట్ ఆడ నేను
A very good morning, everyone. It's our distinct honor and privilege to welcome you to the 10th decennial annual State Conference of Indian Psychiatric Society, Telangana State Branch, here in the vibrant city of Nizamabad. The theme of the conference is Addiction Psychiatry. We welcome all the delegates to this academic feast. May I now respectfully invite our esteemed dignitaries to the dais. Dr. Minhaj Zafar Nasirabadi, Sir, President, IBS Telangana State Branch. Dr. Lakshmikant Rathi, Sir, President, IBS Chief Guest. Dr. R. Bhupati Reddy Garu, MLA Nizamabad Rural Constituency. Shri Bomma Mahesh Kumar Gaud Garu, MLC and Working President, DPPC. Dr. M. Umashankar, Sir, CEO, State Mental Health Authority, Telangana. Dr. Ashok K. Alamchandani, Sir, Vice President, IBS TSP. Dr. Vishalakulla, Sir, Honorary General Secretary, IBS Telangana State Branch and Organizing Secretary, TSPSYCON-2024, Nizamabad. Dr. Anita Rairala, Ma'am, Honorary Treasurer, IBS Telangana State Branch. Dr. Fanikan Kondaparthi, Sir, Editor, IPS Telangana State Branch. Dr. M. Ram Suppa Reddy, Sir, IPS Telangana State Branch, South Zone Representative. And Dr. V. George Reddy, Sir, Organizing Chairman. Handing over the proceedings to Dr. Minhaj, Sir, IBS Telangana State Branch President.
Thank you for the warm welcome. I would request the organizers to start with prayer song. I request all the dignitaries to please stand up for the prayer song.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्याय गानोत्सुतमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलत्सायिने गुरुविक्रमाय गुह्यप्रबलाय गुरवे गुणगुरवे गुरुदैत्यकलक्षेत्रे गुरुधर्मसधाराध्याय गुरुविक्रपरित्रात्रे गुरुपाखण्डखण्डकाय गीतसाराय गीतनादाय गीततत्त्वाय धीमहि गौडगल्फाय खण्डमत्याय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि ग्रन्थगीताय ग्रन्थगेयाय ग्रन्थात्मनात्मने गीतलीलाय गीताश्रयाय गीतवाद्यपटवे गेयचतुराय गायकवराय गन्धर्वप्रियकृते गायकात्वेन विक्रमाय गङ्गाचलप्रणयमटे गौरीसनन्दनाय गौरीहृदयनन्दनाय गौरभानुसुताय गौरी गणेश्वराय गौरीप्रणवाय गौरीप्रणयाय गौरभावाय धीमहि गोतहस्ताय गोतघोषाय गोपगोपाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि. Thank you.
Thank you. May I request all the dignitaries to come for lighting of lamp? Thank you. May I request our guest of honor, Mr. Mahesh Kumar Garsar, please say a few words here.
గౌరవ మహిళా ప్రొఫెసర్ నసీరాబాద్ గారు, ప్రెసిడెంట్ IPS TSP, లక్ష్మీకాంత్ రాఠీ గారు, అశోక్ గారు, విశాల్ ఆకుల గారు, అనిత గారు, వాణికాంత్ గారు, ఎం రామ్ సుబ్బారెడ్డి గారు, జార్జ్ రెడ్డి గారు, భాగ్యారెడ్డి గారు, టెన్త్ యాన్యువల్ కాన్ఫరెన్స్ ఆఫ్ ఇండియన్ సైకియాట్రిక్ సొసైటీ జరుపుకోవడం మీ అందరికీ కూడా అభినందన తెలియజేస్తా ఉన్నాను. నేను చాలా సందర్భాలు చెప్తా ఉంటాను, డాక్టర్ ప్రొఫెషన్ అనేది చాలా గొప్ప గౌరవప్రదమైన ప్రొఫెషన్ ఈ దేశంలో. We go and ask any 10th class finishing student, what is your future goal? So more than 50% of the students opt for MBBS. They want to become a doctor. డాక్టర్ కావాలనే కళ 10th పాస్ అవబోతున్న ప్రతి మెజారిటీ స్టూడెంట్స్ కనబడేటువంటి అంశం. అఫ్కోర్స్ పొలిటికల్ ప్రొఫెషన్ అనేది లీస్ట్లో ఉంటుంది, డాక్టర్స్ అనేది చాలా టాప్ ప్రయారిటీలో ఉంటుంది. డాక్టర్స్ పాతకాలంలో మేము చూసే డాక్టర్స్ పెద్దలకు ఒక డాక్టర్ అయితే పిల్లలకు ఒక డాక్టర్ చూసేది. ఇంత సొసైటీ ఎంత అభివృద్ధి చెందంటే వల్ల కొన్ని వేల స్పెషలైజేషన్స్తో డాక్టర్స్ ప్రొఫెషన్ ముందుకు వస్తూ ఉంది. దాంట్లో ఒక ప్రత్యేకత ఉన్నటువంటిది సైకియాట్రిస్ట్. ఈ సమాజంలో ఎదుర్కొంటున్నటువంటి ప్రధానమైన సమస్య మత్తు పదార్థాలు. ఈ దేశం ఆ దేశం అని లేదు, ఈ రాష్ట్రం ఆ రాష్ట్రం అని లేదు. ప్రతి చోట దినదినాభివృద్ధి చెందినటువంటి చెడ్డ డిసీజ్ వల్ల దేశంలో మాదక ద్రవ్యాలు. ప్రపంచవ్యాప్తంగా చూసుకుంటే కూడా అసలు డ్రగ్ ఫ్రీ దేశం అనేది ఈ ప్రపంచంలో లేదు. గొప్పగా చెప్పుకున్నాడు సింగపూర్ కానీ పోర్చుగల్ కానీ డ్రగ్స్ వాడకాన్ని కంట్రోల్ చేస్తూ అతి తక్కువ మోతాదులో దేశాలు తప్ప డ్రగ్ ఫ్రీ దేశం అనేది లేకుండా పోతా ఉందంటే ఎంత దుర్మార్గము మహమ్మారిలాగా మారుతుందో మనం అర్థం చేసుకోవాల్సిన అవసరం ఉన్నది. పాశ్చాత్య దేశాల్లో ఎర్లీ 60s ఎర్లీ 70s స్టార్ట్ అయినటువంటి దురలవాటు ఆనాడు అమెరికా అధ్యక్షుడు నిక్సన్ రోజుల్లో డ్రగ్స్ మీద 70s ఎర్లీ 70s డ్రగ్స్ మీద యుద్ధం ప్రకటించి ఆ తర్వాత 1986 or 87లో ఇది దినోత్సవాన్ని జరుపుకున్నట్టుగా ప్రారంభించిన చరిత్ర చెప్తా ఉంది. ఎక్కడైతే డ్రగ్స్ వాడకం అధికం ఉంటుందో ఆ సొసైటీ నాశనానికి నాంది పలుకుతుంది. మన దేశంలో కూడా ఉత్తరప్రదేశ్ లాంటి పెద్ద రాష్ట్రం, మహారాష్ట్ర లాంటి పెద్ద రాష్ట్రం, పంజాబ్ లాంటి అతిపెద్ద పొడవైనటువంటి బోర్డర్ ఉన్న రాష్ట్రంలో కూడా అత్యధిక మాదక ద్రవ్యాలు ఎగుమతి అవుతూ ఉన్నాయి, దిగుమతి అవుతూ ఉన్నాయి, వాడకంలోకి వస్తూ ఉన్నాయి. తెలంగాణ సమైక్య ఆంధ్రదేశం తెలంగాణలో కూడా ఈ మధ్యన ఈ దురలవాటు విపరీతంగా పెరుగుతూ ఉంది. దురదృష్టం ఏంటంటే సమాజానికి ఒక ఉదాహరణగా ఎగ్జాంపుల్గా నిలవాల్సిన వారు, మార్గదర్శకాన్ని ఇవ్వాల్సినటువంటి సినీ తారలు, పారిశ్రామికవేత్తలు, స్పోర్ట్స్ మెన్, వీరు ఈ దురలవాటికి పడతా ఉంటే చిన్న చిన్నగా గుడి అడుగులు వేస్తున్నటువంటి యువతరం చాలా స్పీడ్గా ఆకట్టుకోపోతా ఉంది. భారతదేశంలో అటు కేంద్ర ప్రభుత్వం కానీ రాష్ట్ర ప్రభుత్వాలు కానీ మాదక ద్రవ్యాల మీద వాడకాల మీద ఉక్కుపాదం మోపుతున్నప్పటికీ కూడా సమాజంలో మార్పు రావాలి. ప్రభుత్వాలు ఎంత కఠిన నిర్ణయాలు తీసుకొని ఎంత కఠినమైన పనిష్మెంట్స్ ఇచ్చినా కూడా సమాజంలో అవేర్నెస్ రావాలి, మార్పు రావాలి. మన అమెరికాలో చూస్తాం, నేరం రుజువు అవుతే చాలా తీవ్ర పనిష్మెంట్ ఉంటుంది. అప్పటికి కూడా చాలామంది అవతల దానికి ఏం అడ్డు అదుపు లేకుండా పోతా ఉంది. దేశంలో కూడా కఠినతరమైన చట్టాలు తీసుకొస్తా ఉన్నాం దీని మీద. ఒకప్పుడు పట్టణాలకే పరిమితమైనటువంటి హెరాయిన్, కోకాయిన్ ఇవన్నీ కూడా ఇవాళ గ్రామీణ ప్రాంతాల్లోకి వచ్చేస్తూ ఉన్నాయి. గంజాయి వాడికో మోటుతనం కనబడితే సొఫిస్టికేటెడ్ రూపంలో ఇంజక్షన్లు ఇలాంటి సొఫిస్టిక్ మందులు వాడుతూ ఉన్నారు. దీన్ని ఆపాల్సిన అవసరం, అరికట్టాల్సిన అవసరం ప్రతి పౌరుడి మీద ఉంది, ముఖ్యంగా డాక్టర్స్ మీద ఉంది. ప్రభుత్వాలు ఎన్ని చర్యలు తీసుకున్నా ఆదిలోనే దీన్ని ఆపాల్సిన అవసరం ఉంది. సామాన్య జనంలో అవేర్నెస్ తీసుకురావాల్సిన అవసరం ఉన్నది. ఆ దశకి మీరంతా కూడా కృషి చేయాలని, రాజకీయ రంగంలో మేమంతా కూడా ఎప్పటికప్పుడు దీన్ని అప్రమత్తంగా ముందుకెళ్తున్నప్పటికీ సమాజంలో దీనికి అవేర్నెస్ తీసుకొచ్చి అట్లీస్ట్ మన తెలంగాణలో డ్రగ్ ఫ్రీ స్టేట్స్లో అతి తక్కువ మోతాదులో వాడుతున్న స్టేట్గా తెచ్చుకునే ప్రయత్నం చేద్దాం. ఈ దిశగా రాష్ట్ర ముఖ్యమంత్రి గారు కూడా, రేవంత్ రెడ్డి గారు కూడా చాలా తీవ్రంగా దీని మీద ఎక్సర్సైజ్ చేస్తూ ఉన్నారు. పలుమార్లు అధికారులతో సమావేశమైనారు. చాలా కఠినతరమైనటువంటి దీనికి శిక్షలు పడాలని, ఇది ఎక్కడ కూడా కాంప్రమైజ్ కాకుండా ముందుకు పోవాలనే తపనతో తెలంగాణలో కాంగ్రెస్ ప్రభుత్వం ముందుకు పోతా ఉంది. దీంట్లో మీ భాగస్వామ్యం కూడా ఉండాలని, భవిష్యత్తులో సమాజంలో వివిధ హోదాలో ఉన్న మనం ఈ డ్రగ్స్ మీద, ఈ డ్రగ్స్ మమ్మారి మీద సామాజిక యుద్ధం చేయాల్సిన అవసరం ఉన్నది. అప్పుడు కానీ ఇది ఒక అదుపులోకి వచ్చే అవకాశం లేదు. డాక్టర్ విశాల్ ఇందాక చెప్తా ఉన్నా, చిన్నతనంలో కూల్ డ్రింక్స్తో మొదలయ్యేటువంటి ప్రక్రియ, విస్కీ బ్రాండీలకు పోతే తర్వాత తీవ్రంగా రూపం దాలుస్తూ ఉంటుంది. తెలంగాణ రాష్ట్రం మన లెక్కల ప్రకారం దాదాపుగా 40 to 80% రోజు లిక్కర్ తీసుకుంటే కానీ నిద్రపోయేటువంటి పరిస్థితి వాళ్ళు చాలామంది ఉన్నారు. ఇక్కడ 2-2.5% డ్రగ్స్ తీసుకున్నటువంటి జనాభా ఉంది, చాలా పెద్ద శాతం. సో దీన్ని అరికట్టడంలో మీ పాత్ర గణనీయంగా ఉండాలని, ఆ కార్యక్రమం మా సహకారం మీకు ఎప్పుడు ఉంటుందని నేను మళ్ళీ చెప్తా ఉన్నాను. సమాజంలో డాక్టర్స్కి ఉన్నటువంటి గౌరవం, ఆ విలువ, ఆ ప్రత్యేకత మరే ఇతర ప్రొఫెషన్కి లేదు. మీరు డాక్టర్లుగా అయినందుకు మీ అందరిని కూడా నేను అభినందిస్తూ ఉన్నాను. మేము డాక్టర్లు కావాలని కళ్ళు కానీ కూడా కాలేకపోయినా అలాంటి వాళ్ళందరికీ కూడా మీరు మార్గదర్శకులు. ఈ ప్రొఫెషన్లో మీరు రాణిస్తూ ప్రపంచానికి ప్రాణదాతలుగా, భగవంతుడి తర్వాత డాక్టర్ ప్రాణం పోసే దాతగా ఉంటారు. ప్రాణదాతలుగా ఉన్నటువంటి మీ అందరూ కూడా అభినందనలు. ముఖ్యంగా సైకియాట్రిక్ ఫీల్డ్ అనేది చాలా కష్టమైన ఫీల్డ్. ఆ దురాఘాతానికి అలవాటు వ్యక్తి ఎప్పుడు ఏం చేస్తారో తెలియదు. మా ఫ్యామిలీ కూడా ఇలాంటి పేషెంట్ మేము ఏగుతా ఉన్నాం. కష్టతరమైనటువంటి ప్రొఫెషన్ కాబట్టి దాంట్లో మీరు రాణించాలని, మరి 10th యాన్యువల్ కాన్ఫరెన్స్ జరుగుతున్న సందర్భంలో మీ అందరికీ కూడా మా తరఫున అభినందన తెలియజేస్తూ, మా వంతు సహకారం ఎప్పుడు ఏది ఉన్నా ప్రభుత్వ పరంగా కానీ వ్యక్తిగతంగా కానీ మీ చేదోడు వాదడుగా ఉంటామనే మాట చెప్తూ సెలవు తీసుకుంటా ఉన్నాను. జై హింద్.
Now we will go for a small felicitation of Sir Dr. Mahesh Kumar Sir.
Okay, sir.
మున్సిపల్ బడ్జెట్ మీటింగ్ ఉంది, వెళ్ళాల్సిందిగా నన్ను క్షమించాల్సిందిగా కోరుతూ సెలవు తీసుకుంటాను.
May I now request for organizing chairperson Dr. George sir to address the gathering.
morning. Welcome to the 10th annual conference of the Indian Psychiatric Society, Telangana State Branch, to Nizamabad. I see the hall is almost full. Thanks for coming. I think we started this schedule on time because I think we're just 10 minutes late of the program today. Thanks to all the postgraduates who had come on time to present your papers. It was wonderful to see you in the morning here. With a few words, it's warm to have our chief guest Dr. Lakshmikant Rathi sir here with his busy schedule. I think he was hopping from Guwahati straight to Hyderabad, from there again traveling almost 230 kilometers wherever you are here. Thank you very much, Rathi sir, and it's a privilege to have you as the chief guest for this our 10th annual conference. And we have our distinguished Dr. Bhupat Reddy sir, MLA of Nizamabad rural. I think sir, it's nice to have you amongst the guests for this auspicious day of our 10th Telangana annual conference. And Dr. Umashankar sir, Dr. Minaz, Dr. Chandani sir, Dr. Anita, Dr. Fanikant, Dr. Ram Subba Reddy sir, Vishal. I think holding a conference is, I think, in Nizamabad, we were thinking it will be definitely a challenge, but so wonderfully developed Nizamabad with good infrastructures. I'm sure we'll be able to organize more and more programs. And the psychiatrists of Nizamabad, you have done a wonderful job for taking up this annual conference. It was in 2016, I think Nizamabad had the first midterm CME. Again, Vishal was there as the organizing secretary. And again, congratulations to Vishal. After 10 years, he has taken up the state conference. In between, he has done the South Zone also. Congratulations, Vishal, for your efforts, and hope you continue to have the more programs in the future. And today's theme for the conference, I'm sure it will definitely benefit all of us in our practice. Hope we'll do many more programs like this. MLA sir, yesterday we had a pre-workshop on awareness to medical officers, sir. I think this was the first time we are doing, sir. Not only we psychiatrists talking about the program, sir. We wanted to go into the public through the medical officers to the paramedical staff, sir. I think we just bring it to your notice, sir. With these few words, I thank you all, and thank you Nizamabad for giving this opportunity.
Thank you, George. Time for my address. Respected IPS President Dr. Lakshmikant Rathi sir, Dr. R. Bhupati Reddy sir, MLA Nizamabad Rural Constituency, he is also an orthopedic surgeon. Dr. Bhuma Mahesh Kumar Gaur sir, he has just left. Dr. M. Umashankar sir, CEO State Mental Health Authority. Dr. Ashok Kalimchandani sir, Vice President IPS TSB. Dr. Vishal Akula, Honorary General Secretary, Indian Psychiatric Society Telangana State Branch and Organizing Secretary TSPSYCON. Dr. Anita Rayalala, Honorary Treasurer IPS TSB. Dr. Fanikant Kondapatti, Editor IPS TSB. Dr. Ram Subba Reddy sir, IPS TSB's South Zone Representative and our past President. Dr. V. George Reddy, Organizing Chairman and immediate past President IPS TSB. And all the delegates of the dais, I welcome you all. A very good morning to all of you. I would like to start with my journey. I took over in June 2023, and I would like to thank all the members and EC, IPS TSB for their cooperation throughout the year. I would also like to thank all past presidents, all past secretaries, treasurers and all office bearers of IPS TSB for bringing IPS TSB to this level. in its 10th year. With the birth of it, Telangana state, we had Indian Psychiatric Society, Telangana state branch newly born, and within no time we could reach the top. As Dr. Lakshmikant Rathi sir was saying, our branch is looked upon. Last 2 years, for last 2 years, we have been winning best state branch award in IPS. All thanks to all our past presidents and all their hard work. Last year was very eventful. We did lots of awareness activities. On World Suicide Prevention Day, almost 100 of our members all over Telangana state participated in World Suicide Prevention Day activity, and we created awareness in general public. World Schizophrenia Day, World Bipolar Day, all were observed by most of our psychiatrists in their clinics, in their hospitals, in their medical colleges, and the events were successful. We could percolate the knowledge which we have to general public as well as doctors. World Autism Day was celebrated along with the NGO Marham, in which Governor of Telangana was there. To speak about awareness activities, this time we did a novel thing with help of Dr. George Reddy and DMNHO. We could visit almost 150 schools. We addressed students of 10th standard in 150 schools all over Telangana. 10th standard examination, we would see lots of students committing suicide and getting stressed up. So we conducted awareness program. Almost 50 psychiatrists went to various schools and conducted awareness activities in the school, taught them how to cope with stress, and this was the first time that we could percolate to the society so much, so deep. We also, along with Indian Medical Association, medical colleges and other organizations, we conducted various awareness activities. Thus, we didn't spare any stone unturned. At Apollo Hospital with Dr. Ashok Alimchandani sir, we did midterm CME, topic being how to establish psychiatric practice, and it was a runaway success. PG CME was done at Pratima Institute of Medical Sciences by Dr. Sai Krishna Pulli and Dr. Kishan sir, and on research development, in which PGs were taught how to start research, how to do a paper. It was also a runaway success. One extra CME was done by Dr. Pawan at Chalmeda Institute of Medical Sciences on autism for postgraduates. Again, I would like to say that this was the second time that we won Best Branch Award, and I would hope that we do a hat-trick. I would extend my wishes to Ashok Alimchandani sir to do the same. Coming on to today's yesterday's this program, it started with a bang. We did incidentally, yesterday was World Yoga Day, and we all started with yoga teacher, and on the cricket ground, Christian Medical College cricket ground, we had yoga teacher teaching us some asanas. After that, we played cricket. There is this mission 99 by Dr. Sridhar Raju sir, who says that we should all stay healthy, mental as well as physically healthy, to be healthy till 99 years of life. So it started this cricket match. So we doctors, we psychiatrists, we sit at one place, we don't do physical activity for our own health. We started this and we played cricket. Yesterday we also did a program. Dr. Vishal, Dr. George Reddy and Dr. Fanikant and his team did a program for medical doctors as well as paramedical staff, taught them how to take care of people who have substance abuse, because many, as our MLC Garu was saying, there are many people who are addicted to various substances, but they don't come to psychiatrists. So many of them, they touch general practitioners they come in contact with paramedical staffs. So it was a good activity to take care of them. Today we saw two Galaxy of Stars, Dr. TSS Rao sir and Dr. Lakshmikant Rathi sir speaking, and we have more in live. We have paper presentations, we have oration awards, and Galaxy of Stars from all over the country. I would like to congratulate and thank Dr. George Reddy sir and Dr. Vishal for their efforts and the whole team. Thank you. My best wishes to all. Thank you. Now it is time for handing over the medal. I'll hand over the medal to Dr. Ashwani Channel and we'll change the places.
Big round of applause.
So we'll change the seats. Absent. I hand over the proceedings to new president, Dr. Ashok Chandani sir.
Thank you, Dr. Minaj. Respected immediate past president, Dr. Minaj, Dr. Nizamabad. Honorable President of the Indian Psychiatric Society, Dr. Lakshmikant Rathi, our Chief Guest of Honor, Dr. Bhupat Reddy Garu, MLA Nizamabad, Urban Constituency, Dr. Uma Shankar, the CEO of the State Mental Health Authority, Dr. Vishal Apula, Honorary Secretary and Organizing Secretary for today's conference, Dr. George Reddy, Organizing Chairman, Dr. Anita Railala, Treasurer of the TSP, Dr. Fanikant Kondaparthi, Editor, Dr. M. Ramsubba Reddy, South Zone Representative, and dignitaries of the dais, fellow colleagues in the TSP, and all delegates and postgraduates who have come here today for this conference. It is a great honor and a privilege to be given this responsibility of the presidentship of the Indian Psychiatric Society, TSP, in the 10th year of its existence. It's a beautiful day and I feel doubly honored because this happens also to be my birthplace. So I feel very nice today sitting here, standing here before you all. The last few years our society has been making good progress and that is reflected in the fact that we have been awarded the best state branch for 2 years in succession, and it's indeed a big responsibility on me, and I do hope that we will continue the momentum with the cooperation of all. We have so many dynamic leaders, Vishal, George, Dr. Kishan, so many, and younger generation also, so many are coming up, and with their enthusiasm and energy, I think we can continue and take our society to a even greater height that we need to do. As we see, there is very little penetration of psychiatry in the different parts of the state. So I think we need to go broader and deeper, just like all our other fellow specializations have been going and penetrating to all levels. Coming to the conference theme itself, it's a very nice topic the organizers have chosen. It's a beautiful day, it's a beautiful arrangement. All the arrangements have actually exceeded our expectations. And I thank you, Dr. Vishal and George, for doing this. The theme of the conference, of course, as my predecessor, Dr. Minajan, just pointed out, de-addiction services. This is a very important aspect, and as we realize that it is not merely drug and alcohol de-addiction, but there are several types of addiction which are coming up in society. As society changes gear and as society is changing in its composition, the relationship between parents and children is changing. Children and adolescents are relating more to the world around them and finding pleasure and therefore also developing addiction for many more things like internet addictions, and all these are being talked about, and it's good that we are addressing all these issues which are becoming a major problem in society, going beyond the drug and alcohol addictions. I thank you all for giving me this opportunity to be the president, and I do hope that I will live up to your expectations and fulfill all my obligations. Thank you once more. Now the next item on the agenda is an Honorary General Secretary's report by Dr. Vishal Akula. Can I call upon Dr. Vishal, please?
Good morning all. Warm welcome to Nizamabad and welcome to 10th annual conference of Indian Psychiatry Society Telangana State Branch. So respected dignitaries, today's chief guest, our national president Dr. Lakshman Reddy sir, and our president Dr. Ashok Chandani sir, and guest of honor Dr. Bhupat Reddy sir, and one more guest of honor Dr. Bhuma Mahesh Gaur sir, and our immediate past president Dr. Meena sir, and President Dr. Anita Rairala, editor Dr. Fanikant Mullaparthi, and one more guest of honor, and Superintendent Delegate Mental Hospital, and CEO Mental Health Authority of Telangana Dr. Umar Shankar sir, and State South Zone representative from IPS TSB Dr. Ram Subbareddy sir, and TSPSYCON-2024 Nizamabad organizing chairperson Dr. Jaz Reddy sir. So already Meena sir covered many points about General Secretary report. I welcome our incoming president Dr. Ashok Chandani, who is an academician and a teacher of teachers. I am eagerly waiting to work under his leadership as a General Secretary. Your dedication and discipline and determination for Telangana State Branch will bring it to more heights. And our outgoing president, Dr. Meena sir, it was a wonderful experience working with him. During this year, under his leadership, we could do a lot of awareness, and it was truly a learning experience. Thank you, sir, for all the guidance and cooperation. And during his tenure, we got a national level award from Indian Psychiatry Society. For this, I would like to thank our national president, Dr. Lakshmikant Reddy sir, and today's chief guest, our beloved IPS president, Dr. Lakshmikant Reddy sir, who is a dynamic leader and doing a lot of good work in Indian Psychiatry Society. His vision and mission is crystal clear to bring IPS to peak level. His energy is unbelievable and no one can match his speed. So we have to please give a good round of applause to our national president. We all know his stature and his work. During this half term of his tenure, he has achieved many milestones. His vision to see at least 2,000 new members to join and convert all LYM, Life Ordinary members, to Life Fellows, and for that he has chosen our past president and founder secretary of IPS TSP, Dr. Jaj Reddy, as a chairman membership drive. We will work with you for the vision. Thank you, Dr. Jaj Reddy, sir. Now I welcome Dr. R. Bhupat Reddy, sir, our honorable MLA and Nizamabad rural constituency, who belongs to our own community, our own doctor's fraternal community. Is a busy orthopedician and I'm trying to say is a member of IMA Nizamabad. So thank you very much, sir. Who has Bhupat Reddy sir contributed a lot of he has contributed a lot to the society. We are fortunate to have him. Fortunate to have him as our Nizamabad MLA rural constituency. I welcome Sri Boma Mahesh Kumar Gaur Garu, MLC and Working President TPPC, Telangana Pradesh Congress Committee. He is our strength and fortunate to have him here. And I welcome our mentor, Dr. Umar Shankar sir, CEO Mental Health Authorities of Telangana State. He is doing a wonderful work in Telangana State in the field of mental health, both administratively and clinically. So please give a big round of applause to Umar Shankar sir. Thank you sir for showing us the way. And I welcome Dr. Anita Rai Rala Madam, Honorary Treasurer of IPS TSB, who is a very active member of the society. So thank you very much, madam. And I welcome Dr. Fanikant Kondaparthi. He is editor of IPS TSB. He is doing good work and taking our journal to new heights. And also I thank our past leader Sai Krishna also. I welcome Dr. Ram Subba Reddy sir, Professor. He is a South Zone representative. Pleasure to have you, sir. I would like to welcome Dr. Jaz Reddy sir, our organizing chairperson of Telangana State's TSPSYCON-2024, without whom this conference would not have. Thank you, sir. I thank Jaj sir for extending his valuable experience and advice to conduct this conference in a smooth manner. And I thank Nizamabad Psychiatri Society members, Dr. B. Keshavlu and Dr. Rajendra, Dr. Rajshekhar, Dr. Arun, Dr. Vikas, Dr. Pradeep, Dr. Shalini, Dr. Ravi Teja, and especially Government Medical College, Professor and HOD, Department of Psychiatry, Dr. Shiva Prasad sir, and team, and all the Nizamabad Psychiatry Society members. And I would like to thank the organizing committee members for your cooperation. Especially, I would like to thank Dr. Sai Krishna and team, and from Dr. Fanikant and team for your cooperation and extending support. Especially, I would like to thank my parent organization, my assistant professor Dr. Asha Monika, Dr. G. Saket Reddy and Dr. Varun. So thank you very much for your valuable support. I am grateful to see the hall full of audience. I hope you all will enjoy the academic session. Thank you one and all for attending this conference. Thank you very much.
Hello. Yeah, I thank you, Dr. Vishal. I will now call upon Dr. Anita Ravirera, our honorary treasurer, to present her report.
Good afternoon, everyone. Respected past President Dr. Minat sir and the current President Dr. Ashok Alimchandani sir, and today's chief guest Dr. Lakshmikant Rathi sir, and Bhupati Reddy Garu, MLA, the guest of honor, and Boma Mahesh Kumar Gaud Garu, another guest of honor, and the current office bearers of IPS TSP, and Dr. Umashankar sir, CEO State Mental Health Authority, and organizing secretary of today's conference, Dr. Vishal Akula, and organizing chairman, Dr. George Reddy Garu, and all the dignitaries on the dais, I feel very privileged and delighted to be a part of this decennial IPS TSP conference held in Nizamabad. And the topic for this conference is addiction psychiatry. We all know that how addictions have increased leaps and bounds in the society, and not only the substance abuse like alcohol and cannabis, but also behavioral addictions like mobile phone addictions, internet addictions, porn addictions, they've all increased. Particularly very concerning thing is to see that in 10-year-olds, from 10-year-olds, in adolescents who are considered to be the crucial age of the society, they are also getting addicted to substances and behavioral addictions. So at this juncture, I think it is the best time to talk about addiction psychiatry, pondering on the important nuances. Like we all know that biological factors, psychological factors, and social factors are responsible for addictions, and the diagnosis, management, and treatment biologically and psychologically is an important thing to learn. So this conference theme is carefully planned to address all these requirements and to well equip the psychiatrists to deal with these conditions. So I think it is a well conceived thought and theme for this year. And also I feel that not only, and recently we have seen that many de-addiction centers in the society are being run by non-psychiatrists and non-doctors. It is very, very difficult situation. So as psychiatrists, I think it is our responsibility to run the de-addiction centers on our own and to take the lead in running the de-addiction centers. And at this juncture, I congratulate all the speakers, because all the speakers were selected from different parts of the country and they are experts in the field. And at this juncture, I also request all the postgraduates, because the postgraduate numbers have increased exponentially from the last 2 to 3 years, and it is very much needed to have poster presentations and paper presentations for NMC to consider them for exams. So it is a part of their curriculum. So I request all the pages to take active membership in IPS TSP, and you will, I definitely say that I will assure you that you will learn, because all the programs are designed particularly taking PGs into consideration. So I think it is a well thought about, and all previous IPS TSP conferences or PGCMEs are all top notch. And coming to the venue, it is a very good venue and very good infrastructure. Really it is very, I was surprised to see Nizamabad can hold such a huge conference, and the members have almost reached 400, I think. So I congratulate the organizing secretary and organizing chairperson, Dr. Vishal Akula, and Dr. George Reddy for conducting such a wonderful program in Nizamabad. And thank you, the organizing team, for giving me this wonderful opportunity. Thank you.
Next, can I call upon Dr. Vanika Kondapati, our honorary editor, for his brief message.
Good morning all. Welcome to the delegates. Respected incoming President, Dr. Ashok K. Alimchandani sir, outgoing President, Dr. Minan sir, today's chief guest, our IPS President, Dr. Lakshmikant Hati sir, today's guest of honors, Dr. R. Bhupati Garu, Honorable MLA, Nizamabad Rural Constituency, Sri Bomma Mahesh Kumar Gaud Garu, MLC and Working President, TPPC, Dr. Umashankar sir, SMHA CEO and Superintendent of IMH Hyderabad, Dr. Anita ma'am, Honorary Treasurer of IPS TSB, Organizing Chairman of TSPSYCON-2024, Dr. V. George Reddy sir, and Organizing Secretary, Dr. Vishal Akula. Very good morning. I wish this conference a huge success. We can see the efforts of Dr. George Reddy sir and Dr. Vishal and his team. Everyone has put a lot of efforts to give us a wonderful experience. I hope everyone is enjoying the hospitality. As editor, I request all the members and postgraduates to encourage the journal by sending the articles. Our Telangana Journal of Psychiatry is indexed with DOAJ and will be benefited if it's published. Please utilize this opportunity. And I thank the organizers for giving me this opportunity. Thank you.
Thank you, Dr. Manika. May I now call upon Dr. M. Umashankar Garu, the CEO of the State Mental Health Authority, Telangana, and Superintendent of Institute of Mental Health, to address the gathering.
Good morning, all of you. Respected President Dr. Ashok sir, and outgoing President Dr. Minaz Zafari, and today's Chief Guest Dr. Lakshmikant Rathi sir, and Guest of Honor Dr. Bhupati Reddy Garu, MLA of Nizamabad Rural Constituency, and Organizing Secretary Dr. Vishal Apula, Organizing Chairperson Dr. George Reddy, and IPS TSP South Zone Representative Dr. Ramsundar Reddy, and Editor IPS TSP Dr. Fanikant, and other dignitaries on the dais of the dais. Since last 10 years after formation of Telangana, we are organizing this Telangana State Branch Conferences. Regularly, we are doing conference with one theme. The theme may be different in every time. This time, Nizamabad, because I know since long time I am observing that any time some prohibition or something is there. There are a lot of cases, lot of problems noticed in the Nizamabad. Even sometimes we from the State Institute used to come to help the people here. That may be the appropriate, the conference held in the Nizamabad, they given a theme like addiction psychiatry. But addiction may be any time, like morning there is a talk, addiction may be any substance, any phone or porn or anything addiction. So those things will be difficult to cut down unless if they are committed for those. Those people committed to quit, they cannot do it, if unless a good motivation is there. But that is a responsibility of treating doctors and the family members among the patient. So here, what I want to say is, lot of deliberations going on the theme. The various senior faculty is attending and delivering their lectures. This thing will be helping us to create awareness among society. Most of the people, they may not be knowing that they have a treatment for these things. The awareness among society as well as enhance the knowledge of the people, those who are attending to the conference. And as a nodal officer as well as CEO of the State Mental Health Authority, I request all the psychiatrists, those who are treating the patients without any proper guidelines or proper license. Nowadays there are so many problems they are facing. So take the license and admit the patient and treat properly. That will save your skin as well as patients also protected. Yesterday, we saw one WhatsApp message sent by the Ashok Chandani sir. There was a problem in the Chennai. Suddenly, the court sent and inquire all the de-addiction centers in the entire state of Tamil Nadu and take proper necessary action. In that case, anybody, suppose those who are not having a license, proper license, first they will be pointing out, you are treated properly or not. They don't want that. Do you have some license or not? First they will take. So that is the reason, better to take a license properly and maintain the minimum, what are the requirements, and treat the patient. That will be helping you. And that will protect you also. And once again, I will congratulate the organizers organizing this conference very well, and also very good number of delegates also participating. And these deliberations may be definitely helping the delegates to enrich their knowledge, and they go with their.
That's the importance. Now the mental health is one of the fundamental healthcare system in human life. So it is psychiatry is something ఏమైందంటే ఫిజికల్ హెల్త్ మెంటల్ హెల్త్ రెండు. సైకాట్రిస్ట్ ఏం చేయాలంటే he has to treat the patient, he has to treat the disease, he has to treat the family, he has to treat the community కూడా. మన దగ్గర చూస్తా ఉన్నాం, అన్ఫార్చునేట్ నిన్ననే మన మై కొలీగ్ మెడిపల్ సత్యం ఈజ్ ఎమ్మెల్యే ఫ్రమ్ ధర్మ చుప్పదండి, హిస్ వైఫ్ కమిటెడ్ సూసైడ్. సో ది సూసైడల్ టెండెన్సీస్ అన్నాయి. మరి ఎందుకు అన్నది మీరే చెప్పాలి. అంటే ఈవెన్ చిన్న చిన్న పిల్లలు, కాలేజ్ పిల్లలు, ఎస్ఎస్సి ఫెయిల్ అయిన పిల్లలు, లేకుంటే ఇంకా ఇప్పుడు నారాయణ శ్రీ చైతన్యాలు ఎక్కడైతే కొంచెం ప్రైవేట్ స్కూళ్ళలో మన ప్రెషర్ ఉండి ఎగ్జామ్ పర్ఫార్మెన్స్ సరిగా లేకుండా, లేకుండా ఐఐటి స్టూడెంట్స్ చాలామంది, ఈవెన్ వర్కింగ్ ఉమెన్, వర్కింగ్ మెన్, సమ్ వితౌట్ ఎనీ రీజన్ దే కమిటింగ్ టు సూసైడ్స్. ఇది ఒక పెద్ద మేజర్ సోషల్ ఇంపాక్ట్ అయిపోయింది. అండ్ అప్పుడు టుడేస్ యువర్ టాపిక్ ఈజ్ అడిక్షన్ సైకాట్రీ. I think the psychiatry begins from the child psychiatry, children psychiatry. So now the role of psychiatry ఇప్పుడు అన్ని స్టేజ్లలో ఉంది. అయితే స్పెషల్గా ఈ సూసైడల్ టెండెన్సీస్ ఏదైతే ఉందో, ఐ థింక్ అంటే మీరు అంటే అఫ్కోర్స్ ఇట్స్ డిప్రెషన్ సిండ్రోమ్ అండ్ సడన్ దెర్ ఇస్ ఇంక్రీజ్ ఆఫ్ ద స్పైక్ ఆఫ్ ద డిప్రెషన్, దే కమిట్ సూసైడ్. బట్ అంటే దీంట్లో ఇంకా రీసెర్చ్ సీరియస్గా చేసి, బికాజ్ ఇట్ హ్యావ్ లాట్ ఆఫ్ ఇంపాక్ట్ ఆన్ ద ఫ్యామిలీ అండ్ సొసైటీ. ఐ థింక్ మా దగ్గర కూడా ఇప్పుడు ఏంటంటే ఇంకా ఈ అడిక్షన్ కూడా నిజంగా తెలంగాణ గవర్నమెంట్ వచ్చిన తర్వాత ఈ డిఅడిక్షన్ కొరకు అంటే నార్కోటిక్స్ కానీ, ఆల్కహాల్ కానీ, లేకుంటే ఇప్పుడు మన దగ్గర అయితే మన నిజామాబాద్లో అయితే తెలుస్తాం అంటే అడల్టరేటెడ్ ట్యాడీ దే కంటెంట్ సమ్ అప్రోజోలం వెరీ అడిక్టివ్. అండ్ ఐ యూస్ టు మై అంటే ఈవెన్ ద పేషెంట్ వెన్ గెటింగ్ అడ్మిటెడ్ విత్ ద ఫ్రాక్చర్ ఆఫ్ ద ఫీమర్ in the hospital, the third day, fourth day, they used to get psychotic problems, psychosis. They used to give that alcohol. There is no way to control immediately. Even if any number of these what you call drug medicines you give, they won't. They have to supplement with the alcohol or with the daddy. So that is one of the biggest problems in our area. Then of course drugs also. Government of Telangana is very serious about controlling the drugs. Already we have established a commissioner, separate commissioner for the controlling this drug trafficking and all. And it was a full-fledged office now. There is a many staff is there. There are 25 to 30 posts. Fund is given. What I mean to say is the government is very, very serious about conducting this drug menace, to control the drug menace and addictions. So this topic now today you selected is one of the best topic in the psychiatry, and it will have a lot of impact today. So it needs a lot of research, because the impact of the mental health is so much. As I told you before, that it have an economic impact, it have a social impacts, it have a So what I expect from you people is the stress management in the working life. So any software engineers, they are well educated, they are really, earnings are good, everything, environment and ambience, everything is good. But still they are coming to addictions and they are committing suicides, they are doing social activities because of this mental health. So I think at the workplace, stress management is one of the important, I think we need to have a research on that and need to have some focus on that, especially your department side. So this few words, because I am local MLA, any problem is there, I just call me, I will make you more comfortable here. And for the government side, we will have every support with you, Vishal. And actually, I have to say a few words for Vishal. Previously, Nizamabad doesn't know what is psychiatry. Then after Vishal came here, everybody knows psychiatry, there's a department is there. And everybody, so much awareness has come now because he involves in so much of social awareness camps and all. So now it is finally he brought the whole society, state society to Nizamabad. Now psychiatry is going to be very leading profession in the Nizamabad now. So Vishal, all the best to you. Then I thank you for inviting me here and making me part of this privileged conference, then honoring me. Thank you, one and all.
Since sir has to go, we are going to felicitate. May I call upon Dr. President and Chief Guest for the day, felicitate Mr. Honorable.
Sir.
Souvenir of the Telangana State TSPSYCON-2024 seminar. May I call upon Dr. Superintendent to do the honors.
Sir. Hello, sir. Right.
Saket.
Okay. Okay, right. Okay, book it. Okay, ready? Sir. Okay, ready, sir?
Michelle, congratulations. Next, we are going to have address by our chief guest, President of the Indian Psychiatric Society. Sir, we are waiting to hear your.
Can I request the postgraduates at the back, please come forward. Please take time, come forward.
President of the Telangana state, Dr. Alim Chandani, a very well-known psychiatrist who is attached to the Apollo Hospital. The outgoing president, Dr. Minaz, a very good friend of mine and a star of IPS. Organizing chairperson, George Etty, and this organizing secretary, Vishal Akula. Wonderfully, they have organized this conference. A big round of applause for this organizing chairperson. Treasurer of Telangana State Madam, because treasurer, nothing, no conference can happen. So she is the important guardian. Panikan, a very important person on this, and I worked with him. Other dignitaries sitting on the dais. TSS Rao, another faculty, past secretary of IPS, and so many people know my name. Telangana state has always remained very near to my heart because they work very efficiently, very honestly, and therefore they are getting awards since last 2 years. And today also, this year also, they will be remaining in their place, I feel. I especially acknowledge the welcome yesterday night I got at 11:45 p.m. I landed here. And when I landed here at 11:45 p.m., when a car came in front of the gate of this hotel, main gate, 15 people were standing there, and there was a firework, firecrackers were blown, garlands were given, shawls were given. I go to all the corners as a national as well as I go international also. I've never seen such a this. So big round of applause for Nizamabad and Telangana hospital. Mental health awareness is increasing day by day and will increase day by day. Because this is the thing. I've given the slogan this time, you people, you all psychiatrists and postgraduates should spread this slogan to the society, and the slogan is sound body in sound mind only. I repeat myself, sound body in sound mind only. And post-corona period, this society is ready to accept it now. Because this media has highlighted a lot during the corona period that it is related to the immunity. And everybody wants that his immunity should remain high because so many corona new variants, so many bacteria, so many more viruses are going to knock your doors, knock your health again and again. So mental health keeps your immunity at a very high level. It is very important to remain mentally strong. If you are not mentally strong, your physical strength is useless. It is useless. The people who are mentally strong, they come out of the physical elements also, physical diseases also, much faster than what the people who are mentally weak they become. So this is the importance of mental health, and I'm very happy that today you have chosen a theme of addiction psychiatry, which is very good. Addiction was there, addiction is there, and addiction will remain in future also. But what is going to change? Its form is going to change. What is going to change? Its incidence is going to change. Addiction was not there in fair sex before. Girls and women were not taking so much of, but this has changed with the society because both of them are working, both of them are earning. I'm not saying that this is wrong, but this is not, this is only the privilege of man only. But today the addiction of meow now and so many tablets are going, net addiction is there, mobile addiction is there. I think we ourselves are sometimes responsible for this addiction. I've seen mothers feeding their child in my own family. कि मोबाइल दिखाते दिखाते उसको खिलाते हैं और जब वो बड़ा हो जाता है तो उसे हमारे पास लेके आते हैं कि इसकी मोबाइल की लत आप छुड़ा दीजिए. मैं कई बार मॉम्स को कहता हूँ कि लत डाली किसने, वो खाना नहीं खाता तो कोई भूखा नहीं रहता। इंसान, भगवान ने यदि पेट नहीं दिया होता हमें तो हम किसी को भी काम करने की जरूरत नहीं। Try to keep your children as long as away from the mobile. This is the most destructive distraction of this century. I can tell you with authority and of my 4.2 decades of experience. As far as addiction is concerned, I tell you the fear of death is very important. I tell to my alcoholics, you will die one day. You will die vomiting blood one day. You will die in some butter one day. You won't see your children growing up. And this fear of death is very important. Fear of everything is very important. If somebody says tomorrow to me that your cholesterol is increasing, then definitely I or you will start decreasing your fried food and sweets. Because everybody wants to remain healthy and wealthy in this century. So fear of death is one of the most important gradient which you must transmit to your patient with full authority. And I can tell you the success rate in addiction will be much more better to you. This Telangana state branch is working wonderfully well, and this, as I told you, that future is yours. We are treating the tip of the iceberg. We have treated. The iceberg is remaining submerged, which you all postgraduates are going to treat. And many of our chunk is treated by our colleague faculties. Because I always say, no practitioner, a cardiologist, gastroenterologist, skin specialist, nobody can practice without prescribing a psychotropic or neurotropic drug. That is the situation of today. If tomorrow a rule comes, which I want to become, that psychotropic and neurotropic drug should be only prescribed by the psychiatrist, every new psychiatrist will have hundreds and hundreds of patients in front of him. So try to increase the mental health awareness. Try to tell people to talk about it. Tell people you should talk about it, like Deepika Padukone talk, W. Sharma talk. This is important. People come to us, go, but they never talk. But when they put an implant, or when they put go for angioplasty, cardiac surgery, they call all their relatives and tell, मेरे को 3 stent लगे, मेरे को 4 stent लगे थे. So what you have to do, increase public education, awareness. Tomorrow is your best wishes to you. And a wonderful conference. Again, a big round of applause for such a successful conference. Thank you very much. Your president of IPS is just a phone call away from you. Anything you need, whether here or in Telangana state, I'm always available to you. Thank you very much for your warm hospitality.
So we proceed to the next item on the agenda, which is the release of the IPS TSP journal. May I call upon Dr. Rakesh sir to do the honor.
Right, sir.
ఈ పక్కకి రండి.
This side. Okay, ready? Ready, sir? Right.
Thank you, Dr. Rakesh sir. Thank you, Dr. Fani. To Next item on the agenda is felicitation of the chief guest. May I call upon Dr. Manoj, Dr. Amashankar, Dr. George and Dr. Shakti.
Dr. Chandrasekhar sir, Dr. Ashok Reddy sir, Jagannath sir, Sridhar Raju sir, Lakshman sir.
దాన్ని వెనక్కి జరుపుతాయి ఆ టేబుల్ వెనక్కి జరపండి టేబుల్ వెనక్కి జరపండి బ్యాక్ బ్యాక్ ఓకే రైట్
Next, I request Dr. Umashankar sir to please kindly accept our felicitation.
सर दे दीजिए राइट राइट ओके रेडी रेडी सर
Next, I invite Dr. Ram Subbareddy sir to please kindly accept our felicitation.
Yes, sir. Yes, sir. Rajshekar.
सर ओके रेडी ओके रेडी सर మేడం కొద్దిగా పనిసారి కనబడ ఓకే రెడీ సార్
Fanika Kottaparthi. Next, I invite Dr. Anita Madam, Honorary President, to please kindly accept our felicitation.
Okay, ready, sir? Sir, ready?
Jagannath, sir. Sir, yes, sir.
Madam, కూర్చోండి.
Sir, కూర్చోండి.
Okay, ready?
Next, I invite Dr. Vishal Akla, sir, Honorary General Secretary and Organizing Secretary, to please kindly accept our felicitation.
Sir, Jagannath.
Next, I request Dr. Minaz, sir, to please kindly accept our felicitation.
Okay, ready, sir? Right.
I request Chandani, sir, to please kindly accept our felicitation.
Favorite student, Sridhar, sir. Sridhar, sir.
Thank you, sir. Next, I request Dr. George Reddy, sir, Founder Secretary, IPS TSP State Branch, Past President, IPS TSP, and Organizing Chairman, who is the man behind this show, along with Vishal, sir, to please kindly accept the felicitation.
Okay, ready, sir?
I request Vishal, sir, to please kindly propose vote of thanks.
On behalf of Indian Psychiatri Society, Telangana State Branch, and on behalf of Organizing Committee, as a Organizing Secretary, as General Secretary, I would like to thank today's Chief Guest, Dr. Lakshmikant Reddy, sir, and other dignitaries, Dr. Minaz Zafar, Nasira Babi, and our incoming President, Dr. Ashok Chandani, sir, and our guest of honor, Dr. R. Bhupat Reddy, sir, and Dr. Sri Boma Mahesh Kumar Gaur, and our guest of honor, Dr. Uma Shankar, sir, CEO, State Mental Health Authority of Telangana. I would like to thank office bearers, Dr. Anita Rairala, Dr. Fanikant Kondaparthi, Dr. M. Ram Subbareddy, sir, and our organizing chairperson, Dr. Jaz Reddy, sir, and other organizing committee members. I would like to thank other organizing committee members, especially Dr. Jaz Reddy, sir, and all executive council members. I would like to thank especially this conference chief partner, Dr. Raghuram Reddy, sir, and Dr. Prasad Rao, sir, Dr. Chandrasekhar, sir, Dr. M.S. Reddy, sir, Dr. Ashok Reddy, sir, Dr. K. Bhagya Reddy, sir, Dr. Satish Babu, sir, Dr. Sridhar Rao, sir, Dr. Uma Shankar, sir, and Dr. Keshav Rao, sir, Dr. Mayurnath Reddy, sir, Dr. Jagannath, sir, Dr. Ram Subbareddy, sir, and our chief advisor, Dr. B. Kishan, sir, and advisors, Dr. B. Keshav, sir, Dr. K. Shiva Prasad, sir, Dr. K. Gangaram, sir, Dr. Praveen Chintapati, sir, Dr. M. Praveen, sir, and Dr. Jagdish Babu, sir, Dr. Vishweshwar Rao, sir, Dr. Pramod Reddy, sir, Dr. Narayan Rao, sir, Dr. Manmohan Prasad, and other registration committee members, Dr. Dinesh, sir, Dr. Nagalakshmi, Dr. Umesh, Dr. Uma Maheshwari, Dr. Sanket. And venue and reception committee members Dr. Sirisha Madam, Dr. Nivedita Madam, Dr. Asati and Dr. Archana. And scientific committee and souvenir committee members Dr. Sai Krishna Puli and Raviteja Muri and Asha Monika and Saket Reddy. Cultural committee Dr. Rajshekar, Dr. Vivasan Purla, Dr. Pradeep, Dr. Suresh Alladi, Dr. R. Vivek. And food and transport committee Dr. Y. Arun Reddy, Santosh Kumar and Kalyan and Venkataramani and Dr. Niveda. Accommodation committee Dr. Vikas, Sridhar Dandapalli, Prem Nayak, Akshay and Bhanusai. Sports committee Rishikesh Giri Prasad, Om Prakash and Ramana and Varun Rao. And UG especially I would like to thank his master Dr. Sanjay Kumar sir and Dr. C. Shalagi, Dr. Madhuvamshi. And I would like to special thanks to our speakers Dr. M.S. Reddy sir, T.S. Satyanarayana sir and Atul Ambekar sir and Dr. Shailesh Umate, Dr. Naveen Kumar Daburu, Dr. Sai Krishna Tikka, Dr. Vivaswan Burla and other panelists, other speakers. And especially I would like to thank workshop team Dr. Fanikant Kodapati, Dr. Alisha Nagar, Dr. Manasa Prabhakar, Dr. Jyoti and Dr. Salat and other members, non-medical members, Mr. Rajkumar, Dr. Mr. Ajay, Mr. Ashwin and Bhaskar Rao and other team members. And I would like to thank Vakatan members, Jeevan Rao Garu, Baba Garu and other team members for their active contribution in Vakatan program. I would like to thank especially print and media, and I would like to thank the hotel management and sanitation staff and the audio visual team and other supporting team. So if I miss anyone, please excuse me. So thank you very much for giving this opportunity. I would like to thank all office bearers and all IPS CSB members for giving this opportunity. Thank you very much. With this, you will come. Please.
Please stand for national anthem.
विनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Quickly, we'll start the program. Yeah, we request all to be seated. Just 5 minutes, we'll start. Please, somebody is distributing the presidential address.
అది ఇప్పుడు ఫస్ట్ కార్డు ఇంకో కార్డు ఆ కార్డు ఇంకో కార్డు వేసినాల్లో నడుస్తుంది ఫస్ట్ అయితే ఫుల్ చేస్తారు 48 నిమిషాలు
కాపీ చేసుకుంటే
ఇది కూడా తీసుకో కాఫీ ఇది ఖాళీ ఉంది అయిపోయింది Okay. Sir. Okay, ready, sir? Hello, sir, ready? Sir, look here, sir. అవును పెట్టేసిన దీంట్లో ఏం నడుస్తున్నా నేను కొట్టేసి
హలో important announcement. As a returning officer of IPS TSP, I announce that we have started election process. In person, whosoever wants to vote, they can go and vote on first floor. Thank you. The timings are 1 to 3.
1 to 3.
The election process is only for members. Members are eligible to vote. IPS TSP Indian Psychiatric Society Telangana State Branch members have right to vote.
Those who have sent the ballot
Those who have sent the ballot can stay back. Those who have not sent the ballot, they can go in person and vote. Thank you.
While we congratulate our new president for the Telangana State Branch Indian Psychiatric Society, Dr. Ashok Alimchandani, we will now be having the presidential address, Psychiatri Telangana looking beyond the horizon. For this, the chairperson is our immediate past president, Dr. Nizamabad. Sir, we welcome you onto the dais. Dr. Nizamabad, he is currently the professor and head of the Department of Psychiatry at the Deccan College of Medical Sciences, Hyderabad. He is the immediate past president of the IPS TSP, also Assistant General Secretary for the IPS. He is also the Honorary Secretary for the Indian Medical Association Hyderabad City Branch, past intern for the Telangana Journal IMA, past Joint Secretary and Scientific Committee Chairman for the Indian Medical Association Hyderabad City Branch, and old Chairperson for History and Psychiatry Task Force IPS. Sir has held several important positions, including the past Honorary General Secretary for the IPS Telangana State Branch, past Vice President and Honorary Secretary for Hyderabad Psychiatric Society, past Honorary General Secretary for the Indian Association of Private Psychiatry, past member of the Academic Council IMA Telangana State, past co-convener for Doctors IMA National, past convener Media and Mental Health, President. The current position which he has transferred to Ashok sir, Honorary Secretary for the Hyderabad State Branch, and past Secretary and Scientific Committee Chairperson for the IMA Hyderabad City Branch, and as mentioned, co-convener for the website committee IPS South Zonal Branch and subcommittee for the IPS National Body. So with this, I hand over the mic to you.
Thank you. Thank you, Raviteja. Next. May I call upon our President, Dr. Ashok Alimchandani, sir, onto the dais. I would like to introduce Dr. Ashok Chandani sir. He doesn't require any introduction, but formally I need to introduce him. Please welcome our President, Dr. Ashok Chandani sir, from backbench. Dr. Ashok Chandani sir is Professor and Head, Department of Psychiatry, Apollo Institute of Medical Sciences and Research. He is a past President of Hyderabad Psychiatric Society, past Editor, AP Journal of Psychiatry. Dr. M.M. Khan Memorial Oration he has received in 2021. He gave oration on evolutionary psychiatry. He has received Outstanding Teachers Award by Telangana Psychiatric Society. His special interests are consultation liaison psychiatry, evolutionary psychiatry. Also, sir is born in Nizamabad, and I think this is a great news that you are born in Nizamabad and got presidency of Indian Psychiatric Society, Telangana State Branch in Nizamabad. I congratulate you. And sir is going to talk about psychiatry in Telangana, where we stand today, and where we have come from since last 20, 30, 40 years, 50 years, where were we, now where we are, and what is the future, what can be done, and what needs to be done in psychiatry. So without taking much time, I would request Dr. Alim Chandani sir to give his presidential address.
Thank you, Dr. Minaj. Respected chairperson of the session, immediate past president of the IPS TSP, Dr. Minaj Zafar Nasirabadi, fellow office bearers of the society, esteemed members of the IPS TSP, and delegates. It is indeed a proud privilege to be elected as president of this august society in the 10th year of its existence. I remember the struggles we had in the initial days when we were separating from the AP chapter. I feel honored as well as humbled as I stand here to deliver this presidential address. The state of Telangana, as well as the Indian Psychiatric Society Telangana State Branch, have completed a decade of existence, and this is a good time for us to reflect upon and ponder upon where we have come from, what we have achieved, and what lies ahead. These last 10 years, we have seen a lot of change in the status of psychiatry and psychiatrists across our state. These changes we are seeing are not in isolation. They are a reflection of the tremendous strides the state has made economically, in infrastructure, and in the medical and health sector. The exponential growth in the economy which has been taking place is reflected in the per capita income of Telangana, which today stands at $3,800 per annum. Now, this was only $1,700 in the year 2014-15, and please remember that the UN defines our upper middle class economy as 4,400, and we are fast approaching there. So we have to be ready to cater to such a society which is becoming stronger. This prosperity is reflected in the society around us, and parallelly there has been a mushrooming of private specialist hospitals and medical colleges across the state. Simultaneously, there has been an increase in the expectations of society, and who are now expecting even higher standards of delivery of services, and they are expecting a greater sophistication and complexity of medical healthcare delivery, and a greater expectation of specialization, the demand for which is only going to grow further as we go on. This throws up numerous challenges as well as opportunities. They say when there is a challenge, there is also an opportunity. And we need to introspect on what those challenges are and whether we are future ready. simultaneously, we are seeing there is a less stigma towards mental health, and people are willing to take services, and so we need to go accordingly. So, before we discuss the challenges, I would like to just take you to a journey to the past and go back to the roots of psychiatry in Telangana. The history of psychiatry in Telangana goes back a long way. The first detention facility for mentally ill persons, then called Darul Majinine, was started in the premises of present Chanchalgooda jail in the year 1895. That's almost 130 years now since that. And this was later on upgraded and shifted to Jalna, which is now in Maharashtra, the region from where our president comes. And it was shifted to Jalna as a separate hospital for mental diseases in 1907 with 150 beds. This was shifted to Hyderabad in 1953 to the present site of the Institute of Mental Health, Telangana, as a 600-bedded hospital. There's an interesting story here. Some of the staff who were shifted along with the hospital from Jalna, they say that the hospital was shifted because there was no electricity in Jalna, and electricity was then a wonderful treatment. Drugs had still not come, and it was a wonderful treatment which had come in the 1940s to the world, and for that is the reason. Though if you look at the net, you will be told that it was shifted because of the division of linguistics, but that is not true because the division took place in 1956. Then, going forward, the first child guidance clinic was started way back in 1960 in Nilofar Hospital in Hyderabad by Dr. Jayanagara. It was started as a comprehensive program with a psychiatrist, clinical psychologist and child counselors. It was one of the first in the nation. Following this, from the government sector, slowly the private psychiatric sector also started cropping up. The first private psychiatric nursing home was established in the late 1960s in Ashok Nagar by Dr. Yadav, who was the then retired superintendent of the hospital. And after that, we had Dr. Jayanagaraja, and Dr. Majid Khan. So in the 60s, 3 nursing homes had come up. This number went up and 3 more were added in the 80s when Dr. Chandrasekhar and others have started establishing hospitals. The first community outreach program was initiated by the Institute of Mental Health, Hyderabad at Shankarpalli PHC in 1980 as a weekly visit, and I remember it was very highly successful. There used to be huge numbers of patients waiting. So from there it was realized that there is a need for psychiatric services in the rural areas also. This was, mind you, this was much before the National Mental Health Program was initiated by NIMHANS. So in community outreach also, we have been one of the pioneers. The first district community mental health hospital was started in Sangareddy in the year 1985. Now this is about Hyderabad. Now coming to the districts, rather late entry into the field, the first private psychiatric nursing home was set up in Khammam in the year 1992 by Dr. Sharad, who is the late Dr. Sharad, I must say, because he is no longer with us. This was followed by Dr. Satish in 95, then in Karimnagar it came in 98, followed Dr. Kishan, and then slowly it has been growing. But the growth has been very, very slow. The next big step in the growth of psychiatry in Telangana was a transition from individual standalone psychiatric nursing homes to a collaborative model where a group of psychiatrists came together and established Asha Hospital as a ward in the Woodlands Hospital in the year 1998. This was a pioneering step and a role model to the nation and became a benchmark in comprehensive care and in how successful and is now being successfully implemented by many other psychiatrists across the country. As the situation stands now, there are only a total number of 19 private hospitals registered with the State Mental Health Authority with a bed strength of 876, 5 medical colleges with a total of 190 beds licensed, and 3 government hospitals with a total strength of 660 beds, bringing the total number of licensed beds, psychiatric beds in Telangana at only 1726. Coming to the postgraduate training program, we have had a relatively late start. The first DPM, the Diploma in Psychological Medicine, was started in Usmania Medical College, the Institute of Mental Health, I remember, by Dr. Raghuram Reddy, in the year 1979. The MD course was established with just 2 seats in the year 1984. And following this, beyond the MD Psychiatry, the first postdoctoral fellowship in child psychiatry was started by the ASHA group in 2015, as you know, by Dr. Gauri Devi. Now, after this, in the last couple of decades, there has been an explosive growth in the number of medical colleges. As of today, there are more than 50 medical colleges in Telangana, out of which 19 are offering MD Psychiatry with a total intake of 69 per year. Some of our colleagues have been expressing dismay at what are the 69 psychiatrists going to do. But as I'm going to show in the figures as we go ahead, even the 69 may not be enough in the future, given the demand that society is going to place on us. So, now coming specifically to the status as far as psychiatric hospitals are concerned. I'm going to talk about psychiatric hospitals in general, then about the de-addiction services, and then about the child psychiatry services, and then about the geriatric mental health services. What is the pressures and demand, and what are the deficits that are there in each of them. As per the National Mental Health Survey of India 2015 to 2016, the prevalence of serious mental illnesses like schizophrenia, bipolar disorders, addiction and dementia is estimated 8% of the population out of a total of 15 to 20% of overall psychiatric morbidity. Serious mental illnesses comprise 8%. Now you can imagine 8% of the population is such a massive figure. For a population of 3.8 crores, it translates into huge numbers of figures, and most of the time it is unmet. Even the same survey said there is a treatment gap of 75% for serious mental illnesses. Okay, now when you say treatment gap, it is people who have never visited a psychiatrist or never got in touch with any medical personnel for the treatment of the illnesses. So they're just lying there in the community. 75% never are treated. That's a treatment gap. That's a huge treatment gap. Additionally, as per the national statistics, Telangana has got a greater treatment gap compared to other states. That means we still have a lot of challenges. They say it's about 13% greater than the other states. So it's not actually 75%, more likely to be something like 90% the treatment gap in Telangana. Now, and as I mentioned earlier, the present number of licensed beds in the Mental Health Authority is only 1726 in all. The expert committee of the mental health of the World Health Organization recommends an optimum of 60 per 1 lakh population. Recommends a minimum of 30 and an optimum of 60, and they define grossly inadequate if the number of beds are less than 15 per 1 lakh population. If you see the figures for Telangana, we are less than 5 per 1 lakh population. So even to reach that, to cross that boundary of grossly inadequate, we need to triple the number of beds, and to reach the level of minimum, we need to go up 6 times. So this is a huge deficit, and here is where there is an opportunity for all the youngsters who are graduating out and wondering what to do in the future. Other medical specialties have started to reach out and are offering international standards of care in every nook and corner of the state. We are seeing that we are running all ICUs and neurosurgeons and all kinds of specialists, not just at the district headquarters, but the taluka headquarters, along the highways, everywhere we are seeing. So, but when it comes to psychiatry, barring Hyderabad and a few major districts, psychiatric centers are yet to see the light of day elsewhere in the state. Most of us remain confined to our clinics. The corporate sector is not interested in us as compared to other specialties. Psychiatry is a manpower intensive specialty with relatively low margins. Many psychiatrists hesitate to start inpatient care services, and when they do, the growth is very organic and very slow. It might take 5 years by the time his practice establishes a little bit for him to get the courage, let me start a facility, and then by the time that facility is established, it takes 10 years. The cooperative model, pioneered by Asha and then subsequently emulated by Chetan and so many other hospitals, is one in which we can put our energy and our resources together with lesser risk financially, emotionally, less of a burden, and can lead to faster growth. Along with this faster growth, corporates are now talking of branding. That's the way the world is going. Once upon a time, a doctor used to go by the name, this doctor is famous, that doctor is famous. But now the world is evolving towards a state where brands are becoming important. So having a cooperative model will also help in branding. And also it will enable us to provide comprehensive care with subspecializations like de-addiction, geriatric, rehabilitation and child psychiatric services all under one umbrella. As per the committee which was established by the AP and the Canadian Psychiatric Association, ideally 50% of the beds required in society must be in the public sector. And especially in a country like us where we have a lot of relative poverty. Of course, our incomes are rising, but at the same time, a lot of people are still not very prosperous. So the government in the public sector also beds are required. On its part, the government needs to do its bit and fast track the establishment of full-fledged psychiatric wards in all district and area hospitals. The psychiatric wards in medical colleges are grossly underutilized. As I mentioned, there are only 5 licensed hospitals. A total of 19 psychiatry medical graduate psychiatry departments, postgraduate departments are there, and most of the time those beds are going underutilized. And there are so there is a need to foster awareness about the existence of these medical colleges. We need to penetrate that awareness into society and enable those beds to be filled up. It will also help our PGs. It will help society also. There are numerous unauthorized facilities that admit psychiatric patients which are existing in this vacuum. These unauthorized centers are existing because there is a vacuum, and nature does not like a vacuum, they say. So it's being filled by all kinds of people, and that need to be brought under the umbrella of the Mental Health Authority, and we need to rectify their services. This is something, as Dr. Umashankar had mentioned, that in Tamil Nadu, based upon an habeas corpus petition, the High Court had mandated that all the 366 another de-addiction centers need to be given license and then shut down if they are not properly run. Now, coming to de-addiction and rehab services. Increasing prosperity in Telangana, coupled with a change in social structure and dynamics, has led to a burgeoning problem of alcohol and drug addiction. According to the National Family Health Survey 5, at 4.9%, Telangana highest rate of alcohol use among women in South India, and at 50% among men in the age group of 15 to 49, way above the national average of 22.9%. And thus, the problem is of greater magnitude in our Telangana. And of course, you all know how there is explosion in the use of cannabis and opiates, psychedelic drugs is ever increasing. It looks like wherever there is a prospering society, the international drug mafia market targets them and floods the market with lucky. I think that phenomenon we are seeing in Hyderabad also. And so, while there is a need for supply side reduction by increasing policing, our MLA this morning was our guest of honor was mentioning that the government of Telangana has taken it very seriously. They have declared a war on drugs and allocated a separate commissionerate. So that is good news for our society. So the supply side reduction will be done by increasing policing. The demand side reduction also needs to be addressed by society. Now this demand side reduction, in this we can, psychiatrists can play an active role by spearheading awareness campaigns across all segments of society, including schools and colleges. I am very happy that in the last 1 or 2 years, under the presidency of Dr. Minaj and previously, I think Telangana has been very active in campaigning, in conducting awareness campaigns. There's a lot to be done. I think all of us need to also take the initiative to go beyond our clinics and spread awareness. At present, de-addiction services exist in the government, the private and the NGO sector. While de-addiction services have been established in all district hospitals, as mandated by the High Court recently, the government was pulled up, but their functioning is far from satisfactory, and most of them have been established just perfectly to satisfy the High Court. The Government of India has sanctioned 11 de-addiction centers out of the 541 nationwide under the National Action Plan for Drug Demand Reduction, and one addiction treatment facility in Warangal out of 66 nationwide in Engine Hospital, Warangal. Considering that Telangana has got 3% of the national population, these figures are less than 3%, 2%. And considering that we are having actually a greater number of addicts compared to the nation, we need to have more of this. There are very few comprehensively managed centers in the private and the NGO sector, while numerous unauthorized centers exist across the state. There is a need for a focused program in creating trained manpower and to integrate the medical and social sectors in this field. Members of our society have an opportunity to set up de-addiction centers and offer better and professional services. And the situation is no different when it comes to rehabilitation centers. Now I would like to touch upon the field of child psychiatry. It's unfortunately still in its infancy, not only in Telangana but across the nation. In the state of Telangana, there are an estimated 1.2 crore children between the ages of 6 to 18 years. As per the surveys, 10% of the children suffer from diagnosable mental health problems. 50% of those problems are established, of the adult problems are established by the age of 14 years itself. And as in the case of overall psychiatric serious mental illnesses, an estimated treatment gap of 70% remains for children and adolescents suffering from mental health problems. They do not get appropriate treatment at an early age. Most psychiatrists and pediatricians cater to only minor problems like mental retardation, that's intellectual disability, and associated epilepsy and behavioral problems, ADHD, but do not address the other problems of adolescent and other problems which are there. Suicides and hospitalizations due to unrecognized and untreated emotional, behavioral and substance use disorders are increasingly seen in the age group of 10 to 19 years, which is very unfortunate. Presently, there is only one comprehensive child psychiatric department in the government sector at Nizamabad Hospital, Hyderabad. Besides, there are only 3 or 4 child guidance clinics in the whole of Hyderabad. One of the major problems in delivery of child psychiatric services is lack of adequate training in the post-graduation, where the focus is mostly on medical management in the short period of 15 days or 1 month that you are posted there. And in the state of Telangana still does not have a DM child and adolescent psychiatry course. And there is only one postdoctoral fellowship which I mentioned earlier offered by Asha, which has got 2 seats, a 1-year fellowship course. Thus, there are several challenges to be overcome in improving child psychiatric services in Telangana. There is a need to incorporate child psychiatric teaching in the undergraduate curriculum and to increase the duration of training in the post-graduation to 2 or at least 3 months. That is commensurate with the problem that is there in society. There is a dire need to sensitize and increase awareness among general practitioners, schools and authorities in general. Here, we have already taken the initiative, but our members need to play a more active role in achieving this goal. We also need to network with school administrators, child counselors, and to impart training to teachers in identifying and managing common problems. Next, I would like to touch upon the issue of geriatric mental health. Increasing longevity and better health facilities have led to a burgeoning population of the elderly. Telangana has an estimated 11% of the population In the year 2021, 11% of the entire population was above the age of 60. That is a figure of 41 lakhs. And this is expected to go up to 17%, that is 70 lakhs by the year 2036, which is only 12 years away. The prevalence of serious mental illnesses like depression, dementia and psychosis is estimated at 15 to 20%, 25% of this population, and these often go undetected. Many people pass it off as, yeah, he's aging, so he'll be like that only. But very often, dementia goes unnoticed, psychosis also, and even if they have it, they are left to their fate. Thus, the problem is of massive promotions. The virtual collapse of the extended nuclear family, thanks to massive migration which we are seeing in society, whether it is international migration or rural-urban migration, has left the elderly without support. And as per surveys, 80% of the elderly are living in the villages. Thus, a clinic-based approach may not be adequate to take care of geriatric mental health services. A community-based approach would be needed. At present, there is only one specialized geriatric mental health facility run by Asu Hospital in Hyderabad. There are government old age homes in only 19 of the 33 districts, despite the mandate of one in each district under the Senior Citizen Act. The High Court of Telangana has recently called upon the government to fill up all those to start everywhere. There are very few old age homes in the private sector, mostly concentrated in cities, with virtually none in rural areas. There is a need to start a specialized geriatric mental health facilities in the government sector, a dedicated geriatric mental health facility. I hope Dr. Umashankar, you are listening, and we are all with you in getting the government to move. In the government sector, if a geriatric mental health service is established, it will serve as a train. At the community level, there is a need to train doctors and ground level workers like ASHA workers in the identification and management of the elderly in the community. Now, having spoken about the various services, I am going to talk briefly about few changes that are taking place and what we need to do to get future ready. I'm going to talk about the rights movement and the Mental Health Care Act of 2017. The new MHC of 2017 is now a reality, and it has brought sweeping changes with greater emphasis on the rights of the mentally ill. Many psychiatrists have viewed the loss of their autonomy and decision making, even if they personally feel that it is done in the best interest of the patient. The MHC also has mandated the establishment of MHR-based mental health review boards. And while if you read the fine print, the Mental Health Care Act has actually made it easier for us to admit patients compared to the previous act. It's much easier now with just a signature of 2 to the sons. While having made it easier, simultaneously the government is also it throws up interesting possibilities both in the diagnosis and treatment in psychiatry. Leveraging artificial intelligence techniques offers the ability to develop pre-diagnosis screening tools and formulate risk models to determine individuals' predisposition to or risk of developing mental illness. And also, there is now the concept of personalized mental health, where you determine which patient is going to respond to which drug. So, artificial intelligence is coming, and we also need to be ready for it. Touching upon telemedicine. Telemedicine has seen a lot of changes from the first pilot project which was conducted by Apollo Hospital and ISRO. I remember in the year 2003, I think. There used to be a doctor sitting at the other end in the rural village where the telemedicine was being conducted, and he used to act as a go-between between the specialist and the patient there. Now the current post-COVID scenario is a much liberalized scenario where telemedicine has been liberated from all these initial safeguards and shackles. But we need to be cautious in its use, and we need to use it with proper safeguards. Please remember, the onus of detecting serious problems lies on the therapist. So there are several guidelines. I think all of us need to be familiar with those about the do's and don'ts, and most importantly, it should not be beyond 6 months. We can, however, make use of telemedicine to expand our practices with caution. Next, there is also need to digitalize our practices. I think our President, Dr. Lakshmikant Rati, has mentioned in his address in the morning about digitalization, and whole of society is getting digitalized. And right from the beginning itself, the ab initio, from the prescription generation to record maintenance, even in standalone clinics. Please remember, few years, 2-3 years back, we had the first mandate by the NMC to prescribe in capital letters and not to go. That is only the first step. It's a matter of time before everybody will be required to have a printed out prescription. And so we need to actually be ahead of the curve, and rather than wait for society to impose upon us, we need to start digitalizing ourselves, our services, our record maintenance. This results in the minimization of errors, better follow-ups, and the conveniences to the patient. The patient need not keep the files with him, he can come and everything is ready. Now, while we are digitalizing our clinics, we need to be cautious about data theft and hacking. This is a real problem. They say data is a new oil, and there are a lot of corporations in the world trying to get data, and they make huge money out of that data. So constantly there is the risk of data theft. Some of my colleagues we are discussing earlier, remember some private operators were offering to digitalize your entire clinic. I have not mentioned names here of those guys, but after having given you that, and then they were managing your entire thing, and suddenly you realize that your patients are being diverted elsewhere. So the risk of data theft is there, and we need to incorporate firewalls in our system right from the beginning. Now, coming to the last part of my talk about funding. See, we have been talking separate mental health policies, and they have designated certain percentage of the budget for that. I think the state of Telangana also needs to emulate that. That's a way forward. And unless the overall health budget is expanded, we cannot expect more funding for mental health. The corporate sector, as I already earlier remarked, is least interested as they perceive psychiatric services as earnings per patient day occupied. That means if a patient is sitting in the room for 1 day, he generates 1 lakh income, where a psychiatric patient will generate only say 6,000 or 10,000. So they are least bothered. The NGO sector, which used to be a big provider of services, is on the wane, not only in India but across the world. Post-COVID, I think society is becoming more hedonistic, and people are more interested in ever. There's some kind of a compassion fatigue has come. And so donating to charity and NGOs is coming down, thanks to governments also becoming more stricter on the NGOs, but even otherwise they are on the wane. So we cannot expect them to fill the gap. Corporate social responsibility funding, which is mandated for large hospitals by the government of India, can be tracked in this corporate service. Now, insurance coverage would be one way to fill the gap. Private health insurance companies are still not compliant with the MHCA directive of the rights of the mentally ill to insurance. Both the Ayushman Bharat scheme of the Government of India and the Arogyasri scheme of the Government of Telangana cover a long list of mental illnesses, though de-addiction is excluded, and it also covers ECTs and RTMS, and the amounts are modest but still useful. Unfortunately, both these schemes are applicable to government hospitals only. Expanding this coverage to private psychiatric hospitals would certainly help in filling the viability gap and increasing bed occupancy. We as a society need to work on achieving this goal. Entrepreneurship is needed, and that startup culture need to be brought in even into our young psychiatrists. With people's incomes and their paying capacity rising fast, this should not be a difficult task. And in the cooperative model, groups of psychiatrists can come together and put their energies and resources for faster growth. So, ladies and gentlemen, I have tried to highlight the gross deficits in the delivery of psychiatric services in our state and the challenges that lie ahead. In these challenges also lies an opportunity for the younger generation of psychiatrists to rise up and fulfill the demands of society. In this, we all need to work together and help each other to achieve the dream of a golden Telangana. Thank you. This address would not have been possible without the help and cooperation of a number of people. I am extremely grateful to Dr. M. Uma Shankar, CEO of the MHA, Telangana, my mentors Dr. Chandrasekhar and Dr. Gaurav Devi, and my friend Dr. Ramana Cherupari, all directors of Asha Hospital for their valuable suggestions, inputs and insights. I am also thankful to the trust for his inputs. I would also like to thank the staff and postgraduates of the Department of Psychiatry, Apollo Institute of Medical Sciences and Research for their cooperation and help.
Thank you, madam, for accepting our invitation. I think over to organizers.
Thank you, sir. Now I request Dr. Ram Subbareddy sir to felicitate Dr. Ashok Alichandani sir. We request the organizing chairman, Dr. George Reddy sir and Dr. Uma Shankar sir to onto the desk. We request Dr. Uma Shankar sir
for half an hour, followed by Prashanti Hospital oration by Dr. Pratima Murthy Madam, who is the director of NIMHANS. I request all of you to please finish off your lunch and please come. Madam had travelled all the way from Bangalore for us. I request all of you to come back as soon as possible. Thank you.
Bye.
Dr. K. Chandrasekhar, the senior psychiatrist of Telangana State and alumni of NIMHANS, and IPS Telangana State Branch President Dr. Ashok Alichandani, Dr. Bhagya Reddy, senior psychiatrist of Karimnagar, honoring the Prashanti Hospital Oration Award. And I request Dr. P. Kishan, who is the sponsor of the award, to honor the speaker by wearing the medal to her.
Okay.
Dr. Pratima Murthy, Director and Senior Professor of Psychiatry at NIMHANS, Bangalore, has over 3 decades of experience in mental health and alumnus of Bangalore Medical College. She holds an MD from NIMHANS and Diploma in Psychological Medicine from the University of Manchester. She is a Fellow of the Royal College of Physicians, Glasgow, UK. Dr. Murthy has served as Professor and Head of the Department of Psychiatry at NIMHANS, Head of the Center for Addiction Medicine and Head of the Forensic Psychiatric Services. She received WHO Regional Director's Special Appreciation Award Excellence in Science from Government of Karnataka in 2019. the Marfatia Award and the Tilak Venkora Oration Awards. An international consultant for World Health Organization, she has significantly contributed to public policy in mental health, addiction, and the integration of mental illness with non-communicable and enhancing care in custodial settings. Dr. Murthy has made significant contributions to addiction management, including establishing a toxicology lab, developing workplace interventions, and initiating postgraduate addiction programs. She has guided over 50 postgraduate dissertations and has about 250 peer-reviewed publications. Dr. Pratima Murthy is not only an academician on par excellence, she is also a warm, welcoming personality, loved and respected by students and colleagues alike. Acknowledging and honoring her immense contribution to the field of psychiatry, Indian Psychiatric Society, Telangana State, facilitates Dr. Pratima Murthy with the Prashanti Hospital Oration Award on 22nd June 2024 during the 10th Annual Conference of Indian Psychiatric Society, Telangana State Branch at Nizamabad. It was started in 2015. I request Dr. Co-Chairperson Dr. Umar Shankar to read the background about the Prashanti Hospital Oration.
Good afternoon. The Prashanti Hospital Karimnagar Oration Award instituted by Dr. P. Kishan from Karimnagar by contributing 5 lakh in 2015 on the name of his Prashanti Hospital Karimnagar. Prashanti Hospital Karimnagar is one of the first licensed hospital under Mental Health Care Act 1987, established in Karimnagar district, serving neighboring districts and neighboring states of Maharashtra and Chhattisgarh. Awards committee will select the awardee every year and inform the same to the EC in writing. The Honorary Secretary of IPS TSB will send the official invitation letter to the awardee and a copy of the invitation to the award sponsor or family members of the sponsor in coordination with the organizing committee of TSPSYCON. The awardee will be given gold medal, that is a 50 grams of gold plated silver medal. This is the information. Thank you. Thank you, madam. Please.
Can I have the slides on, please? So, good afternoon, everyone. It's a pleasure to be here today to present the Prashanti Hospital Oration for 2024, for which I thank Dr. Kishan as well as the Indian Psychiatric Society Telangana State Branch. Now, it's a toss-up whether to talk before lunch or after lunch. Both these are risky periods to make a presentation. Before lunch is a problem because everybody is hungry and their only thoughts are about food. But postprandial is another problem because everybody. So whatever it is, we'll try and see how best I can present some thoughts to you on new learnings and old teachings. I also wanted to make a special mention of that I have here today, and it's always a pleasure to come for any Telangana state conference. Of course, to all of those who are alumni, this I'm sure is like adult psychiatry, but also in neurology and neurosurgery. We also have basic science departments which do the research to help us understand the brain and the mind in health and disease. So, both in terms of clinical care, training, postgraduate, extremely proud. And whatever research occurs or whatever understanding or improvement of knowledge occurs, in terms of understanding the brain through gadgets, through various new kinds of interventions, through making sure that they get the most modern medicine, the final reason that we are all there today is for our patients. And therefore, what I'm going to try and do is to try and take you through a journey of all the exciting new learnings that seem to be there, but at the same time, how do we stay rooted in the discipline of psychiatry? And I'm sure for the young people here, that's a very, very important and basic question. And sometimes perhaps this basic tenet gets forgotten because there is so much of an explosion of knowledge and discovery in psychiatry. So we'll look at that aspects. So Henry Ford said, anyone who stops learning is old, whether you're 20 or whether you're 80. It's the greatest thing in life to keep your mind going is learning. So I'm sure that even for those of us who perhaps passed the prime years of practice as a psychiatrist, it's very, very important to stay connected. And you heard the presidential oration where the president mentioned that, with AI, maybe there is some kind of a redundancy that sets in. But the psychiatrist who knows AI will be ahead of somebody who doesn't. So that's the kind of thing that's happening. And therefore, learning is very, very critical to learn, to relearn, to new learn, as well as to unlearn many of the concepts that we thought were the truth, were the gold standards. We need to unlearn several things as well. So what am I going to do? I know it's, in about half an hour, I'm going to try and take you through 13 different sections, very, very briefly. And we'll talk about the newer discoveries and what's very exciting for people, because all of you need to know that in the next 3 or 4 decades of practice of psychiatry, many of these things will possibly become available for you and for use with the patients that you treat. And then I will go back to what are the pitfalls and the precautions proconvulsant. And the moment they produce seizures, the person after a few seizures would improve. But these very, very slow in our country, we know that direct ECTs are prohibited. You have to give modified ECTs. Modified ECTs are safe. Nevertheless, people are looking for other forms of neuromodulation. And all of you know that TDCS, TMS, deep brain stimulation have come up as treatments for a variety of psychiatric as well as neurological disorders. But what is that picture on the left side? This is a picture not too long ago, mild currents which help them to get better, particularly for headaches, for various anxiety as well as chronic pain conditions. So you'll see how neuromodulation has kind of come into our lives in many, many different ways, both from natural forms as well as, even if people can't get technology like TMS and TDCS, they're trying electrical stimulation to get better. So from camphor, cardizole, as well as capsulotomies, which were a thing of the past, psychosurgery was done for people with very resistant, intractable conditions. You now move on to TDCS, which has emerged as a promising treatment, we thought 10 years ago, for conditions like OCD, for schizophrenia, even for depression as well as for substance use disorders. We have approaches like vagal nerve stimulation. In fact, one of my students did a dissertation on vagal nerve stimulation and how it helped to reduce craving, for example. And then deep brain stimulation. In fact, I think there was one of the leading magazines had a whole issue dedicated to deep brain stimulation and other neurosurgical procedures to actually bring about. DBS has now become a very, very important treatment for resistant Parkinson's disease. It's also used in resistant obsessive compulsive disorder. And then the whole idea is that you can modulate the neural network through neurosurgical interventions. It also allows you to understand the various circuitries in the brain and what circuitries need to be locally stimulated. Unlike in ECTs, for example, where you don't have a choice of stimulating a particular circuit, many of these focal interventions allow you to stimulate specific circuits, thereby resulting in benefits without the side effects of the treatment. These are all what we call neuroscience-informed treatments. TDCS is direct cranial stimulation, whereas TMS is basically through the understanding of the nerve circuits where you administer a magnetic stimulation, again shown to be useful in depression, in negative symptoms of schizophrenia, in persons with memory impairment. And we think that in future, for hallucinations, you may be able to apply neuromodulation to specific centers, maybe for delusions, maybe for other symptoms. Of course, the jury is not out on all neuromodulatory treatments. We're not really 100% clear that all of them produce the same kind of results, but certainly they're very promising interventions. So, for example, let's take the example of depression. When you look at the neurobiology of depression, it appears that you may have a hypofunctioning dorsolateral prefrontal cortex, a hyperactive center, and there appears to be an anti-correlation between these two centers when you do a functional MRI. And what you need is to balance out this anti-correlation between the two centers. And that's where, the TMS works in terms of normalizing this hypoactivity in a part of the center of the brain and the hyperactivity in another center. So you can say it corrects the dysregulation or brings about better homeostasis between these two regions, and that is associated with an improvement in depressive disorders. Similarly, when you take the negative symptoms of schizophrenia, again a breakdown in the left dorsolateral prefrontal cortex and the midline cerebellar connectivity appears to be associated with negative symptoms of schizophrenia, and you can correct these by again restoring the balance through transcranial magnetic stimulation, thereby reducing the negative symptoms. Again, very exciting, because we know that many of the pharmacotherapy that we have perhaps doesn't adequately address the negative symptoms of schizophrenia. Similarly, in terms of memory, you'll find that the lateral parietal cortex and the hippocampus complex connectivity modulates the declarative memory. And therefore, when you stimulate specific areas around the left hippocampus for a week, you do show improvements in memory. But remember, these are all preliminary studies. In large-scale studies, these kind of benefits have not yet been demonstrated. Nevertheless, they continue to be very exciting areas of approach in terms of neuromodulation. Now let's take understanding of neurobiology and how it is converted to some treatments. One example is postpartum depression, where you cannot wait 3 weeks till your conventional antidepressants can bring about a change. All of us educate our patients and say, you must be patient. In the first week you may only experience side effects. It's only after 2 weeks that you start experiencing the benefits. But here is a drug like oral allopregnanolone, which has been approved in August by the FDA, and you'll see that it has a much rapid onset of action by acting on GABA A receptors in treating postpartum depression. Others like brexanolone can reduce symptoms of severe depression within 3 days. So in a person where you want recovery to occur fast, there are possibilities of drugs like these. Similarly, in Alzheimer's disease, you have something called lecanemab, which is a monoclonal antibody which might be able to reduce the amyloid in the brain and reduce the decline in cognitive, decline in cognition and functioning. So all of these, so one rapidity of action, one in conditions where you thought were degenerative, where there was no scope for improvement, there are drugs that are coming up to address some of these. But again, it's only the beginning. We do not know how they will pan out. And remember, The same promise was there with, with antipsychotics of the second and third generation. But then you realize that subsequently, though they didn't produce tardive dyskinesia, we now have to deal with metabolic syndromes. The same thing is happening with a lot of other drugs used in respiratory conditions, with antibiotics used in different conditions. That you have to keep watching out for the next several years of use to determine their benefits versus their side effects. The gut-brain axis is one of the most popular notions for every disease under the sun, including psychiatric disorders. The gut microbiota we know are important for psychological processes, for immune processes, and finally even for mental health. A bidirectional communication between the gut and the nervous system, the immune system, and the endocrine system, all of which are interconnected, possibly explains why gut microbiota are important. And we know that they are disrupted in depression, in anxiety, great interest in autism spectrum disorders as well. And we know that this kind of disruption in gut microbiota also affects the serotonin system. And this dysbiosis in turn can lead to inflammation, and chronic inflammation, as we all know, is associated with depression and schizophrenia. And that was really the basis of what we were expecting in terms of post-COVID psychiatric and neuropsychiatric sequelae, that inflammation and its immune disturbances would cause these problems. And that's what makes this whole conceptualization very interesting. So what is the consequence of this explanation is that probiotics, dietary modifications are found useful to improve mental health and reduce risk of depression. Now, talking about going back, yesterday was International Yoga Day, and we all had a very sattvic lunch, and people and the experts in Ayurveda told us what kind of food has to be taken and why. And therefore you see, it's almost like history repeating itself when you go back to describing what kind of diets need to be prescribed for what kind of mental health conditions. And personalized approaches examining the gut-brain axis include interventions on maybe changing the individual's gut microbiota. Now that has both positive consequences in terms of personalized medicine, because you're looking at an individual, but what happens then when the individual is exposed to a variety of other environmental conditions? What does the same gut microbiota do in terms of response to external stimuli is something, again, that is not yet answered. Another very exciting thing is precision psychiatry. So looking at how individuals respond, all of you will remember when drugs for tuberculosis were discovered, you had people who were rapid acetylators and you had people who were slow acetylators. And depending on that, depending on what kind of acetylators they were, their response to medication was also determined by that. Similarly, here too, the aim of precision medicine is to look at genetic background, neurobiological build-up, as well as psychosocial characteristics. So the genomics become very important in precision medicine, neuroimaging, functional MRI, PET to study brain structure and function become very important. Biomarkers become very important because they are blood or neurochemical signatures that can indicate specific treatment conditions and treatment choices. And then you may have tailored medications based on a person's genetic and neurobiological profile. This is a projection for the future, it's not yet there. However, just last week, there is this paper which looks at 6 biological subtypes of depression. It characterizes, depending upon there is a biotype, depending upon which neurochemical is mainly disturbed. There is the symptom profile, which talks about the various kinds of symptoms, the behavioral dysfunction, whether there is executive dysfunction, mood and melancholic dysfunction, threat perception, and cognitive control. And you will see that the last thing is what seems to be the response to the treatment, where escitalopram is likely to work, where sertraline is likely to work, where venlafaxine is likely to work, depending upon the neurobiology of that type of depression. So you may actually have neural correlates of what kind of antidepressant works for what kind of dysfunction of the neural circuits. And then tailor your treatment of the patient based on that. Again, you'll see when there is anxious arousal, when there is anhedonia, when there is threat dysregulation and negative bias, it has been suggested that for this profile, venlafaxine might be a better drug than the other antidepressants. And similarly, it goes on. Psychotherapy may be better with people with certain neurobiotypes and so on. So precision psychiatry may also look at personalized psychotherapy, which meets a person's unique nature and characteristics, their cognitive styles and their life experiences. Predictive analysis may become possible through machine learning and data analytics, and it may help us to predict risk to relapses and help clinicians make informed decisions. It may also help in evolving novel therapeutics targeted at specific mechanisms underlying brain disorders. And of course, all of us want to prevent disease from occurring, and therefore, is there anything that prevents the progression of psychological symptoms to psychiatric disorder is something that we are all looking for in psychiatrists. So that's a hope for the future. So the promise of precision psychiatry is that it may improve the effectiveness of mental health treatments. Most importantly, it may reduce the side effects. All of us as practicing psychiatrists are always worried about what kind of side effects our patients will have and why they discontinue treatment. So if you had targeted pharmacotherapy, you might reduce these side effects. Digital technology has made a revolution. It had started pre-COVID. During COVID, it became so very useful. And after COVID, the use of digital technology has amplified many-fold. One typical example of the use of digital technology is Telemanas. I'm sure all of you know about Telemanas. Just yesterday, the last Union Territory, the Lakshadweep was the final place to come on board for the Telemanas. They inaugurated it yesterday. All you have to do is call 14416. Wherever you are in the country, you can talk to a counselor in the Telemanas cell and get some counseling in your language of preference. So this is something again that has revolutionized care, because you don't have people needing to come to the doctor just through a telephone call. The basic interventions can be provided, and quick referrals for people who have psychotic symptoms, quick referral for people who are suicidal or are behaviorally disturbed can occur within seconds. There are very good stories from Telemanas on how suicides were prevented, on how people got immediate help and saved so much in terms of money and other expenses. At NIMHANS, we've also started the NIMHANS Digital Academy for training, and we have several diploma courses, several certificate courses which can completely be done either online or through hybrid modes. And now we are able to reach out mental health training, not just to healthcare providers, but to people working in prisons, for example, several other kinds of settings. We are able to reach out to people to do digital training because of the technology that we have. AI is also something that we spoke about, and that again might have important applications. Most importantly, we all know, and all of us use mobiles, tablets. Again, the presidential address, the president talked about e-health applications, which are also very important, how you can give e-prescriptions. At NIMHANS, we've been using e-prescriptions in addiction medicine for almost 7 to 8 years now, and we hope to, now we're expanding it because we have a hospital information management system to all the disciplines very soon. So, passive data collection is also possible through various kinds of apps and devices. So, for example, if you want to know how your patient with psychosis is doing at home, whether he's pacing up and down, which might be an indication of a relapse, whether he's engaging in various activities, whether she is, feeling suicidal and agitated, all of these you may be able to capture through GPS-based, devices. We know journaling is a very simple way of patients keeping track of all of these things. Gesture recognition, devices, particularly for kids with autism, how to make them recognize social cues. These are things that are very important. Virtual reality-based, devices have also come in, particularly in the case of, autism. Body movement detection as well as eye tracking. There are companies, again, which are doing eye tracking to see whether you can pick up certain traits endophenotypes for schizophrenia and other disorders. So, digital phenotyping, as I said, is movement to movement kind of capturing of the phenotype in situ from personal data devices. MindLab is something again that we are using in collaboration with the University of Harvard, which talks about learning, assessing, managing and preventing through a smartphone app which captures various physiological data and transmit it to the clinician. There are also ways in which you can use apps to assess cognition, but whether you want to use an app to do it or whether you want to just get people to do the crossword every day, that's again something that we need to decide based on what we have. Neuroinflammation in psychiatry, again I spoke about the immune response and its association with depression, schizophrenia, bipolar mood disorders and anxiety. The fact that cytokines and other neurochemicals may alter immune functioning is also very important. We know that chronic stress is definitely something that leads to disturbances in immune responses and it causes low-level inflammation. Now, conditions like Alzheimer's and Parkinson's, neuroinflammatory explanations for these disorders are also talked about, especially when they have comorbid psychiatric symptoms, and the use therefore of anti-inflammatory agents as adjuncts for psychiatric treatment, use of NSAIDs and so on, and cytokine inhibitors is something that again has got a lot of interest recently, particularly after COVID. While we talk of neurochemicals and neuroscience on the one hand, people are increasingly talking about cultural acceptability of interventions on the other. So there is a much greater emphasis nowadays on cultural difference, on equity of treatment, ethnicity, language, religion and social cultural factors, and therefore being aware and sensitive to the cultural nuances becomes an important necessity in modern day psychiatric practice, and tailoring treatments to that is also very important. So, for example, in our integrative center at NIMHANS, we not only have Ayurveda, we have yoga, we are looking at other Indian forms of treatment as complementary to allopathy and to medicate and to pharmacotherapy. So that's something that is again gaining interest, to have a holistic approach towards both understanding the patient as well as treating the patient. Psychotherapy has not been left behind. Even in psychotherapy, there have been several advances in terms of linking it up with technology, providing distant psychotherapy, emphasis on evidence-based for cognitive behavioral therapy, dialectical behavior therapy, and action-oriented therapies. Again, enhancement of cultural competencies to drive therapies. Mindfulness therapies have become very popular. There has been a shift from long-term therapies to short-term therapies. Trans-diagnostic approaches which look at disease conditions across the board rather than specific disease conditions are important. Internet-based therapies as well as neurocognition-based therapies have become popular. Integrative and eclectic approaches, of course, were always there and continue to be there. The emphasis has become on outcome and measurement. The use of psychedelics. We knew that psychedelic substances were used as models to produce psychosis earlier. Now small doses of psychedelics are being used to cause symptom resolution on the other, particularly for wellness, for cognitive enhancement, as well as for various mental illnesses. Psychedelics are being used. All of us are familiar with ketamine, for example. People are talking about MDMA and psychopharmacology. So think about it. Can you have designer drugs to improve your mood, to improve your personality? People are talking about this in contemporary days. Of course, a whole lot of reliance on self-help is becoming very, very popular. How to look after your mind along with your physical health is something that we're looking at. AI in psychiatry. AI has been used over a wide range of areas, from clinical records. I got that you mentioned that data is the new oil. So it's very, very important to look at AI and how it uses data. from records, from sleep data, from heart rate, from movement, through video and audio captures and so on. Virtual reality again for addictions, for autism and other disorders has been used. Diagnostic approaches finally. You know that people are very dissatisfied with the DSM and the ICD methods of categorical diagnosis. People are looking at RDoC, looking at different domains of functioning. They're looking at HITOC, which is a hierarchical taxonomy of various psychopathology, and they're looking at integrated multidisciplinary approaches to try and understand how symptomatology relates to circuits in the brain and to functioning in the brain, and perhaps finally how community implementation occurs with an understanding of what are the active ingredients based on all the various domains of influence. So finally, in the last part of my presentation, I'm going to talk about pitfalls, precautions and the future. So one important thing is the lack of robust evidence for what I've described so far. Very, very exciting, but still not enough evidence. The availability, affordability and accessibility of some of these interventions, particularly when you talk about equity, it's impossible for these interventions to become equitable at this time. The ethics of using some of these interventions, which might invade privacy, which might make confidential information known to other people, also is very important. Legal issues are very important. The risk of personalized medicine is that it completely neglects the exposome, or what is happening around us, which may have an influence on our psychological processes. That's another problem. People are also talking about digital citizenship, that everybody has a right to various kinds of digital approaches. And we also know that science progresses more from disproofs than from proofs. And therefore, we have to see what is the level of proof that whatever I have described so far in the last 20 minutes actually has supporting it. I go back to old teachings, and for all my young friends here, these perhaps are the most important slides that you will need to remember. And for all the veterans here, I think it is a revalidation of what you taught your students and what continues to be. What are the most important core skills any psychiatrist should have is empathy. Of course, every doctor should have it too, but I think there is a much greater expectation that psychiatrists should have empathy, should be wonderful listeners, should have good communication skills, not good communication skills, great communication skills, should be open-minded and non-judgmental in their attitude, which really gets people to come and talk to you. And that appears to be the difference between other physicians and psychiatrists. Somebody said in 2012, a person called Pauls, forget talking, just fill a script. How modern psychiatry has lost its mind. And I think this is a very, very serious reminder for all of us that it's not about pushing pills or writing scripts. There's more to psychiatry than that. In fact, just today on our alumni group, people were talking about somebody who's been writing that all medication in psychiatry is fraught with difficulties. So while there are polar views like that, there are people talking about anti-psychiatry. If we have to use the benefits of what we have, it's very important to use it very wisely. So we cannot afford to look at everything only through a biomedical lens. That would be very myopic of us. We need to make sure that we simply don't use categorical approaches or a checklist or what's called the Chinese menu approach to making diagnosis. We need to understand the entire context of the individual. We know that there can be overlapping categories. There can be escape categories which don't necessarily have to fit into a psychiatric diagnosis. We must recognize more and more the dimensional or the spectrum approaches, or these kind of problems, and they occur on spectrums rather than as clean categories. And of course, there has been a tendency to over-include and call every disorder of living a psychiatric disorder. And that is something again that we must be careful about. And of course, this person talks about the expanding application of pharmacotherapy to every kind of disorder. Brain science also gets investigated in every kind of disorder. somebody found cerebellar, poor cerebellar functioning, and that gets kind of amplified to every disorder. The same thing happens with pharmacotherapy also, that you kind of tend to use it much more than it's intended to use. And that's a warning that is given in this particular article. I mentioned some qualities, but there are others apart from great communication skills and empathy and compassion. The third and the most important thing is trustworthiness. People will only come to psychiatrists and mental health care professionals if they believe that their confidentiality is protected, that they can completely be trusting of the profession, and that's very important. Flexibility in trying to understand the patient and not being dogmatic in your approaches is very important. The ability to maintain uncertainties is much more relevant to people practicing psychiatry. The ability to deal with difficult emotions, we all know that, and that's something that you have to learn to handle, because you will get a variety of patients. It's like language. It is much easier to learn the patient's language rather than expect the patient to talk your language. It's the same thing about the mind and the person's behavior, that you have to learn to understand and approach a variety of patients, a broader understanding of disease, and of course, the continuing knowledge and competence. And that is why it is very important to have listened to the first 20 minutes. Because whatever it is that improves your knowledge is going to be very relevant to your patients, whether it is in terms of applying it or telling the patient the current status of these treatments. For both these things, you need to be very well informed and be continuous learners. Finally, I want to go back to a 1961 article. Most of you would not have been born then. Maybe I wasn't born then too. The objectives of teachers in psychiatry, Romano writes and says, encouraging the students' curiosity to foster the capacity for critical thinking. So those of you who are young teachers, remember that's very, very important. You must understand the sequence of growth and decline in society and pay attention to all determinants, from genetic to environmental determinants. You must apply modern views of multiple causes and effects rather than expecting a unitary kind of explanation for everything. You must understand that mood states, emotions, etc. are generally dynamic in nature. Although the person may have a specific thermostat, the responsibility to external stimuli determines how a person responds to stress. And you also need to understand the unique reciprocal relationship between the patient and the doctor. And in psychiatry, the psychiatrist also has reciprocal relationships with many other colleagues, whether it's a clinical psychologist, a psychiatric social worker, a psychiatric nurse, and so on. And of course, understanding psychology, sociology, and perhaps a whole lot of other logies in trying to understand the entire spectrum of the patient's care. Now, this is a very, very interesting set of characteristics that Nirmala Srinivasan, who is a patient caregiver group, she started this thing called Amend and Face Me subsequently. There's an article she's written in the Indian Journal of Psychiatry in 2015 saying what are families' expectations of a psychiatrist. So what do families look for? They look for, and this makes a psychiatrist possibly, possibly close to divinity, because it's just impossible to expect all this. But it's important to know what patients expect of a psychiatrist. The zeal and stamina to be alert during the consultation, how they are in appearance, to be properly dressed, to be warm and make the patient comfortable, to be pleasant in an emergency, accessible to the patient at various times, preference for the same gender is something that they've talked about, listening with a keen ear, what I spoke about, communicating with ease, something I mentioned, you having good body language so that the person feels welcomed. Trustworthiness is something that I described from a psychiatrist. The same thing the family member says. Polite but firm in giving advice. Showing leadership skills, particularly when a family is lost or confused. Having the ability to be a team player. Taking the family together in a collaborative relationship. Being open-minded and respecting the caregivers and the patient's right to information about treatments. And the personality of the psychiatrist. So people are constantly judging us, whether we like it or not. The fact that whether we remain unruffled in times of crisis, whether we have an air of competence, whether we are mature in the way we behave, whether sometimes we are rude and abrasive, or we are assertive, whether we are intuitive, whether we are compassionate and caring, whether we are positive and optimistic, whether we demonstrate genuine respect for the patient, and whether we are open-minded to tell people and offer logical explanations. Now, seems like a long list, but actually a lot of this is written about doctors as well. So it's a little bit more than what is expected of all doctors, but sometimes it just appears a bit superhuman at times. And of course, various kinds of professional expertise, which again is something that we've talked about. So we need to know what kind of expectations our patients and their family members have. If we expect that they will develop this trust in us and come back to us for continued, care. I'll end with a couple of sayings. One is that psychiatry is a strange field because unlike any other field of medicine, you never really finish. Somewhere along the line, while you're trying to understand patients and their psychopathology, you're probably working with yourself to make yourself more mature, more competent, more meeting all of those expectations. And, we all still are learning on the job, which keeps us young. And secondly, what Viktor Frankl said, a sound philosophy of life, I think, may be the most valuable asset for a psychiatrist when he or she is treating a patient. And I think that's the worldview that makes us different from other practitioners of medicine, to also have all this knowledge about neurobiology, circuitry, intelligence, applications of technology, but at the same time to be grounded in this philosophy is what makes a whole psychiatrist. Lastly, when we look ahead, perhaps we need to have a developmental approach in the way we understand children, adults, people in old age. We of course need to know about neurocircuitry, psychopathology and targeted interventions. There will be a continued search for better tools and better approaches. Our approaches will turn to prevention and health promotion rather than just the treatment of disease. So we need to work with other colleagues. We may not have the appetite or the ability to do all of that, but we need to work with others. And finally, a multidisciplinary, multi-technology and a bridged understanding of the brain and mind. More and more the brain and the mind are getting closer. We tend to compartmentalize them as very, very different things. So looking at it in an integrated manner is very important. And finally, one value that all of us perhaps needs to keep forever is the value of humanism, which will definitely make us not just better psychiatrists, but better human beings. Good luck with all that you do, and thank you very much.
Thank you very much, madam. Madam has shared a long experience, wisdom of almost 35 years in the psychiatry, and she talked about learning, unlearning, various dimensions of these things, and gave good inputs for all the young psychiatrists, how to be a good psychiatrist. I think there's a lot of benefit to all the young psychiatrists and in turn to the patients, our own patients. Thank you very much, madam. There won't be any question and answers at the end of oration, so we thank the speaker for sharing us so much wisdom with us. Thank you.
We now request Dr. Gangaram sir, past treasurer, IPS South Zone, Dr. K.K. Lakshman sir, President, Karimnagar Psychiatric Society, and Dr. Vishal sir, Organizing Secretary, TSPSYCON-2024, to felicitate the speaker and the chairpersons.
Sir, close. Ready, sir?
Now Dr. Vishal sir will felicitate Madam with the
One minute. Come to me immediately. Sir, Madala Ran, sir. Idhar. Okay, ready, sir? Okay. Done. Thank you.
Now we have Asha Hospital Oration Award. For that, I would like to invite the chairpersons onto the dais, Dr. K. Chandrasekhar sir and Dr. Sridhar Raju sir. Dr. K. Chandrasekhar sir is the founder, director and currently managing director of Asha Hospital, Hyderabad. He has been in clinical practice for the last 42 years, teacher for DNB Psychiatry since 2006. His special areas of interest include neuropsychiatry, geriatric psychiatry and mental health legislation. He is also the past president of IPS AP chapter and IBS South. We welcome you, sir. Dr. Sridhar Raju sir is the consultant psychiatrist and director of Samalochana Kendram, the first psychiatric hospital started in Telangana in 1995-96. He got his MBBS from Kakatiya Medical College, Warangal, DPM from Osmania IMH, Hyderabad. He is also the Secretary General of Indian Medical Association, Warangal branch, President Indian Medical Association, Warangal branch in 2014, and President Indian Psychiatric Association, Indian Psychiatric Society, Telangana in 2018. Sir was also the pioneer president of Indian Association of Private Psychiatry, Telangana, and the proprietor director of Prata Productions. Dr. Sridhar has also participated in different agitations and organizations, including the Telangana agitation Gandhi to Gandhi Path Yatra, from Gandhi Hospital, Warangal to Gandhi Hospital, Secunderabad. His first movie is Mera Bharat Mahan, Telangana 2019 release, and his social awareness short films were on alcohol addiction, alcohol suicidal behavior, Stone, You and Me, tobacco awareness film, COVID-19, etc., COVID-19 awareness films. We welcome you, sir.
At the outset, I thank the organizing committee for having given me the opportunity to chair this Asha Hospital Oration session for two reasons. The recipient is a good friend of mine whom I was associated for several years, seen him in several forums, and is basically from a clinician how one can develop into a very astute academician and also an organizational inspiration. That is what Dr. Kishan is, and I am very pleased. The second reason is that being the founder director of the Asha Hospital, I feel that this year's oration has gone to a really worthy recipient. With this, I invite Dr. Kishan to come out to the class.
We invite Dr. Ashok Chandani sir, we invite Dr. George Reddy sir, Vishal sir, Dr. Bhagya Reddy sir, Dr. K.K. Lakshman sir. I request the State Branch to permit all alumni members and sir students to join for felicitation of sir. I request all KPS members and students of Kishan sir to please come near the stage.
Sir.
I request all students to please come. I request TSS also to please come, sir.
iPhone కింద పడితే బాగా ఓకే రెడీ సార్ మీకోసం వెయిట్ చేస్తాను ఓకే ఇట్స్ ఎ క్యాన్సర్ వేసిన ఫోటో వేస్ట్
Dr. P. Kishan was born on July 1st, 1962 in the Mogilicherla village of Warangal district, Telangana. He received his MBBS degree from Kakatiya Medical College,
Ready,
Warangal, and MD in Psychiatry at Usmania Medical College, Hyderabad. He is presently working as Professor and Head, Department of Psychiatry, Pratima Institute of Medical Sciences, Karimnagar. He started his private practice in Prashanti Hospital at Karimnagar, which is one of the first licensed psychiatric nursing homes under the Central Mental Health Act outside Hyderabad. Prashanti Hospital is having 73,000 patients follow-up data, which is the highest in Telangana state. He is the founder and instrumental in instituting awards like Prashanti Hospital Oration Award, Shadavana Award for Best PG Paper in South Zone IPS, Dr. P. Raghuram Reddy Oration Award, Dr. P. Raghuram Reddy Award for Best Published Research Paper, and Dr. P. Raghuram Reddy Award for Best Research Protocol. Dr. Shekhar Reddy Oration Award in Pathology, Porandla Kailasam Memorial Award. He is one of the members to prepare the constitutions of IMA Karimnagar, Karimnagar Psychiatric Society, IPS Telangana State Branch, Kakatiya Medical College Alumni Association, ZPHS Mogilicherla Alumni Association. He received several awards and honors given by government and non-governmental agencies like Indian Medical Association, NATCOM Oration Award at Nellore in 2014, Dr. Masudan Joshi Annual Psychiatry Update Endowment Oration Award in 2021, IMA National President Award for editorial work of Telangana Journal of IMA, Adhyatmika Seva Vibhushan by IMA Nizamabad in 2020, Best President of Branch Award IMA Karimnagar Branch in 2016, Best Zone Award of Indian Psychiatric Society as South Zone President in 2019. He guided many postgraduate students, was a guide for 19 theses, awarded MD degree to 19 postgraduate students as head of the department till date. As an author, he published 15 publications in indexed journals and written book chapters and presented several papers and symposiums at national and international conferences on his special interests of spirituality, yoga, psychotherapy and preventive psychiatry, for which he visited 25 countries till now. His extensive knowledge on spirituality and its practical applications to the current situations and words of wisdom has transformed many people. He paved a way for future generations in the field of medicine and psychiatry as a teacher and as a guide with his immense contribution. Dr. P. Kishan has held many prestigious positions in the World Psychiatric Association, Indian Psychiatric Society, Indian Medical Association Karimnagar Psychiatric Society. He is a member of various organizations internationally and nationally. He had organized CME programs and conferences at state level, zonal level, national level and international level at various capacities. He is organizing chairperson for the annual national conference of Indian Psychiatric Society 2025 to be held in Hyderabad in January 2025 at HICC Hyderabad. Indian Psychiatric Society Telangana State Branch is delighted to present the prestigious Asha Hospital Oration Award to a person who is always ready to serve the society and share his wisdom to the younger generations selflessly. This was awarded to Dr. P. Kishan on 22nd June 2024 during the 10th Annual Conference of Indian Psychiatric Society, Telangana State Branch, Nizamabad.
I thank organizers for giving me this opportunity to introduce Asha Hospital Oration Award. This award is instituted by Asha Hospital Hyderabad by contributing 5 lakhs in 2015, and the name of Asha Hospital Hyderabad. Asha Hospital Hyderabad is one of the first licensed corporate psychiatric hospital under Mental Health Act 1987, established in Hyderabad, serving Hyderabad and districts of Telangana, Andhra Pradesh and neighboring states. Asha Hospital is running Asha Jyoti Rehabilitation Center, Asha De-Addiction Center along with DNV course and fellowship courses in child psychiatry, etc. Awards committee will select the awardee every year and inform the same to EC in writing. The Honorary Secretary of IPS TSP will send the official invitation letter to the awardee and a copy of the invitation to the award sponsor in coordination with organizing committee of TSPSYCON. The awardee will be given gold medal, 50 grams gold plated silver medal. Thank you.
Good evening, everybody. First of all, thank you very much for Indian Psychiatric Society Telangana State Branch, the executive and leaders of the Telangana State Branch. And thank you very much to the Asha Hospital for founding this oration. When Dr. Chandrasekhar was the MD of Asha Hospital, he contributed 5 lakhs. Because we have done the foundation work of the Telangana State Branch Foundation. With all guidance from Chandrasekhar sir and Raghuram Reddy, we prepared all the things. Thanks to both chairpersons. Both are very close to my heart. Always, Raghuram Reddy groomed me directly as a teacher, and whatever the problem, Dharma Sandhya, anything comes to my mind, I will give a call to Chandrasekhar sir. Always responds very lovely, and in my growth, the sir contribution is a lot. And the sir specialty is I think during the AP conference, he attends all state conferences. He will be there almost till the end of the validation function. So this everybody should learn as a leader, a silent leader, and he is always very silent and wise person. Thank you very much, sir, for chairing this session. And again, one more dynamic chairperson, that is Dr. Sridhar Raju. He is the person after Gopal Sharma left the Warangal. He is the senior most person in that area. So he is also a person to maintaining the database in his own hospital. He maintains every patient's record. I think Asha Hospital also, there is some errors there. Now not 73,000 patients, it's 78,000 patients. Today I am presenting them. So Asha Hospital and IMH alumni, IMH also having a lot of big data. this is the data for the individual doctor database, but there is a group. The Ashas will have a lot of data and very big data, and as well as IMH Hyderabad. So I think even that Caesar Raju is a almost senior psychiatrist from the Warangal and other surrounding districts. He expressed his insights. I am expressing my insights in this oration. He expressed his insights through society involvement. Everybody has seen his biodata, and through movies. And thank you, and it's my proud to be a younger brother in my IPS. And coming to why I am presenting this, I selected this topic. Why I selected this topic? To share my experience to all, especially postgraduates, because I learned a lot of things during postgraduate period only. Immediately after MD, I started my practice. First at Kukatpalli, migrated within 4 months to Karimnagar. So I have visited Annaram Subbareddy Hospital, IS, even Rajamandri Mansa Hospital, and the first hospital by DS Raju at Vizag. I visited IMH Hyderabad, IMH Vizag, and IMH Madras. During post-graduation, if you are having some idea about this, I think we will plan in that way. That is one thing that young psychiatrists has to be. A lot of young psychiatrists coming every month, every year, 100 psychiatrists are coming. So better to have a database. I am having the first patient of data hard copy with me, and I am getting first year of my patient till now under follow-up. She well married and having children and all the things. So this is a wonderful enjoyment. If you cannot go to burnout, you will enjoy every patient, and if follow up during the whole course of your life, they will come to it. So not only they, their family members also come. So the database maintenance is very important. There is a message, and at the same time, one more, my selfishness is to encourage the research, because I understood the research is very necessary after going throughout the world. I visited 25 districts in the world. The research, because we are most respected country, but as an individual, they question our database. What doctor, what you are talking, where is your database? So we have to develop the database. And this is one thing. And there is a private psychiatrist should maintain the data. It will be helpful for your practice. And we should license the private medical college and IMH Hyderabad. We license, a lot of insights will come, and probably it will be just now I discussed with Uma Shekhar. This database has to be analyzed, and it will throw a lot of light for future generations. And with this few remarks about my topic, and what is the necessity of database? Always have a hard copy of record, and how to record the database, especially in private practice, because I am a private practitioner. Of course, I am also teaching. Always have a hard copy of record, which is as simple as possible. It may have your own style, but follow the Mayer-Gross format. We should spend some budget to maintain the hard copies, as well as digitalization of it, and by using software. There are a lot of softwares available, and you have to maintain that hard copy without any. There are a lot of changes. Rainy season, you have to protect the data, especially hard copies, as well as the digitalization is available. So even though you cannot believe this hard disk and software, there are 3-4 software companies surround me. The three left without address. So ultimately, again, we have to upload our data to the software. Now, present software is very good. I don't want to promote it in this forum. But digitalization and other software, there are a lot of software available in the market. I will guide you if any answers coming, approach me. Separate staff maintenance also necessary, like Jilani. Everybody knows Jilani here after IMH. So you do that. I am having a lot, 2-3 Jilanis in my hospitals. When I am talking, I will see the record. Within 2 minutes, we can put the record on my table. So that is how each file is having 100 copies, hard copies. So he knows immediately go and get the record. That is the advantage. So you have to have a separate staff maintenance for record keeping, as well as digitalization. It is useful to approach and record the data in a systematic and scientific way, by which will minimize the diagnostic errors. If you go systematically, you will not diagnose. If you don't record, okay, listening you will have to debate. Unless you write, you will not reach a proper acute diagnosis. That also helps and minimize the diagnostic errors, allows comprehensive treatment planning, where I see the picture at one time with the treatment plan will be different. It is useful to maintain the privacy of the patient. If you write, so I have seen some divorces. My colleague psychiatrist, somebody has written schizophrenia, and he explained how the schizophrenia comes, how it runs in the families, that they want to divorce, and the patient for follow-up, she came to me. So if you write something, there things will happen like that. So it will maintain I will give only register number, I will not give any detail. So register number will guard. So this will maintain the privacy of the patient and decrease the legal problems and facilitates the follow-up, the course of illness. So second episode, third episode, you can record in the short form how the course of illness is moving, whether from neuro disorder to mood disorder to psychotic disorders, even reverse also I have seen because of the fallacies in the diagnosis process and data given by the family members. It is helpful when the patient lost their records. No, some people will come, sir, but patient 20 years, he visited all psychiatrists, so he will not have data. But when the patient lost the data, when you return the data, you can immediately open by surname, you can open the data, by name of the patient you can from village also, if you give a keyword, you can open the data of the patient, and the total data of the patient, which we can save time, it saves the time, and otherwise you have to take again detailed history. It increases the patient's confidence on us, as well as it increases the confidence on the institute. Maybe Asha, they will have records. So IMH is having a record. So that is it increases the confidence on not only on doctor and the institute also. So the database will be a source to classify the grouping. I have 350 groups of research. I'll show that later. You can group you can classify according to ICD-10 and DSM, and you can have your own grouping for your own target insights to hypothesis to separate group. For your own requirement of research, following the standard case-taking formats, classificator system, which will be helpful to the future churning of the database to fulfill the requirement of research. This will improve the therapeutic relationship, improves the trust of the patient, helpful in controlling the course of illness by various pharmacological, non-pharmacological interventions, which will, because I started my wellness clinics at the third decade of my practice. Because after insights, there are some different methodologies for non-pharmacological interventions. So, along with the course of the patient, you will grow, you will change your methodologies, how to intervention, how to prevent the further episodes, how to improve the quality of food, how to improve the prognosis of also this database will help us. And it will prevent the burnout. Somebody will come, doctor, 20 years से आ रहे पेशेंट, क्या कर रहे, उसका बीमारी क्या है, वो पागल है मैं मालूम है, मगर उसको बीमारी क्या है बोलते हैं. So please sit down, offer a seat, then you open the record, you tell from first day to 20 years duration. So what has happened, what are the complaints, the patient will salute you, and automatically he scores the attendance, you are not regular, you should be regular, some village leader will come and so these are all the problems they convince about us. So that is the way helpful for the database. So have a comfortable. Now I am opening just 1 month back I requested my software provider to give my master sheet of the database. And he provided me now 98,000 patient database is there, it's a 78, and he provided me, so he provided me 76,000 patients master sheet. There are 2-3 master sheets he provided. ICD classification is different, as well as my own groups are different, and 350 groups are there for research, as well as even my different data sheets of individual groups also is provided. This is the master sheet.
next month.
Otherwise, I can skip this. This consists the number complete number 76,000 plus patients. Is it possible? So here, before opening the data sheet, this is the data sheet he provided. So I think this match can. So we go on. So you can go through so you can get width and length, you can go to the data and so here before starting presentation from this data, there are 3-4 points I want to mention. The first phase of the presentation is what are the groups available according to ICD-10. Go back to the presentation. Enough. Go back to the presentation. So the first stage of presentation is analyzing the different groups according to ICD-10. So what is out of 76,000 patients? So how the data is there? Individual groups, the 10 groups of ICD-10. Then the second phase, I am having over 350 groups of patients, research groups. I write on the hard copy. This is a family study. This is a sibling study. This is a twin study. So they, my assistant will separate person is there. They update in twins group that will be attached to the twins group study. So if you can have only twins group patients. So like that, the grouping was done. So I am having a lot of 350 groups. That is the second part of the presentation. The third part of presentation is my postgraduates and my youngsters are involved in the publications. So that's the third part. Fourth part, I express my own insights in my own publications, which are mostly spiritual and yoga and other things, because that is the base of my wellness clinic. So coming to the first part, so organic cases, around 2,000 patients of organic patients are there. So the second group are, most of the, here I have shown the first slide is that only delirium, depression and other things, but other all I see first group disorders are there with me, which I don't want to show because I want to cover so much matter here. So second group is psychoactive source. Total patients are 6,000 patients. In psychoactive, most of them are alcoholics. There are 104 female alcoholics are there. The female alcoholic group is there. The 14 cannabis now is rising. Now recently it is rising in Telangana. Nicotine, most of them are alcoholics, are both having nicotine and opioid also. This is schizophrenia. Third group is schizophrenia and other psychotic disorders are 15,000 patients. Schizophrenia and all psychotic disorders, whole group is 15,000 patients, around 16,000 patients are there. Out of 16,000, around 10,000, 9,636 are schizophrenics. Schizophrenic disorders are around more than 2,000. Acute psychotic episodes are more than 2,000. And delusion disorders and schizotypal, schizophrenia form and other NOS. So, coming to mood disorders, 36,000 patients are mood disorders. I don't know whether the database has to be analyzed, whether it is going with other epidemiological studies, other studies. So here the mania patients, around 3,000 patients of mania first episode. And all the diagnosis, what I consider is the first entry diagnosis. After that, the diagnosis that was included here. So hypomanias and other things. Then depressions. Out of this, all mood disorders, 32,000 patients are mood disorders. Out of them, I am having separate analysis of how depressions are. Then recurrent depressive disorders, cyclothymia, dysthymia, mixed affective disorders, seasonal psychosis, seasonal depressive disorders. So in the depression, 32,000 with somatic features, most of them are psychotic features with bipolar tendency. I am having my own way of ICD and DSM hybrid diagnosis, which I learned from Dr. Ramarao Varangal. So he gave his own diagnosis. Neither it is in ICD or other, but he is one of the successful psychiatrists and a good person who writes very nice notes, like Dr. Chennan. He writes at least if you are not meaning that, if you write the symptoms and differential diagnosis, wonderful, that I learned from Dr. Ramarao. So somatic is somatic with psychotic, with bipolar tendency, with depression with transient positive disorders, attacks, declaration sexual, secondary sexual arousal disorder, predominant anxiety, panic attacks, with depression with panic attack, migraine headache, depression with convulsion symptoms, depression with hypochondriac preoccupation. My therapy intervention, the choosing of drug of depression, antidepressant is different with different categories. So depression with atypical features, with catatonic features, early psychotic features, obsessive rumination. I go for sertraline. I don't know my weakness. Immediately in the bracket I write, this is for sertraline. Depression with obsessive rumination, usually which was published by Dr. Sanjay. Then it's homosexuality. There are female homosexuals also there here. Sexual arousal disaster 3000. Lot of morbidity here. Then insomnia patients, more than 5000 patients only insomnia they come. Sleep disorder, sleepwalking, and excess sexual drive. Excess sexual drive, eating. This is the sixth group of disorders. So here, excess sexual drive, eating of non-nutritious substances, sexual phobia and aversion, female, even male sexual aversion, female, males 12 and female 8 sex before and now, first 1 month of marriage. The hypersomnia, premenstrual tension, 120 patients, behavioral disturbances, antepartum onset, chorea gravidarum, 16 patients, very good group of patients are there, chorea gravidarum. There is a chorea during the pregnancy, sometimes there is streptococcal or with history of pyrexia, without history of pyrexia also. Postpartum psychosis, postpartum depression, postpartum mania. So there are, then the personality disorders, the seventh group. There are more than 500 patients are having personality disorders. In this category, all paranoid traditional personality disorder with epileptic personality. So many patients are epileptic. Dr. Gopinath has done and wonderful thesis on epilepsy and its consequences. So I have gone through this whole thesis during my post studies. The epileptic personality is separate, and I included that category here. So group 4, group 8, that is mental retardation. There are more than 2,000 to 3,000 patients are mentally retarded, and with OCD, without behavior problem, with behavior problem, with psychosis, with OCD features, with bipolarity, with epilepsy, with cerebral palsy, where we can extract the chart of that particular patient from the data. So coming to the childhood disorders, both 9th and 10th, enuresis patients, here the female and male enuresis. I got a patient of 50 years enuresis. When he brought his daughter for enuresis treatment, because getting married problem, after marriage, son-in-law complained. After treating, after third day he came to me, sir, I'm also having the same problem. So this type of insight, wonderful experience we get. I think that Senshaker knows much more with this type of cases. Psychosis, childhood onset, depression, childhood onset, mania. Most of in my insight, the depression, childhood onset, I will ask whether this fellow is having enuresis in childhood. Sir, 7 ఏళ్ళ వరకు పోసాడు సార్, 9 ఏళ్ళ వరకు పోసాడు సార్ అని చెప్తారు. But they don't come for enuresis treatment, they come for depression. When we are treating depression, if you try to ask the history of enuresis in all childhood depressions. And that depression will present as sometimes agitation, we think about ADHD or something. So if you ask this enuresis is present, usually it goes to the depression. And Freud told that they are weeping through the bladder. So OCD, childhood with OCD, ADHD, autism and Tourette disorders, stammering, stuttering, conduct disorders, speech language, and scholastic problem, regressive syndromes, and sibling rivalry. So here one more group I added along with ICD-10, senile onset, psychosis, senile onset, depression, senile onset, mania, senile onset, OCD, senile onset, phobic disorders also senile onset. So these are the additional thing I added to ICD here. So as a separate group, I am having that data. Coming to the special groups, there are 350 special groups, but I think my children helped us, at least helped me that around 250 to 80 groups are given here. Firstly, I will go through it. This alcoholic anonymous group, abnormal movements group, there are abnormal movements with psychiatric problems, abnormal sex group, there are a lot of, if you go to the family, it's like a booth katha, it's like that. Or attend that 80 problems, I cannot tell anything. It is like that. So, abroad group, adopted son group, the adopted children, there is a separate group, adult analysis group, and what just now I told, drug allergy groups, lot of drug allergies. I show the slide of drug allergy group. Only few slides I am showing from these two groups. Only I think 15 slides I am sharing these groups. So because I cannot share everything. That asthma group, atypical symptoms group, we have a lot of them, sometimes atypical features in depression, atypical features. When we will have depression diagnosis when the bachelor's group, they don't marry throughout life, they are a separate group and they have separate problems identified. Behavioral therapy, aversion therapy group is separate, how many therapies are given, how many coming to follow up, how many revisions. Wellness group, personality disorders, wellness group, neurotic disorder, wellness group, psychosis. These are after 12 years data is there. Blind group, total blind and single eye, and in the born blind, different analysis is there. In the Bombay group, a lot of people settled in Bombay and beyond also there. Wellness group, bipolar, behavioral therapy, relaxation therapy group is separate because I started every Thursday I should do relaxation therapies for neurotic disorders since beginning. But I am not able to find a therapy for bipolar, mood disorders, schizophrenia. That was the mission. I have gone to so many places in abroad. I learned all yoga, all these therapies. I am being a member of Caucus member of spirituality, Caucus member of complementary alternative medicine of APA. I learned so many things from USA. They respect India a lot. But here I learned a lot of things from abroad. Then even Tao therapy in WPA Egypt. I learned a Tao therapy from Buddhist ways. So with these insights, Raghuram is always there. Is the Bible for us. He was not satisfied with the psychodynamics. Chandan used to tell that Sir was a master in psychodynamics, but he shifted to TAT. Because I am doing the therapies, I am not successful in behavioral therapy. So something to be done, something more, some insights I have got from the world, then I prepared these books. So coming to the consanguineous marriage group, religious conversion, there are a lot of conversions. What is the analysis? I am having my own analysis, but I am not going to publish it, but to the understanding. Couple group, creative group, a lot of creativity. Some patients are very creative. Bipolar creativity, there is a book, Soul in the Brain by Michael Trimble. How to the creativity of psychosis, creative bipolar. Cyclotherapy group, deaf and dumb group, completely senile deafness with age, deafness group is separate. Deaf and dumb group is separate. Delayed marriage group, Delhi group, there are other depot preparations group, district legal service. I served the district legal service for 3-4 terms. Then they referred the patients for counseling. There's a separate group is there, divorce group, doctors' families group, and medicals group also there. The Dubai group, UAE group is there because some patients migrating and coming. And dysthymia group, our management plans are different. They are coming and going abroad. Now, dysthymia group, abnormal ear, ectodermal anomalies, I recorded everything. They are changing the form. Some ears, 1 year abnormality, both ear abnormality, and even palm and sole abnormalities groups are there. So, some people are early there. Within 3 months, patient become normal. After 2 years, he will come. So, only 3 months, so what is the background of this patient? Why these patients are becoming normal? We think that once episode, 3 years will go on, 3 to 4 years. But some patients, some families, we are in musicians and arts. That people getting psychosis. I see the patients like మీరు ఏం చేస్తారంటే మేము ఈ కథలు చెప్తాం సార్, మేము పాటలు పాడతాం సార్, మేము the voice, the sonai voice, the family. That families are getting a lot of response. That has to be studied. It's only the group I have done that group only. Early marriage group, early marriage having different problems. Early drugs of the economic sudden fall of economics. Ectodermal anomaly groups, epilepsy group, expiry group is there. Some patients' attendants will come, sir, my thoughts chanpayad, sir, so immediately I will open the family study. Then what is the reason of expiry? How he expired? What is the reason? who is reporting, what is the relation of reporting. So this can be analyzed at almost 40 patients. I will tell that I am having a slide for the presentation. Eye abnormalities group that comes under ectodermal. The Canada group, Africa group also there, ESA group also there, NRIs. Then female alcohol group. I think I will give something. Here, transgenerational. Yeah, this is transgenerational course of illness. Because 3 families, 3 generations of patients are there here. So when the mother is taking, Amma is also my patient and the girl patient. There are a lot of patients are there. How the course of illness is going through generations. It's called transgenerational course of illness group is there. These are all the future potential groups to do research. And female alcohol group is separate. Fruit of LAD because long-acting Sun Pharma stopped when patient is available. There are neurotic patients after therapy also they are continuing weekly 1 capsule. And some people are taking monthly 1. I don't know how they are responding, but they are okay. Folate 2 group, folate trio, folate tetra. These are different group is there. Intercaste group and love marriage, free treatment group because of NGO, B1D group. Full moon, there is a link between the moon, full moon, Amasya group, Paurnami group, Ashtami Navami group also there. Because my OP is very busy on that day. Then I will see the calendar. This is a thing. Probably, I don't know what is Punnamina. You see the Punnamina movie of Chiranjeevi, you will understand what is the link between this. So grief, then grief group, the grief patients, animal dies, full-blown pathological grief is there. No, I have seen in even lower socioeconomic patients. Gutka group, voluntary, Vidhivanchita group. Patient is good, family is good, the time is not because of the incidents happen in the time that male group is there, female group is also there. The house visit, separate groups are there. Homosexual group, then hypertension, diabetes because hypertension, diabetes first after 10 years they develop hypertension. Irregular treatment will have generally they will enter to hypertension and diabetes. I don't know because of anxiety. They are producing this non-communicable disease. Hypothyroid, IBS group, intercaste, Nepal group, because a lot of Gorkhas are having different groups, they always the way come from cotton root. Asthma group, increased libidinal problems, living I will close because the Maharashtra group is also there. Migraine, marital problems, medical group, MLC group, MLC. I write MLC because litigant talk, always I put in the bracket MLC. You be careful with that patient, always that record will be there. During discharge they will do some problems. So if you MR group, nasal allergy, lot of nasal allergies are decreasing, I will show that paper. Then occupational therapy, organic, orphans group, parent and child. Father is also taking treatment, mother is also children also taking treatment. Phenomenology group, I am having 2 slides on vertigo, giddiness. Most of them I have seen phobia and OCD. I am having my own explanation and other that my mind is not working in OCD. Sir, my mind is definitely intelligent. It is intrusive, it is against me. Sir, my mind is definitely intelligent. I have written as a phenomenology. My patient is telling my mind is not listening. So I grouped it, I presented in ABA and it is the psychogenic vomiting group, psychometry, how many psychometries I have done. So what are it is very useful or not? What are the diagnosis? My diagnosis and psychometry, how it has helped me. Remarriage group, the RMPs, a lot of RMPs have personality problems, I am having that group. So here, yoga, widow group, the young widows are different problems. I will skip this now going to the east slide. Alcoholics, anonymous group, then adoption and twin study, adopted children, siblings and twins. I am having 130 twins are there. So these twins can be compared to the siblings and adopted children. So this is a big group, as can be analyzed, we can have a wonderful thing. I think with this big database, I am able to have this type of patients. Brufen, allergy, the drug allergy group, paracetamol, Tegretol. SJ syndrome, every year I am getting one SJ syndrome because I am the highest Tegretol writer. I don't know, company tells me because my weakness to carbamazepine. Now it is available as this other drug. So because most of them valparin side effects, I will shift to the carbamazepine. I am happy with that. I will put a black box warning. If you have to report if any itching, a skin rash, you report. I write the name of the person, responsible person. Generally they will come. And never, no deaths have happened till now, irrespective of the almost 20 cases of SJ syndrome. Skin allergies and wellness group. Mood disorders group is there. Wellness, last 2 years, 12 years experience. Psychosis, I will be using Gayatri. I will show the publication. And relaxation therapy, all behavioral therapy, relaxation therapy, aversion therapies, and Jacobson's, all these will come. Couple study group, because first husband comes, next wife comes. So that's why this is the first, these males are, because they males came, for husbands came, then after wife. First wife came, then husband. Who is affecting who is the last? Deaf and dumb group, only deafness group, and blind group. These are comes under the behavioral disturbance due to sensory deprivation. So how the sensory deprivation? The phenomenon is different in blind group, phenomenon is different in deafness group. So marital status study group, diverse group is different, living separate is different. Ear group, ectodermal, other anomalies like six finger, other palm and so, creases stages. Then parent-child study. So one of the parent as well as the children. Phenomenology research group. The giddiness is a symptom. I separated the group because I am seeing this patient giddiness comes with the most of the phobic disorders are OCD spectrum disorders. Probably the phobic disorder, my insight is this. The lizard is somewhere on the wall. This phobia, giddiness is related to the vestibulocochlear now. The movement and balance. This is the visual, somewhere I learned from two research papers on that. The picture of the lizard is moving towards you as if you are moving. So thought is coming to you. The image is coming to you. Spatial movement of thought is there in the OCD patient. Spatial movement of lizard, spatial movement of something, as if it is coming there, it is moving. This movement is linked to the balance, that's the balance in our, that is why giddiness. If you write fluoxamine, patient will be alright. Most this giddiness will be the first symptom, one of the good responses, the phobic disorder. That is my observation. Then is my mind is not listening. My OCD patient, a separate group is there. Whenever he tells that the mind chapter ventilator. So if in 80 days, going on titrating the fluoxamine and the fluoxetine, certain mind chapter. So that is the thing. So that patient group is there. To analyze, I published a paper. I will show that. Psychogenic vomiting, we publish a paper. The Prashanti module of anti-vomiting behavioral therapy module. Because smell technique, chewing technique, and debilitation technique, giving space, these are all the techniques we use. And we have done hyperemesis gravidarum, fourth gravida. 3 abortions, first 3 abortions because intolerable vomiting. Fourth para, she came to Karimnagar. One of the stubborn gynecologists sent to me. Then I am also stubborn. I will give behavioral therapy, I don't charge. No, pitchy doctor, none am just one. So then, now she is an OCD patient. His son born after behavioral because the husband is a high court advocate. So I will only behavioral measure. Patient became normal and they delivered. The son is also OCD patient who born after delivery. And the patient, mother is also OCD patient who belongs to Manchiria. So these are the insights we will get this twin study and triplets. And I am 2 triplets and twins study more than 140. I show the pictures of the twins also. Pregnancy group. There are 477 pregnant women on drugs. I take consent, special consent for using psychotropic drugs. I'll keep that record along with my record and allow them. And I'm having 3 problems out of 477. I will tell 1 to 2% problems are there. So first pregnancy out of these 477, 443 are first pregnancy. The 2 consent forms attached to the record, that is second pregnancy also, they have given consent. Third pregnancy 8. I think fourth pregnancy something there, this is error. Probably some 2 pregnancies are abortions. The 4 consents, but 2 abortions, that were they gone to the 4th pregnancy. So here pregnancy group, trifluorescent group, this is a trifluorescent group. A lot of, I cannot put everybody here, 400. So this is a halobedal group. The first test tube baby of Karimnagar, this patient, he is a halobedal patient, he is a test tube baby girl. So now she is doing BTech. Sir, this is Telangana Hospital, Market sir, beside sir. This is Respirator group, this is Olanzapine group, this is Carbamazepine group. I shifted the sodium valproate to Carbamazepine. I don't know, my religion on Carbamazepine is safer than any drug in bipolar mood disorders. All bipolar mood disorders stabilize on one drug, then I allow them to pregnancy if they want opted. Then TCA group, that is bromipramine and antidepressant group also there. Imipramine group, the fluoxetine group, then bromipramine and fluoxetine combination groups. Suddenly they come. We don't want to go for abortion, sir. Please, we will continue. We will sign whatever the signature you want. We will sign. Then they will take their own risk. This coming to the twins. So the mother is a patient. She is having 2 twins. Out of 140 twins, are different twins are there. So both twins are on treatment. Only 1 twin person is on treatment. Later other person will come. Monozygous, heterozygous. Then twins are just born. Only 4 years also I recorded the twins group. But mother is on taking patient. We have to see in follow-up. So mother on treatment. Only 1 twin on treatment. Both twins on treatment. This patient, this is a bipolar. Both are suffering with bipolar disorder. Both are suffering with phobic disorder. Both are OCD patients. Both are married. She is a successful marriage, having 2 children. Beautiful, wonderful husband. She is getting marital problem now. So here, widows study group. The young widows, different widows are having different problems. There are 836 widows, male widows and female widows. Then some here, the third parties. Some cases of publication by my postgraduates and younger colleagues. I show some studies. This is a case series of compulsive insertion. So this is a oral insertion. She always gets pleasure, compulsive insertion. She is getting pleasure and compulsive doing of oral insertion. This is a patient. She masturbates continuously with 3 fingers, always in the vagina. Because of the wetness, she developed a fungal infection here. I am having all video clips. Every photo and video clips, I will take consent. Then here, you see the fingers, same fingers are after treatment, schizoaffective disorder with compulsive masturbation. So probably that second orifice of the Freud. Then the rectum, compulsive insertion of the finger into the rectum, lead to rectovaginal fistula. This patient went to Chaitana also, anybody in Chaitana. So they also treated. Then they separated, surgery was done after taking consent. So that was the mental retardation with little borderline MR with this OCD feature. So I don't know, that's one poster was presented by postgraduate Freudian relevance. There are 3 orifices. Here 3 cases. She presented a poster. So we have one more group of untargeted symptoms, response of untargeted symptoms in psychiatry. So here you can see the asthma. This is a schizophrenic patient. He is administered till now since last 20 years on my treatment. So very good improvement. She is earning a lot of money. She is having one daughter's son. Daughter is a doctor and an engineer. He is recently died as a bank manager. Came from Nizamabad. There are ST tribes. And now she reported that 90% of her Indians are decreased schizophrenia treatment. I don't know what is the relevance with this. Probably the psychosomatic. These are response of psoriasis with tricyclics. Not 100% pure, but lot of response is coming within 1 to 2 weeks. So response of untargeted symptoms. We are not targeting, but the patient reporting response. These are psoriasis. These are vitiligo patients. Then you see how vitiligo is becoming. Small patches are disappearing. So this patch you can see that how it is disappearing. So small patches are disappearing, but vitiligo whole completely will not get remission. We should not dermatologist's job, but that we have to explore the role of this psychosomatic link. The testosterone role in schizophrenia, the two schizophrenic, undescended testis and underdeveloped testis, and the testosterone is almost zero. So they are giving depot every month. They are giving depot testosterone along with the antipsychotic. Now the psychosis is decreased. Now very minimal antipsychotic with only depot antipsychotic. So these are all the one more patient with undescended testis with probably not scrotum is free but is developed psychosis. Then compulsive cutting. The different you see this son very high socio-economic family. Sir, okkasari cut chesthe daddy. That is the thing. So father, sir, yes, sir, 2 days, but I remember okkasari cut chestukuna. You see the father also injuries, the compulsive cutting. This was published as a poster and a paper also. So here, vitiligo response of schizophrenia, I think that Sharanya got award for this poster. You can see the front position, 1, 2, 3. She responded after 3 months. This is a right lateral position, 1, 2, 3. She responded. The pigmentation, you see change of pigmentation from this side. So the right lateral, the other lateral position is you see the changes. She got the. So the vitiligo response was documented by follow-up study of a vitiligo patient. So when I killed my baby, there are 2 twins for this lady. She killed one of the twins, and the second pregnancy was under follow-up. Very violent patient, very violent. I don't know what the link of this special patient had a bizarre violence. This was published as a poster. Then coming to the other publications, psychogenic vomiting published by Sanjay, the same, the hyperemesis gravidarum, 4th para, the survived and reported now on follow-up treatment of OCD. Whole family suffering, a lot of family members are suffering OCD. Psychogenic vomiting, again Prashanti anti-vomiting module of behavioral therapy, we developed it, and then this is a publication done again by Apala, and at the time Sanjay is not there, just joined. We published together. One individual came with she's a female working 24 years old in LIC office. She's a female, she's a winner of lot of female sports, and she stayed throughout life in the female hostels. And she brought by another female of LIC, and she converted as a male. Because she told that I am a male, sir. My parents brought me like this, brought up is like this. So we changed, we have taken the radiological sex, where the ovaries are there or not, like that. Then the hormonal testing, then we have taken the legal opinion, and after that we changed the gazette, name change, sex change. And now I gone to the only one marriage of my patient for her marriage, and she now had 2 children. The precipitating factor of visiting the doctor is her lover, so-called his lover, and her lover is the other female. If you don't change to male, I don't want to go to my marriage. So that is the precipitating factor. I changed them. I promised that the girl also, within 1.5 years, everything will change, she married. So there are 3 more cases a year. Infertility cases, there are one schizophrenic patient, there is one schizophrenic patient, there is a depression patient. All 3 reported that, sir, because of drug I became pregnant. So antipsychotic would have hyperprolactinemia. You see more than 400 patients are delivered in my clinic. Most of them, half of them are antipsychotic. With hyperprolactinemia, how they become pregnant, I don't know. But the gynecologist will tell me. No, drugs water, first was antipsychotics, banjai, the pregnancy cow. No, I have shown this. That a patient will become pregnant. I don't know how they have become, because I don't want to go here. So this schizophrenic both become pregnant. This fellow came, he is died now. This fellow has become a very adult, now getting married. I am having the other pictures. He is taking care of mother now. So this page, he came to me in Bhuminedi Hospital, the famous hospital. Sir, Bhuminedi will get Bhavamar has to pay the fees. The first pregnancy in Telangana, paid by the parents. సో సార్ డాక్టర్ సార్ 10,000 ఇవ్వండి అని వచ్చాడు. అరే నాకెందుకు ఫీజు అంటే నాకు ఏం సంబంధం లేదా, నా మందులో అట్లా పిల్లలు కాదు, మీకు ఎట్లా అయ్యారో నాకు తెలియదు. సో దిస్ ఇస్ ద వే, this is the first case. Second case is this suicidal. Third case is depression. Also suffered with 10 years infertility, 7 years infertility, running lot of prescriptions of infertility treatment, but they became. We don't know the mechanical factor of ampulla, fertilization. Probably the they are probably copulating with full mind or experiential. So copulating is not completely. Probably something is there to analyze here. Phenomenological research, giddiness, again, this is a phenomenological research. Giddiness and my mind is not listening. This is a paper I presented in APA. Mind is not listening to me. Then another, the OCD patients as a phenomena. So because most of the patients, I have seen 40 years before MD, I read My Mind and Mysteries and Its Control by Shivananda book. I read before MD. So mind control books are there in railway platforms. All these Ramakrishna Mission people will write Mind and Its Control. So everybody trying to control their mind, become patients and come to us. They will be confused. So we don't know that. The mind is different, soul is different. But the Americans may not believe that. So here, because that is mind is not sleeping, sir. Sleepless patient will come. So నేను పడుకుంటానే నా మైండ్ పడుకుంటేస్తాను, అది ఆలోచిస్తూనే ఉంటుంది. This is the mind is different. So my mind is not sleeping, my mind is not listening. These are OCD and sleeplessness. Indian Avana syndrome. When you do Sandhya Vandana, if anybody does Sandhya, you don't know. Any puja to goddess, first Avahana syndrome. Avahana is, we will get Avahana. Because do Gayatri, Sadhana, that Sandhya Vandana, first Gayatri will, Anganyas, Karanyas will be there. In that you will get mantra in your own body. Then in the body the goddess is there, you will pray for it, doing prayer for that. So that is Avahana. Most, we are around 400 plus transient positive disorders and described, analyzed in the Indian Avana syndrome. Coming to my publications, last phase. So I am having my own insights of my practice of this much data, with all commitment, with all empathy to patient, which I learned from my teacher, Dr. Raman Reddy, and all teachers of like Dr. Ashok Reddy and Chandani and other seniors here. I am having my insights. First I shared in my presentation of AP, that psychiatric care, illness to wellness. Then this is something different. So this is yoga and spirituality, my southern presentation address. Then I think that was one of the highly cited article of my own publications. Coming to the yoga and health services, that Gangadhar's article we have written together, how to integrate yoga to the mental health services. Then Markandian phenomenon, one of the phenomena we published, we can change our neurobiology. By spirituality, the bidirectionally change the psychology and spiritual, biopsychosocial spiritual approach. And we published this is a part of the explanation of the how this our spiritual mechanisms will work. Comprehensive psychotherapy by using psychotic by using Gayatri mantra. Comprehensive psychotherapy of mood disorder by using Mrityunjaya mantra. Trikala, that Sandhya Vandanam, what is the secret of this? Where Chidambar Rasa is as a part. Chit means mind, Ambara means sky. If we increase the space, if a 10 by 10 room में पूरा फाइल डालते तो बहुत मुश्किल होता है फाइल निकलने के लिए. So if you less space, more confusion. So more space, that is why in Sandhya Vandana, morning you pray the sky, morning sky, afternoon sky and evening sky. People think that we are praying sun. Sun, solar family is holded by the sky, that is Akasha Tattva. I learned this point from Amit Goswami of quantum physicist from New York. I went all the way to New York to listen his lecture, quantum physicist, talking on consciousness. He told in India it is called Akasha, A-K-S-H-A. I am the only Indian in that group, New York Open Center, I did it, Akasha Tattva. So if we are praying the Akasha, it is the sun. Krishna is the sun, color is the sky color, Rama sky color, Shiva sky color. He is the owner of probably the masculine part, feminine part is the whole solar family, is the Prakriti. So this is, I don't want to go deep, barbarican way of seeing, and that was I already presented in, this is expanded, this is the last slide. Then I have written one editorial on expanding mental health research in India, providing funding agencies with the need of the hour. Lot of funding is going to demands. I think Madam is not here. Whatever the funding of Ayush funding going to, I have seen 170 lakhs, 220 lakhs of fund sanctioned to one project of Ayush fund. Where you get? How much IMH is getting government funds for research? Having very big data. How many private institutes are getting data? Asha Hospital, I don't know how much they are getting fund from the funding agencies. There are international funds available, the national funds are available. Now that is the real insight. Craving for starting research fund. KBS started a research fund of teachers and IMH alumni. Approved. Now we are going to give this a time. 5 lakhs fund was deposited in the IMH Alumni Association by KBS, the Teachers Fund for Research. Then South Zone Background Research Fund. Then I propose, lastly, I think with the Chandani's guidance, we try to approve next AGB, not this AGB and next AGB. So 10 lakhs research fund, we are having 50 lakhs. What you are doing with 50 lakhs? Sir, Chandrasekhar sir told when we are division, Kishan, ages could double punch money. And the veteran bank loan age sir. Really, sir, if you remember, correct. Age is 10 lakhs 50 JC, that is interesting protocols. There are a lot of people are there interested to submit protocol, encourage them between 20,000 30,000 rupees. So we have to do a lot of research, we have to license the private institutes, single doctor database, multiple group doctors database with institutional database. Then we will have a good license of research in future. This is only Modi has done wonderful job. Whole world is bending on 21st June. Now we are shifting to spirituality. Gangadhar sir is a master in ECT. The first phase of his research. Second phase on yoga. There are a lot of research papers on yoga. Now he is shifting to spirituality. Because next level is yoga will repair the hardware of the world. Then the other things, spirituality will change the mindset, and that is a higher level of thing. And our research agencies should be now. Modi started some research fund last year I think. So there we have to do a lot of research, and we have to encourage youngsters to do research. 100 members of psychiatrists coming outside. At least 10 members should be academic side research, 10 members of private side research. And this spirit of presentation is have your own database, try to do, you will get insights, you will get research. The future direction is the last slide. I think the future directions of my own thing is to have retrospective and prospective naturalistic studies, to study the course of illness in Indian scenarios. Very good. I am comfortable after 78,000 patients at 62 age now. Still my wife is with me, because my joke was when I APA I am entered. My database is around at that time 60,000, 58,000. Oh doctor, are you a general practitioner or psychiatrist? Number one question. Other friend has put whether your wife is still with you or not. It is very difficult. How many patients you will see? How it is possible in India? Because the culture, the strong family system, our patients are always come with attendant. That is the secret of success today. Without attendant, nobody takes tablet. So we will take response. In the attendant also, you have to identify the good attendant in the family. Educated, and you tell that is the success of practice. Your patient dropout will decrease, compliance will be increased. To study the course of illness in India, they are becoming normal. Schizophrenics are producing, they are getting jobs, they are getting married, they are producing children. You have seen here, they are not burdened to the society, they are useful persons, provided you have to give good placement and good rehabilitation. When my passion of Ashok Reddy sir is not here, when I have done a seminar on rehabilitation, where the OHPV papers are there. Then rehabilitation then rehabilitation you find a psychiatrist. Then Jagannath came and started a rehabilitation center. Nobody volunteered for rehabilitation. When during my PG I have done a seminar on rehabilitation, I have done I think who has written chapter in the CTP, rehabilitation. His name is coming to me. He has written a book on rehabilitation. I got to the book also. When during that seminar, I got to the CTP, I got to the book written by that author of CTP. Then Ashok Reddy sir, he parledane ఊకి rehabilitation అవర్తో ఆడ పిచ్చోడు ఉంటే వాడు ఇట్లా బిజినెస్ పెట్టుకోమంటే అన్నాడు unless కూడా ఐటీలో వాడకుండా పోతున్నాడు. We cannot do very difficult. Rehabilitation is very difficult thing. But provided if you take caste system, no, Gowda, if you train them to make at least what target lekukunda easy cheppachtaru. This is the way you can rehabilitate. A lot of Indian caste system helps us to rehabilitate in a better way. You don't train the weaving to the landlord family. The landlord family will not weave, will not do all this chota works. So you have to identify. You should counsel properly and rehabilitate. So that course of illness is different because strong family system in India. To study how to improve the prognosis of the patient. I believe one of the a psychiatrist can change the prognosis if he is really determined. Nasib likh sakte, फिर लिख सकते. So if you change, if you plan, if you are having commitment to the family, you take one landlord family, he will not do any work. Then I requested them to any capitalist is there in your family. So when minister I got, is having very big lot of factories. Let them recruit him. Now he recruited for 20,000, 30,000 salary. His duty is only observation and reporting to the boss. But that is the only thing done. So if you rehabilitate different, you will get salary. His wife is will see him. If don't earn, any male will not earn, the wife will go to the mother's place. So they study the transgenerational course of illness by studying the patient who are suffering 3 generations, and study the factors of nature and nurture, brought up by studying adopted, sibling group, twin studies, other things, to do phenomenological research like I have told that cultural factors influencing psychopathology and Indian patients. So we are still reading now I entered IPS EC. Now my first proposal, you should have Indian text for psychiatry which is equal to CTP. So that was Ajit Awasthi and other who I think were there working there. Last point is to study effect of yoga, spirituality, neuropathy. With this I am closing. I think I have a lot of time and thanks for bearing me. Thank you.
What should I say of narration? Really mind-boggling for individual psychiatrist to collect so much data and present it in his own way to analyze the problems which he observed. This shows that his commitment, number one. The second thing is the skill of acute observation. And the third thing is the passion to help the patient. I think all this put together made Dr. Kishan an exemplary person in the field of psychiatry. I'm sure he has got a lot of years to go, and I think the valuable information which he shared now, I think once it is systematized and goes to a large number of people, they will find some inspiration from his work and further do it. I think all the young psychiatrists should take the inspiration from him, especially with reference to documentation. How the documentation helps and how a clinician in private practice can do research. I mean, all these things is a person there who is in front of you who has done all this, and I think a big congratulations to him, Dr. Kishan. Thank you. I think we'll end this session here.
In one word, we can say he's a Superman of psychiatry. He lived a life living beyond life, above life. Persona above life. I congratulate Kishan Anna for the achievements. Thank the organizers.
Now to felicitate speaker and chairpersons, I invite Dr. Nagendra sir, senior psychiatrist, Dr. Dinesh sir, past president, Hyderabad Psychiatric Society, Dr. George Reddy sir, Dr. Ashok Alim Chandani sir, Dr. Bhagya Reddy sir, onto the stage.
నెక్స్ట్ ఎగ్జామ్లో పెట్టుకుందాం మా ఫ్రెండ్స్
I request all the delegates to give a standing ovation. Sir had opened a panorama box with the data. Now the onus lies on the next generation to interpret Sir's findings and to come with a few new researches. Thank you all. I request George Reddy sir to felicitate Dr. Kishan sir.
Okay, sir. Sir, look here.
Thank you all. Within 2 minutes, we'll start for the next award session. Late Podu Chinnareti Venkatramamma Award.
So there is no competition. It's a really good paper presented, submitted by Dr. Nivedita, consultant psychiatrist. Now I invite Dr. Nivedita to present his paper.
Thank you, sir. This is a survey to assess the attitude, approach, management of perinatal psychiatric disorders among doctors other than psychiatrists. And this was done by Team Samanvi, IPS TSB. Introduction. Perinatal period is a period which is 1 year before and after delivery. So this period, no doubt, we all know is a very challenging period for the women. They face physiological changes, physical changes and the hormonal changes which end up and which don't spare the mind also. It also gets affected. But what is more important is that these 2 years are the nurturing environment for the child. And definitely the fate of the future society lies in the hands of the maternal mental health. Coming to maternal mental health significantly contributes to the health during pregnancy and postpartum period. Literally any psychiatric condition can occur in this period. It could be a de novo occurrence, or it could be an relapse of a previous condition, or it could be exacerbation of an ongoing illness. So because it is a stressful condition basically. And as untreated psychiatric conditions are associated not only with the poor mental health conditions in the mother and the child, but also associated with increased complications of pregnancy like hemorrhage, preterm births, unplanned cesarean sections, etc. They are also associated, now suicide is considered as one of the leading causes of maternal deaths. I think obstetricians have dealt with the causes of maternal death like puerperal sepsis and everything so well that the neglected area, that is the mental health, maternal mental health, is unmasked by this very fact. So untreated anxiety and depression are found to be significantly associated with intrauterine growth retardation and small for gestational age babies. So untreated substance use disorder. In the wake of increased substance use, we are getting referrals from the labor room, and we see alcohol withdrawal syndromes there, which is very alarming these days. And in these conditions, of course, it is not very hard to believe that there are deleterious effects on the health of both mother and the child. Studies suggest that 30 to 50% of women have common mental illness disorders during pregnancy and the postpartum period. Despite this huge number, we often find that maternal mental health is not adequately addressed. This study, we tried to explore the gaps of healthcare system so that we can see that these gaps are filled and a smooth delivery of all the needed for these mothers is supplied. Health professionals like obstetricians, pediatricians, general physicians, or any other specialist for that matter, are the frontline health professionals to whom a pregnant woman might go for help. Hence, these people play a very crucial role in early detection and management. Our study aimed to assess the attitude, approach and management of perinatal psychiatric disorders by doctors other than psychiatrists. So the objective was to find the target population of doctors and target areas of awareness and intervention. It was a cross-sectional study using an online survey. We prepared a semi-structured questionnaire. Apart from the demographics, there were three subsections, three sections addressing 10 questions each to attitude, approach and knowledge and management. It was inspired by standard tools like MICA, and area were doctors following allopathy. Exclusion criteria was psychiatrists, doctors practicing any other form of treatment like homeopathy, Ayurvedic, and paramedical staff were removed. So coming to the results, out of 220, 18 had to be excluded as per the exclusion criteria. We were left with 202 doctors, of which 71 were MBBS doctors, 71 belonged to medical specialities, 38 were obstetricians. We had to make a separate group for obstetricians because they are the very important frontline professionals in this area. And 22 belong to surgical specialities. And gender-wise also, lady doctors took the survey more in number, 76% we got it from there, and only 23 of men contributed to our sample. We tried to have three other groups depending upon the place of work. So 25% were associated with academic institutions, 42% were associated with non-teaching hospitals, and 32.7% were individual practitioners. And the mean age of the sample was 38. Mean years of experience was 11, which ranged from 1 year of experience to 45 years of experience. Coming to the questionnaire proper, the section 1, which is about the attitude, we found that 15.3% of doctors expressed that mental illness is always evident and recognizable, hence probing is not necessary. This included 26.3% of obstetricians. Then 25.2% of doctors believe that postpartum psychosis is a condition that always requires separation of mother from the baby. When we are coming up with MBUs, mother-baby units, I think this is a very significant thing. 41% of doctors accepted that they do not routinely assess mental health issues or psychosocial issues in the pregnant and postpartum women. More than 95% of MBBS doctors though did say that they try to ask, but 58% of the specialists didn't. Though these percentages look very small, the reason why they gain our attention is that our sample is no ordinary sample. These questions or these information was supposed to be known by all the doctors is what we felt. So hence these small percentages are also being highlighted here. Section 2 is about the approach. 58.9% of doctors were not aware of screening tools for assessment. 56.9% were unaware of risk factors of perinatal psychiatric disorders. Then 72% of the doctors were unaware of all the symptoms of postpartum psychosis. Again, MBBS doctors were more aware compared to the rest. Section 3 is about the knowledge about how to manage these cases. 53% of doctors did not feel competent in assessing and dealing with psychiatric symptoms. 96% of doctors were unaware of all the complications of untreated psychiatric illness. 66% of doctors and noteworthy 74% of obstetricians opined that treatment of mothers with antidepressants had deleterious effects to the fetus. 49.9% of doctors had no clue about dealing with substance use disorders in this population in the wake of, again as I said, increasing substance use in this population. 50% of the doctors could not suggest best contraception for women stabilized on anti-epileptic agents. Coming to comparison analysis, there was no statistically significant difference between the groups, but as the bar diagrams shows here, the scores attained by all the groups clearly declined through attitude, approach and then knowledge. It was coming down. the mean scores were lower in approach and knowledge. MBBS group outperformed the others overall. Obstetricians scored more about among the specialist group. This bar diagram is about the workplace comparison between the workplace groups. So significant difference in approach of doctors associated with academic institutions. Probably as they simply refer the cases to the psychiatry department. They don't approach them by themselves or manage these cases by themselves. Again, this is a scattered plot to show the distribution of the total score of the questionnaire with the years of experience. Here we see that a group which is associated with academic institutions had a positive correlation between the years of experience and total score obtained. This is scattered plot to show the same comparison of negative correlation between years of experience and total score in the non-teaching hospitals. This is a scattered plot to show a negative correlation again between years of experience and the total scores of individual practitioners. Coming to the discussion, good number of articles are published in journals of other specialities in the recent past linking perinatal mental health to various adverse outcomes of pregnancy like hemorrhage, preterm deliveries and etc. Yet we found a considerable lack of proper attitude and approach to these cases. A similar survey was conducted by Zishiku in Singapore, published last year. This was exclusively done in obstetricians and the results found were similar to our survey. A similar study in Europe concluded a lack of awareness and training. Thus, this seems to be like a universal problem. Study coming to the national studies or Indian studies, a study by Jyoti Gupta in Himachal Pradesh was done on postpartum depression only in obstetricians and primary health professionals. Results were similar but had a greater percentage of unawareness. Their approach and attitude scores were ranging more than 93% of the doctors being unaware of most of the information. This might reflect upon the activities of the DMHP program in that individual states, as the Himachal Pradesh DMHP website itself states that the program is not running smoothly because of the lack of professionals. Then, though some of the basic questions were not statistically significant, we were surprised to know some doctors being unaware of the information like baby blues and postpartum depression are not the same. And they all felt that there is no need for treatment in this condition as it is self-limiting. A recently published study by Wingarten et al. Stated suicide as a leading cause of perinatal death now. In wake of such an alarm, even one doctor being unaware of these conditions is not what the society can afford for. We could see that MBBS doctors outperformed others overall. The reasons could be compulsory psychiatric postings in MBBS curriculum now, which was not there before. When we did our MBBS also, it was only an optional posting. And these people are from these medical officers. MBBS group is from the medical officers of UPHCs in Hyderabad districts, who were constantly exposed to training program under DMHP. Likewise, doctors associated with teaching hospitals with greater number of years of experience showed positive correlation to total scores. This could probably be because of the constant interaction and exposure to the awareness activities conducted by psychiatric departments in the respective hospitals. To conclude, we wanted to find the target population of doctors and the target areas of awareness needed. We conclude that awareness programs about perinatal mental health to all the other specialties is the need of the hour. All doctors need awareness about the safety profile. They seem to overvalue the side effect profile of the psychotropic agents. A risk-benefit ratio that is generally calculated by any doctor is, this seems to be swaying more towards the risk, thereby having an undue fear of use of these agents in this population, leading to neglect. This is an urgent need. There is an urgent need for the upskill of frontline doctors in prompt recognition and proper management of these cases. We acknowledge all the doctors who took a survey. It is not easy to come up with our ignorance, being so sportive to come up to and take this survey. We are really thankful, and the rest of the names in the acknowledgement are the propellers of this study. We are really thankful to the IPS TSB for supporting this study. Future directions, more standard tools can be used to accurately assess aptitude and knowledge separately in bigger sample size in individual specialities, which may yield more information. Studies can aim to find correlation between compulsory and optional psychiatric rotation in MBBS doctors. Further studies can explore differences in attitude towards psychiatric illness as per their work of place of work. These are our references, and thank you very much. This is how a mother and baby should be happy. Thank you very much.
Thank you. Dr. Nivedita completed her presentation. So if you have any questions or clarifications, you are welcome to ask. Madam, the questionnaire from where you have collected this one? Where you got?
Questionnaire we only have compiled, sir.
Compiled.
MICA is a clinician's attitude scale, but it is a 20 item scale and has a Likert of 5 parameters, sir. We thought that it would take a very long time, might discourage people, many doctors from participating in it. So many questions, 10 questions out of it, which we felt are very important, we took them for attitude. Then approach also, we similar standard tools we took, and we tried to get inspired from them and make our own 10 which we felt that were very important compiled. So the whole semi-structured questionnaire was brought together by us, the IPS TSB team. I mean, Samangli team, we 3 people, sir. Dr. Shweta Reddy from Asha Hospital and Sharma Siddiqui from Deccan Medical College and me, sir. We all sat together to compile the questionnaire. And management also, it was more based on the clinical this thing, sir. Whenever we write, I think every psychiatrist would agree that whenever we write an antidepressant for the postpartum depression, they don't take it. And mostly they come back to us in a very worsened state. When we ask them why they didn't take, the obstetrician asked us not to. Is a common answer we get. So, and our study, this was very important, we wanted to explore, and we saw that 76% of the obstetricians felt that was using antidepressant by the mother in that age group would be deleterious to the baby, even if the mother is lactating.
Naturally, they don't have much knowledge about antidepressants.
Yes, sir. So this is, yes, sir. So we have to maybe have some awareness programs to let them know the safety profile of these drugs.
Then what is your opinion on the specialists are having less awareness regarding the postpartum psychosis, all these things, when compared to normal MBBS people?
Yes, sir. Probably these are the medical officers, sir. They are freshly passed out from MBBS students. That's what I have just made a probability that it could be because when we were doing MBBS, psychiatry posting was not a compulsory posting, sir. Out of 212 students in my batch, I think only 2 of us came for psychiatry posting back then to IMH. So now it has been made through the efforts of IPS recommendations. I think it is now made a compulsory posting, and that could be the change why MBBS students have outperformed the other specialities. Other specialties obviously for a little older generation.
Okay, after completion of the specialty also they should improve their knowledge.
Yes, sir. They must.
Why they are not doing that?
Maybe for even the specialist, every specialty there should be a posting in for psychiatry, sir. That might improve.
Yeah, Dr. Nivedita.
Yes, sir.
I must congratulate you after an excellent presentation.
Thank you, sir.
You compiled the questionnaire yourself.
Yes, sir.
And especially those who are questioning the obstetricians and gynecologists
yes,
after delivery. The very pivotal point of this whole essence of the questionnaire is postpartum psychosis.
Yes, sir.
The obstetricians and also including I think the pediatricians also they think they don't consider there is such thing like postpartum psychosis. But when you counter question them, when they say no, nothing like that, don't give antidepressants and all blah blah blah, whatever they say. Can't you question them? There are quite a good number of cases where infanticide are there. Just now we have got Dr. Kishan's presentation where a twins were born, the mother killed one of the twins. So there are quite a group. In my own clinic, I get cases like infanticide cases.
Yes.
So did you counter question them to at least enlighten them or to fulfill your question to be answered?
It was not an in-person survey, sir. It was an online survey.
Oh, I see.
So that's the reason we did not want to discourage people. It should take less time for them to complete the whole thing. So it is just a preliminary thing, sir. And that is what I said in future directions, that if this can be taken up as a personal interview and in a more standard tools can be applied, I think more information will come per speciality if it is done.
I thought by virtue of you being in Hyderabad city,
yes, sir.
Personally, because very, very important
yes,
case, and especially for future generations and young psychiatrists, the postpartum psychosis is one of the very good department. The pediatricians, as well as gynecologists, and general physicians also, and basically these doctors also should know the importance of the postpartum psychosis. Even prenatal psychosis also, that are related to that one.
Yes,
Thank you very much.
Yes, sir. I just would like to share that many of the doctors who took the survey called me back to say what are the right answers. Please send us the key. I think in that way we prepared a key and send it to them. So it was one awareness thing that we did. And till they went through those questions, those thoughts or doubts also did not come in their mind. That was what we understood. And all of them were very sportive in coming forward and taking us.
Thank you, Nivedita, for your excellent presentation.
Thank you, sir.
Thank you all the delegates for question listening. Now, if there are no questions, we will stop the session. Thank you very much.
Now to felicitate speaker and chairpersons. Felicitate chairpersons, I invite Dr. Vishweshwar Rao, Consultant Psychiatrist, Mancherial, Dr. Rajendra Suryanaidu, Sir, Assistant Professor, Government Medical College, Nizamabad, Dr. Sheetal Ram, Assistant Professor, KMC, Warangal.
Vishweshwara, sir.
Sir. Photo.
Thank you all. I request next postgraduates to come and start uploading in the laptop so that we will be ready for the next award session. Dr. Nikita, Dr. Prithviraj, Vasim, Kalyan, Latira, Nandini, Sai Krishna Yadav, Shweta, Sharda,
ఇదొకటి మళ్ళీ దీనికి ఆపోజిట్లో పెద్ద స్టాల్ ఉంది కదా, అది తీసుకున్నాకంటే ఇక్కడ స్టార్ట్ అయిపోయింది. అది తీసేసుకున్నా పైన ఈ ఫ్లోర్ తీసుకున్నా, ఈ ఫ్లోర్ కార్డ్ కాపీ చేసి ఇచ్చాము. మనకు రేపు కార్డు కావాలి రైట్. ఇంకా బాయ్. ఇది కూడా అయిపోతే తీసుకొచ్చేద్దాం.
post-graduates to come forward to encourage your own colleagues. Please come forward. Dr. Pratyush.
ఇంకరెంట్ కార్డు మెయింటైన్ ఇంకరెంట్ క్యాష్ సెకండ్ వన్ అయితే ఆ రెండు ఫుల్ అయిపోతాయి ఇక ఒక్క ఇంకా 9 నిమిషాలు ఉంది అది అయిపోతే 2 కార్లు ఇప్పుడే ప్రోగ్రామ్ ఇప్పుడు కాలేదా
Our chairpersons for this PRAD IMH Alumni Association DJ Award, Dr. Sirisha Ma'am, Dr. Psychiatri sir.
కార్డు
Dr. Sirisha Ma'am is a professor of Psychiatry, Institute of Mental Health, Hyderabad, Deputy Superintendent, Institute of Mental Health, Hyderabad, worked as HOD, Psychiatry, OMC, Hyderabad from 2021 to 23. Number of publications are 25. Areas of interest, PG teaching, forensic psychiatry. Dr. Fanikant Kondaparthi sir, currently working as an Associate Professor of Psychiatry, OMC or HIMH, Hyderabad, working in government sector since 16 years, co-investigator for National Survey on Patterns of Substance Use in India, conducted by Government of India, past editor for Telangana Journal of Psychiatry, IPSTS. Current editor for Telangana Journal of Psychiatry, IPSTS.
Good evening everyone. At the outset I would like to thank organizers for giving me this opportunity. It's wonderful to chair this session. Dr. P.R. Reddy IMH Alumni Association Award. This award was started in 2002 and contributed by IMH Alumni Association. Amount of 41,000 was contributed, and winner will get a 50-gram medal coated with silver medal coated with gold, plus 2,000 rupees cash, plus a certificate. And PGs who are studying post-graduation in Telangana are eligible to participate. And names of the winners will be announced in the valedictory function to be held tomorrow. I wish all the PGs all the very best. And now I will pass on my to Dr. Fanikant.
Good afternoon, everyone. Without taking much time, we'll start the presentations. I invite the first speaker, Dr. GSM Nikita from IMH.
8 minutes presentation, 2 minutes questions.
So you have only 8 minutes for the presentation and 2 minutes to take the questions. Please start.
Good evening everyone. I am Dr. Nikita from Institute of Mental Health, Hyderabad. I am here to present my study, which is on a comparative study of personality traits in violent and non-violent offenders. According to National Crime Records Bureau, non-violent crimes are defined as a crime where no injury or force is used on another person, like bribery, theft, prostitution, check bounce and gambling. Violent crimes are violation of criminal law that involve the intentional use of violence by one person against another, like inflicting physical harm, homicide, robbery, rape, intentional threatening attempt, etc. The aim of the study was to compare the personality traits of violent and non-violent offenders. Our objectives were to assess and compare the personality traits of violent and non-violent offenders and to study the socio-demographic profile of the study sample to determine if there is an association between socio-demographic variables and violent non-violent offenders. Ethical clearance was obtained from Osmania Medical College Ethics Committee before carrying out the study. Materials and methods: the sample of 60 male convicted prisoners was taken from Chellapalli Central Jail. Among them, 30 were violent, 30 were non-violent offenders were included in the study on convenient sampling. They were differentiated as violent and non-violent as per definition given by National Crime Records Bureau. Neo-personality inventory was used to assess personality traits. The inclusion criteria were age of 18 to 60 years, those convict prisoners who are in position and willing to participate in study by providing valid written consent. Exclusion criteria: presence of accessible psychiatric disorders, psychoactive substance dependence, intellectual disability, organic mental disorders including dementia and delirium. Methodology: a semi-structured intake proforma was used to collect the socio-demographic details. The personality traits were measured by NEO-PI scale. After obtaining the permission from concerned authorities, study subjects who met the inclusion criteria were interviewed. NEO-PI scale was administered for assessing personality traits. It assesses an individual on 5 dimensions of personality. These traits are openness to experience, that is intellectual curiosity and creativity, conscientiousness, orderliness and persistence, extraversion, sociability and positive effect, agreeableness, cooperation and trust, neuroticism, anxiety, depression and emotional instability, and their scores are relatively stable across lifespan. Modified Kuppaswamy scale was used to study socio-economic status. So the tools were semi-structured intake proforma, NEO-PI, modified Kuppaswamy scale, and statistical analysis was done using SPSS. The results were there were 60 convicted prisoners, 30 each violent and non-violent. Mean age of the violent convicts was 32.7 plus or minus 4.38 years, and non-violent convicts were 33.7 plus or minus 6.65 years. Most of the study subjects in the violent group and non-violent group belong to rural background. Majority of the violent convicts were unmarried, divorced and separated. Majority of the violent and non-violent convicts were high school dropouts. Most of the subjects in violent and non-violent group were employed before coming to jail and were students. Most of the violent and non-violent convicts belong to nuclear families. So as you can see, the age was in violent with 32.7 plus or minus 4.38, and in non-violent 33.4 plus or minus 6.65. Majorly, the significant difference was observed in marital status among violent and non-violent, where majorly we found divorced and separated couples. Personality traits among violent convicts showed statistically significant high scores on neuroticism and extraversion, low scores on openness, agreeableness, and conscientiousness. Non-violent convicts showed statistically significant high scores on openness, agreeableness, conscientiousness compared to violent offenders. All respondents across both groups were found to have consumed substances such as alcohol and cannabis in their lifetime. Majority were found to have consumed alcohol. About 83% of the violent convicts were found to have consumed alcohol across their lifetime, and 76% of non-violent were found to have consumed alcohol. Past history of crime was reported in 40% of the violent offenders group, 7% of non-violent offenders. So there was a statistically significant difference between past history of crime and violent group. The present study aimed to assess and compare the personalities of violent and non-violent convicts. The study findings indicate violent convicts had high scores on neuroticism, extraversion, low scores on openness, agreeableness, and conscientiousness. This indicates increased aggression, mental distress, and antisocial behavior among the prisoners. On the other hand, non-violent offenders had an average score on openness, agreeableness, and low scores on neuroticism, extraversion. This indicates that the non-violent convicts are relaxed, detached, careless of social rules, and self-satisfied. The strengths of the study was that there were not many Indian studies that have compared personality traits across violent and non-violent crimes. The study was carried out in jail. All subjects were convicted prisoners. Limitations of the study: all the information gathered from the prisoners was taken. There was no way the information could be cross-checked. There could possibly be recall bias on part of the study subjects given the long duration between crime and assessment. Violent convict group had high scores on neuroticism, extraversion, low scores on openness, agreeableness. On the other hand, non-violent offenders had average scores on openness, agreeableness, low scores on neuroticism, extraversion compared to violent group. Being divorced, past history of crime, incarceration were found to be risk factors for violent offense. Implications of the study. We need to realize that the criminal activity is a product of many factors, out of which personality traits are important. Some personality traits like impulsivity, hostility are associated with personality disorders. Lot of studies show the link between personality disorders, particularly borderline personality disorder, and crime and violence. Because personality disorders are rooted in childhood, improving parental styles, providing proper supportive environment in school and in surroundings is recommended as preventive measures. All the study subjects in both groups had history of consumption of psychoactive substance, hence more awareness programs to be conducted at the level of police, media, school, colleges and organizations directed towards public would indirectly decrease the crime rate by decreasing the substance consumption. A thorough understanding of how each personality trait relates to criminal behavior emphasizes the importance of equipping oneself with healthy personality traits in order to deter from criminal acts may be considered. Recommendations for future research. More studies involving large sample size longitudinal study designs involving multiple centers is recommended. This helps in improving our understanding of personality traits and their subsequent development into personality disorders in order to overcome criminality in the future. Thank you.
She has finished her presentation. Any questions from the floor?
What is the need for the study? Why did you want to actually compare both the groups? Point number one. Second, why use Neo5?
I wanted to know if there was a difference on personality traits in violent and non-violent. Because before my study, I kind of considered that there is not much difference in personality traits. So as a result, I thought I would perform this study over as a comparative.
What was the need? That was the question.
Simplify this. Are there any studies to show that non-violent offenders and violent offenders are going to be different? Okay, point number one. And if there is a difference, is going to be an intervention which is going to help them in a different way. Okay, there should be a scientific reason why we are doing a particular study. Okay, just because there's a convenient sample, I can divide it into two groups and compare. I should not do it. Okay, that's why I'm asking this question.
Any interventions you would like to suggest?
Early interventions like on the levels of school, media, police, education of the individuals can be done based on this personality traits of the individuals. So as we increase the awareness, the repeated offences of the individuals and all can be controlled and can be brought down.
And the location ready. Actually, the way you have presented is, it looks like the non-violent offenders have a relatively stable personality compared to non-violent. So I don't think, unless you compare with normal population without any history of crime, so it's like what is a now non-violent offenders have a stable personality compared to only violent offenders have a different personality. They are not normal personality. So all your inferences or implications which you have told is that only non-violent offenders have a significant deviant personality. So in truth, it doesn't happen. So unless you would have had a separate third group with no history of any violence.
That is the limitation, sir, we should have.
That would be the biggest limitation.
Thank you, sir. I invite the second speaker, Dr. Prithvi Raj.
Hello everyone, good evening. This is Dr. Prithvi and I am going to present this our paper. Title of the paper is Scarlet Drops of Stress, So we are exploring the rare case series of hematohydrosis, and the authors are these. So before starting this slide, I would like to say that we have taken the informed consent of parents and the patient and assent of the child, and we have shown these images. We will go to a glimpse of a video which is showing losing of blood to the sweat. So coming to the introduction, hematohydrosis, which is also known as hematidrosis, it's a highly unusual medical condition where a person exudes a mixture of blood and sweat from unbroken skin or mucosa. This phenomenon typically occurs when an individual experiences extreme anxiety, and the process involves constriction and subsequent dilation of capillaries that are around sweat glands to the point of rupture. So under severe stress of fear, the capillaries can burst, causing blood to exit the body through the sweat glands, and the blood mixed with sweat is pushed to the surface, appearing as droplets of blood with sweat. Commonly, the blood can ooze from the forehead, eyes, nails, umbilicus, and other skin surfaces. So diagnosing hematidrosis is challenging due to its unknown pathophysiology and lack of confirmatory tests. It necessitates the exclusion of conditions such as bleeding diastasis, connective tissue disorders, vasculitis, and self-inflicted or secondary wounds. So the presence of erythrocytes in the bloody discharge is used to distinguish hematidrosis from other conditions like chromohydrosis or pseudochromohydrosis. And the secreted fluid may appear blood tinged, and the blood load is very minimal. So there are few systematic reviews available on hematidrosis cases. Like the first comprehensive review was conducted by Holobeck et al. In 1996, where he compiled 76 cases from the existing literature and classifying them based on the triggering factors. And commonly acute fear and intense mental contemplation were found to be the most frequent inciting causes. And after that, Kluwer et al. Also in 2018 he did a systemic review on 25 cases and found 9 cases which had psychiatric diagnosis, and there was good outcome seen with anxiolytics and psychosocial support. In 2021, Shafiq et al. Analyzed 36 cases of hematidrosis, where he found there were 83% of the cases being females, and majority of them being under 18 of age. So management, which invariably consists of medications like beta blockers, anxiolytics, tricyclic antidepressants, and serotonin reuptake inhibitors, with or without psychotherapies. So coming to case report number 1. A 15-year-old girl, a resident of urban Hyderabad of Telangana, was presented to the Psychiatri department of Neelafra Hospital on October 22, 2023 with a history of bleeding from the intact skin over the frontal region of the scalp for the last 2 months. So the patient who experienced her first episode of bleeding from the scalp, accompanied by sweat when she was at the college, then she was sent home. Subsequently, she was taken to a local hospital by the parents, where physician has seen the patient and asked to get a referral from a dermatologist, and later she was examined by the dermatologist, and local hair was shaved over the scalp to check there are any local cuts or trauma, and they ruled out all the dermatological causes, and she was referred back to the physician. On further evaluation by a physician, it revealed that she was feeling anxious and tense with a history of bleeding episodes in the temporal relation with anxious episodes, so she was referred to a psychiatrist. On psychiatric examination, it was found that she was born out of a non-consensuous marriage, full-term normal vaginal delivery, firstborn who attained normal developmental milestones, and there were no conduct abnormalities in childhood. She attained menarche at 13 years of age, and regular normal cycles were seen, and she was now living with the literate and working parents, and she is pursuing intermediate in a private college. And through the history, we found that she has no history of bleeding from any other areas of her body, nor she had any anticoagulant, antiplatelet, drugs, dyes, any history. She had no past history of major medical or surgical illnesses, bleeding disorders, eye or skin infections, physical trauma, fever, rash, ulcer, or any other organic causes. And there were no family member had similar complaints. Her routine hemogram, blood counts, platelet counts, bleeding time, clotting time, and APTT, PT, all the peripheral smear examination, LFT, RFT were found to be normal, and there were no history of any blood in urine or stool. Similar findings were also seen in the second case too. These episodes of bleeding, which were never lasted more than an hour and occurred 1 to 4 times per day, were triggered by exams, parental conflict and academic stress. Each episode began with a watery secretion from the face, followed by a bright red bloody secretion, and subsided on its own without leaving any bleeding point, scar or injury. So during the interview, a similar episode has seen and blood was collected for the investigation, revealing erythrocytes on the microscopy, and it was confirmed that by taking a peripheral smear of the blood, it shown that the blood belongs to the patient, and there are no cuts or trauma over the body of the patient during the physical examination. So she was diagnosed with a specific phobia, examination phobia, and she was started on treatment with estrogen, and it was taken up to 15 mg, which resulted in significant improvement, and there were no further episodes over a period of. This is a picture of first case. Coming to the second case, she was a 8-year-old girl from Nizamabad, who was a resident of Karimnagar of Telangana, was admitted in the Nizamabad hospital, the pediatric department in Hyderabad on November 25, 2023. She has been experiencing bleeding from her face and eyes from the past 2 months. She has been seen by dermatologist and referred to the psychiatry after ruling out the skin issues. Similar episode was seen in this child, and history has shown no significant issues. During the examination, she appeared mildly anxious and guarded. Her general clinical and systematic examinations were normal. There were no cuts, trauma, abrasions, or telangiectasia over the face. So she was diagnosed with specific phobia, examination phobia, and treated with fluoxetine 10 mg, which led to mild improvement. The frequency of episodes decreased. Subsequent episodes were reportedly less severe. Patient is currently lost to follow. These are the pictures of the patient. These are investigations done to rule out the other causes. Coming to the discussion, so diagnosis is based on the criteria. It should be recurrent, spontaneous, painless and self-limiting oozing of bloody discharge. It should be witnessed by the health professional. Usual blood components are found in biochemistry studies of the discharge, and site of blood is intact with no abrasions, telangiectasia, purpura. So in our studies, which were in the line with the older studies, it shown that there are female patients, and also they improved with the SSRIs. As per the existing literature, extreme physical or emotional stress was a main trigger, but can also occur without any preceding stressful situation. In our case, academic performance was the trigger. Coming to the conclusion, to sum up, despite its rarity, hematohydrosis should be kept in mind as a potential diagnosis for such type of bleeding episodes, especially when a patient's physical laboratory examinations are normal, presenting with the psychological stressors. And it is also crucial not to hastily label the patients with factitious disorder, as this can lead to distressing outcomes for the families asking assistance for their child who is dealing with this extremely uncommon condition. Yes, ma'am.
Dr. Prithvi has completed his presentation. Now it is open for discussion. Any doubts, queries?
Being the same person back again. Okay, a wonderful case study. But I was concerned that this is a award paper for research work. Okay, this is a case presentation or a case series presentation.
Yes.
Okay, it's only a technical issue. I really don't know whether this can be called as a research work, because all the judges are supposed to rate you on methodology, how your results are, how conclusions are. Whereas this would be in a completely different format. I was just concerned about that. That's all. Nothing more than that.
Thank you.
Any more questions from the audience?
What kind of isolated diagnosis you have taken?
We have taken the specific phobia.
Can you explain how it can be a special phobia?
So there are features of atomic dysfunction, where there is sweating, and also some problem of gastric related bloating and all in the patient. And this is only happening during the trigger or a situation which is academic performance in this case. And there is significant distress in the patient secondary to the episodes which are happening at that time. And this is not explained by any other diagnosis.
So there are known situations or stresses, right?
Yes, sir. Apart from the academic pressure.
So in all the cases there are known situations or no
Examinations, as per.
And the patients are aware about that thing?
during the first they could not be able to establish there is a temporal relationship according to the patient. So later they came up, this is they were experiencing similar episodes when there is something related to the academic situations. Thank you, sir.
One quick question. Why you are thinking it as an examination phobia? Phobia means the person should have some irrational fear and the person should avoid that particular situation. Were there such things? You can answer this question.
Yes, ma'am. So, in the both cases, it was actually this is a diagnosis of exclusion, ma'am. And coming to psychiatric diagnosis, this hematohydrosis is we took as a sweating phenomenon, and these things are seen only during the examination time or whenever they are preparing for the examination, and there is extreme fear related to the examination and the performance during the examination. So we have come up with that. Yes, sir. The patient also trying to avoid the particular examination and trying to bunk the classes to escape from the teacher's scoldings and all. We did not mention in the case.
But did not come in your presentation.
Yes.
How diagnose it as an examination phobia? That's what I was wondering. Examination, everybody will have the fear. If the person is not properly prepared, he will fear going to the exam. Then how can you diagnose? That's it. Yeah.
Thank you. Okay, thank you, Dr. Prithviraj. I invite the next speaker, Dr. Wasim, to present.
Good evening, everyone. Today's paper presentation is a cross-sectional study of prevalence of disordered eating behavior and its association with stress among medical students of Hyderabad. These are the details of the author. Eating disorders are complex psychiatric syndromes in that it can lead to significant and potentially life-threatening medical and nutritional complications. The lifetime prevalence of eating disorder in general population and Western countries in India is given to 1.89%, 1.69% in India. These disorders, often untreated for extended periods, may follow chronic course with progressively worsening prognosis, affecting students' academic potential. Eating disorders are serious health issues predominantly seen among adolescents and students. Disordered eating behavior sits on a spectrum between normal eating and an eating disorder and may include symptoms and behaviors of eating disorders, but it is lesser frequency or lower level of severity. Disordered eating may include restrictive eating, compulsive eating, irregular and inflexible eating patterns. Medical students are associated with high levels of stress that stands as main factor leading to higher risk of eating disorder. There are very few studies concerning eating disorders and their associated risk factors among Indian population. The need for the study is medical education is marked by numerous challenges, including fluctuating periods of crisis, with the multitudes of subjects to cover, frequent assessments and adjustment to new environment. The first year medical students can predispose them to disordered eating behavior. As medicos progress towards the internship, as we have both study group, one is first year medical students and second is internship students. Interns have rigorous workloads, unpredictable schedules, and they always keep worrying about their future and settlement. So they can also predispose to disordered eating behavior. However, the diagnosis and treatment of eating disorders in this population are hindered by limited availability of relevant literature, with the majority of studies is conducted on Western populations, leaving a gap in understanding and addressing the issue among the Indian students. Aim is to study the prevalence of disordered eating behavior and its association with stress among medical students of Hyderabad. Objectives to determine and compare prevalence of disordered eating behavior in first year medical students and MBBS interns, to determine and compare the perceived stress among both groups, to study the association of perceived stress and disordered eating behavior. Inclusion criteria: age more than or equal to 18 years, male, females and others. Medical students of first year, undergraduate and MBBS interns, these both groups have been taken. Students are willing to participate for the study. Exclusion criteria: no case of psychiatric disorder or on psychiatric medication, substance dependence except nicotine dependence. Sampling, convenient sampling, sample size for both participants who consented for the studies. It was 139 students after excluding. Study design, cross-sectional and comparative. Period of study was 2 months. Days, both government and private medical colleges of Hyderabad. Ethical considerations data was collected after taking informed consent and confidentiality was ensured. Ethical committee approval was taken from the Institute's ethical committee. Methodology, the data was collected by self-report questionnaire through Google Forms. Semi-structured intake pro forma for regarding social demographic data was collected. Disordered eating behavior was assessed by eating attitude test E26 scale, and stress was assessed using perceived stress scale. These are the studies to eating disorder test, attitude test E26 and perceived stress scale. Statistical analysis was done by SPSS. Review of literature showing the prevalence of disordered eating behavior ranging from 11% to 29%, and the prevalence of stress around 42% among the medical students, and female students having higher stress. Results: a total of 139 students participated in the study. Of the respondents, 71 were from first year MBBS and 68 were from internship. 40% were male and 59% were female. This is showing social demographic data, gender, college, year of study, along with high risk for eating disorder and high stress levels. In results, about 58% students were the body weight were in the normal range, and 11% students had underweight, 23 were overweight, and 7.9% of the students were obese. The E26 results were revealed that 27, that is 19.42% of the participants scored above 20, putting them at high risk of possible eating disorder. That disordered eating behavior. Among males, 21% reported high scores, and females, 18% of the females had high scores, and 31% of the students who scored high on each score were overweight, and 27 were obese. 27% were obese. There was also a positive correlation between BMI and disordered eating behavior, which was statistically significant. PSS value revealed that 35 students, that is 25%, were under high stress, and 62% had moderate stress. And it also revealed that 32% of the females had high stress, when compared to the males who had 14% were under high stress, and which was statistically significant. This table showing the risk of eating disorder and stress level across the study subjects. There was not significant when we compared with first years and the interns. The difference was not significant. A positive correlation was found between stress and disordered eating behavior. 51% students having disordered eating behavior were under high stress, and 37% were under moderate stress, which was statistically significant. Pearson's correlation coefficient between PSS scores and E26 scores was found to be 0.356, which indicates moderate correlation and found to be statistically significant. This table shows the Pearson's coefficient. The 2 stars indicate significant at less than 0.01. This is a table showing eating disorder risk and stress. You can see 14, that is 51% of students who are under high stress had high risk scores for eating disorders. In our study, overall prevalence of overweight was 23% and obesity was 7.9%. These findings were similar to other studies done by Ramaya et al. And Chabra et al. The prevalence of disordered eating behavior was found at 19.42%. This finding was similar to previous studies of Ramaya et al. And Srinivasan et al. And other studies done in Lebanon and Pakistan. The study also revealed that 35 students were under high stress, and moderate stress was highly prevalent among both genders. Also revealed that 27 females, that is 32.53% of the females have high stress compared to males, and which is similar to other studies. A positive correlation was found between stress and disordered eating behavior. Conclusion: the prevalence of overweight and obesity is on rise in medical students. Prevalence of disordered eating behavior is high among medical students, especially in those with high stress levels. Females are more prone for high stress, while moderate stress was highly prevalent among both genders. There was positive correlation between stress and disordered eating behavior, leading to hypothesis that high stress is associated with disordered eating behavior, putting them at high risk for eating disorders. Routine screening with questionnaires and interviews and further referral to a psychiatrist can potentially aid both early diagnosis and treatment of these illnesses, and also prevent serious psychiatric illnesses like eating disorders. Implications of study: students who report high stress must be assessed for psychiatric disorders like eating disorders. Students having disordered eating behavior should be regularly screened with questionnaires and interviews and should be referred to psychiatrists. Limitations: the scale used for disordered eating behavior was a screening test, not diagnostic test. and simple size was small. A recommendation for research, future research is further study involving larger sample size and longitudinal studies design are needed to establish the causal association between stress and eating disorders. These are the differences.
Thank you, Dr. Wasi. Any queries from the floor?
What is disordered eating behavior? I didn't get that.
It's a spectrum between normal eating and eating disorders.
So what are we assessing here? Are we assessing eating disorders or are we assessing what is exactly?
Like disordered eating behavior can be like symptoms of eating disorders.
There can be precursors to eating disorders or risk of having an eating disorder.
High risk for eating disorders.
Okay. So what is EAT26 actually? What does it assess?
It assesses it's a 26 questionnaire item. It assesses dieting and oral control subscale and bulimia subscale. The questions are there. Different types of questions like do you vomit after eating, or do you fear of gaining weight?
Is it a screening instrument or is it
a screening instrument?
What does it screen for?
It's screening for eating disorders.
Yeah. So my problem is only with the title of your this thing. Maybe you should have said risk of eating disorders in medical students. Then the whole thing would actually have fallen. Why did you use the other term? I really didn't understand because it's not a technical term, neither it is anywhere valid sort of a term. Okay, so that's the only thing.
Thank you.
Any more questions?
Any data or any cohort study states what proportion of this disordered eating behavior would turn up into actual eating disorders? Any cohort studies or such kind of data?
Such studies are not there, but many studies regarding this only, like high risk for eating disorders have been done.
No, maybe for example, if any study has followed over the next 3 years, those who have these behaviors finally turn up to eating disorders.
I quantified such studies.
Because usually the prevalence of eating disorders is very low. We hardly see in clinical practice. So how many of them might get turned up into eating disorders? Any such kind of data you have?
No, sir.
Because that actually means, right? So in the follow-up, they might, over the time, they may actually become an eating disorder patient. So that will be very useful actually. Or if you can follow up this data over the next few years, then that would be actually helpful.
Thank you.
Yeah, thank you. I invite the next speaker, Dr. Kalyan Vainala, for his presentation.
Good evening everyone. I'm Dr. Kalyan, Psychiatri second year resident from IMH, Hyderabad. Title of our study, a cross-sectional study of knowledge and attitude of nursing students towards electroconvulsive therapy. Introduction. ECG it is a multidisciplinary approach and it is a team approach in which a psychiatrist, treatment nurse and anesthetist are involved, and it ought to consider as a minor OT procedure which includes pre-operative preparation and post-operative care. ECT is effective treatment but divergent and controversial. Our two courses, general nursing midwifery and BSc nursing students. Inclusion criteria: aged 18 to 45 years, nurses who had not done psychiatry postings and who had given the written informed consent. Methodology. A cross-section study on the nursing students attending a tertiary care hospital on a rotational basis. And EC approval committee was obtained by the Institutional Ethical Committee of Osmania Medical College. BSc and GNM nursing students who had given written informed consent on the first day of the psychiatry rotational postings were included in the study. A semi-structured intake proforma was utilized to collect socio-demographic data, and the nursing students were requested to complete a questionnaire which is designed to assess the knowledge and attitude towards ECT. This is a review of literature where a few studies are showing that nurses have poor knowledge over ECT and have negative attitudes towards it. Results. A total number of 135 nursing students were included in this study. Out of 61 were BSc nursing students and 74 are general nursing students. The mean age of these studies is 21 years. Let's get into tables. Okay. The mean age is 21 years and most of them are female nursing students, 86.7% are females and 11.9% are male nursing students, which consists of 45% of the BSc nursing and 54% of the GNM nursing students. And most of the people, students belong to lower middle class and all are unmarried subjects. This is a second table which is showing that history of psychiatrists in the family, previous experience to the ECT. There are very few people, just 1 or 2 people in the subjects who have history of psychiatrists in the family or any first degree and second degree relatives with psychiatric illness. These are the tables that showing knowledge about ECD in BSc and GNM student. Most of the nursing students have knowledge about the general boards of ECT and side effects of the ECT. But GNM the ECT, the nursing students have very poor knowledge on mechanism of action, how ECT works. Here we can see the scores that most of the BSc nursing students, 90.16 and 98% of the GNM nursing students have poor knowledge about the effectiveness of ECT. Discussion. Nurses being consistently present and accessible to the patient and their families in hospitals hold a pivotal role in healthcare. So, while diagnosing and prescribe treatment, nurses spend extensive time directly interacting with the patients, making them crucial for the source of information. So, the study was evaluated on both BSc and GNM nursing students, revealing generally good knowledge regarding ECD indications, procedural aspects and logistical considerations, such as concern during outpatient feasibility. However, awareness of the ECT regarding effectiveness and potential side effects, especially among GNM nursing students, was notably deficient. This deficient could lead to the dissemination of inaccurate information, reluctant to engage in discussions about ECT, and subsequently impact patient decision-making process and outcomes. BSc nursing students are in medical field for 4 years compared to general nursing students, we are 3 years, which explains the better knowledge and attitude in them. Media portrayal, which often sensitizes ECD negatively in movies and television, was identified as a significant contributor to these misconceptions among healthcare professionals and a public eye. Addressing these challenges through targeted educational interventions could enhance the acceptance and effective utilization of the ECD as a treatment option. Most of the nursing students, 80% of the GNM, 60% of the BSc nursing students have negative attitudes towards ECD. Conclusion, the current study identifies gaps in nursing students' knowledge regarding ECT and highlights the need for comprehensive education on ECT mechanism, patient preparation, mode of action, and potential side effects. Limitations in the study was limited to only one center, so we cannot generalize the results to all nursing students. And it was a cross-section study. It had to have instead longitudinal study where we can assess the nursing students on the first day of the posting and the last day of the posting, so we can show better knowledge and attitudes whether improved or not. implications. Addressing these knowledge deficiencies is crucial to enhance understanding among nursing students, ultimately fostering greater acceptance of the ECG as a treatment option by reducing stigma and misinformation. Reformed education can play a significant role in promoting patient acceptance and improving overall perceptions of ECG within the healthcare. This is the scale we have used. Knowledge part, performance scale, semi-structure intake performance. This is the ethics committee approach. Thank you.
Any questions?
I wanted to understand as to why you chose these two groups.
GNM and GNM.
What is the difference between the two groups?
Sir, to evaluate like how it's a knowledge in GNM and BSc nursing students.
No, why are these two groups separate? Or is it, what is the difference between the two groups?
Groups, like educations and qualifications. Like in BSc nursing, there are students taken with minimum qualification of the MCI or NEET. But GNM students are not who are qualified at NEET. And we art group people can also join into GNM nursing students.
So when did you actually do the test? In the sense it is the first year BSc student, final year BSc student, final year GNM student, first year GNM student, what was the time frame?
Second year GNM students with BSc third year students.
So both of them finished. Okay, according to your understanding, BSc nurses more exposed to psychiatry or GNM nurses more exposed to psychiatry? Or are they equally exposed?
BSc are
more. How many months posting usually they have?
Usually 45 days.
And GNMs?
1 month.
1 month. Okay, so 15 days more exposure.
Yes.
So you tend to find that GNMs would have less awareness or attitude would change.
Both of them have less knowledge and attitude. Compared to both of them, BSc are somewhat better.
Okay, fine. Thank you.
Thank you, sir.
Yeah, please, sir.
To just know, should we expect those students who are coming for the first time to the posting, do we expect them to have a good knowledge about ECT? At least the attitudes may be different. So do we expect? Because even a lay person, they are equivalent to lay because they are there for the first time into the psychiatry. So do we expect them to have more knowledge about ECTs?
Instead, there was capital limitations like instead of we did a cross-sectional study. Instead of doing a cross-sectional study, if we had done a longitudinal study, it would be better. So like whether the knowledge and aptitudes improved or not improved, we have found it.
So what prevented you from doing that?
Things. Initially, I want to first check this and next I will do the further studies, long-term study.
Yeah, your time is up.
Thank you, sir. Thank you, everyone.
Thank you, Dr. Kalyan. I invite the next speaker, Dr. Athira.
Good evening, everyone. I am Dr. Athira here, presenting a study before you. My study is a cross-sectional study of personality traits associated with alcohol dependence in patients attending the psychiatry outpatient in a tertiary care center, Sangareddy. According to the WHO, alcohol is a toxic and psychoactive substance that can lead to dependency. If alcohol use contributes around 3 million deaths globally, and harmful use of alcohol accounts for around 5.1% of the global disease burden. Personality traits were considered as forerunners for alcohol use and dependence, and several key traits have been linked to the severity of alcohol use disorders. In the current study, we'll be utilizing mostly the 5-factor personality model, which includes the big 5 personality traits, that is
neuroticism, extraversion, openness to experience, agreeableness, and consciousness. The aim of the current study was to establish personality traits and its association in alcohol dependence patients. The objectives of the study included to assess the socio-demographic profile in alcohol dependence patients, to establish the personality traits in alcohol dependence and its association with the personality traits. It was a cross-sectional hospital-based descriptive study conducted from the months of January to March 2024 in patients attending the psychiatry outpatient at the tertiary care center. Sample size obtained was 50. It was discussion of my study according to each demographic variable. When we are coming to the age and gender, my mean age in my study came to be around 33 years, and it corroborated with the other findings from Compton et al. And Grant et al. But majority of my participants turned out to be female, which actually contradicted with the other studies from Compton et al. And Grant et al. Education level, most of them were not educated, around 48%, which actually corroborated with other findings from other studies. If you look at the occupation, my studies contributed around 48% were farmers, and if you look at other studies from Malaya et al. Or Samsad, most of them had higher rates of substance use in occupations having hard labor or manual labor. Monthly income showed significant variability in my study, and it was actually in other studies like Hasin et al. And Califajaf studies. they showed that lower income was associated with higher rates of dependence. In marital status, most of the participants in my studies were married, and it is actually a contrasting finding by Lawson et al., which actually showed that marriage was associated with lower rates of alcohol dependence. Residents in my studies, most of the participants were from rural areas. It again corroborated by a finding from Kumar et al. The type of families, they showed different drinking patterns in studies by Morse et al. In chi-square analysis, we have seen that family structure influences personality traits. It was again corroborated. Then we come to the socioeconomic class that we had mentioned that extraversion and neuroticism was seen more commonly in lower socioeconomic classes, and openness to experience was more common in the upper middle class. This is again corroborated in studies by Mayers et al. And Roberts et al. We come to the conclusion that alcohol dependence affects a broad range, with majority of the participants being female, primarily concentrated in the early 30s. And note that mostly half of the participants were not educated. And naturally we can link it also with the socioeconomic status of my study, which was actually low. We can come to the conclusion that most of the low socioeconomic class or illiteracy can actually contribute to high dependency. And hard labor, because farmers constituted a large scale of my study, we can also conclude that hard labor will also contribute to some extent to dependence. Marital status and the type of residence, that is rural areas, this actually we can come to a conclusion that most of the cultural acceptance in rural areas, we can see that. And that's it.
Dr. Atira has completed her presentation. Any doubts, any queries?
I have a couple of questions here. What's your research question? What exactly was your primary objective?
My primary objective was to assess the personality traits in alcohol dependence patients.
Yeah, you had some reference to that. You wanted to have control group and see whether it is acceptable or not. It's the same.
I wanted to see which personality traits will be more common. I didn't have a control group. I just wanted to see which personality.
Results you would actually show various correlations with various others.
Yeah.
The primary focus is not on the group as such, in general.
It is in general. It's not to. It was like convenience happening. So there were no two groups as such.
So you have a group of alcohol patients.
Yeah.
In them, how did you say what percentage of them had openness? Any such results you have?
In general, no. Because
That was your objective.
Yeah, but when we are further objective was to link it to further demographic traits. So that's why I have linked each demographic trait to a particular personality trait.
Once you have linked, what are the implications of this?
We can go for targeted interventions for the patients, because when we are linked to demographic traits, now we can know which type of residence or which type of age distribution or which type of gender distribution have more implications or have more tendency to go towards dependence. It is not only beneficial in an individual level but also in a preventive strategies. We can use it because it can be used at a general level, because we'll be more aware.
Do you think the results of your study are generalizable to that extent?
No, but yeah, when further studies in a longitudinal study should be done with a larger sample size, then it can be generalizable. But my current study is not.
Okay, thank you. Your time is up. I invite the next speaker, Dr. Nandini.
Good evening everyone, I am Dr. Nandini, second year postgraduate from GMC Siddipet. The title of my study is a cross-section study to assess mental well-being of medical professionals at a tertiary care center in Siddipet. Mental well-being is a crucial aspect of overall health. It relates to the classic WHO definition of health, that health is a state of complete physical, mental and social well-being and not merely absence of disease or infirmity. Mental well-being per se means having positive feelings about oneself, having good relationships with other people and living with a sense of belonging to the society. Medical profession has a competitive environment where independence and resilience are required and celebrated, but it comes with a common notion that it's okay for medical professionals to work for prolonged hours, the threat of workplace violence and disturbed sleep cycle and emotional exhaustion. Because of this, they tend to overlook their own symptoms and are more prone to some stress-related disorders which can directly affect the quality of healthcare system. My justification for the study would be very few studies have been done to assess mental well-being of medical professionals. It also helps to create awareness about the need to look after the mental well-being of medical professionals, and it can prevent suicides. My aim and objectives of the study are to assess mental well-being of medical professionals and also to determine the association of various factors with mental well-being. Coming to review of literature, according to an international study done in Turkey in 2022 by Isagul et al., concluded that mean WEM-WBS scores was 52.95 and that gender, marital status and education levels condition mental well-being in a statistically significant level. A cross-section study done in Pakistan in 2021 observed that younger participants and males scored significantly higher than older participants and females respectively, and that physicians practicing in public hospitals scored significantly than physicians practicing in private hospitals or clinics. According to an Indian study done in Punjab in 2015, showed that the mean WEM-WBS scores, Warwick-Edinburgh mental well-being scores, is 48.1, which is lower than the general population, and that males and older participants have scored significantly higher than females and younger participants respectively. This is a summary of my methodology, where the study setting is Government General Hospital Siddipet, and it is a cross-sectional study where a convenient sample of 120 medical professionals have been taken after Institutional Ethics Committee approval. My inclusion criteria is like medical professions of age 20 to 50 and those who have given consent. And those with pre-existing mental illness and those who are on active psychotropic drugs were excluded from my study. After obtaining informed consent, subjects were asked to fill Warwick-Edinburgh mental well-being scale, which is a 14-item scale. With 5-point Likert type scoring system developed by Tennant et al., which has good internal consistency and high test-retest reliability. The total score ranges from 14 to 17, where less than or equal to 45 indicate poor mental well-being. Scores of 41 to 44 indicate possible or mild depression, and less than or equal to 40 has high risk of probable clinical depression. Coming to my results, 83% of the study subjects were less than or equal to 30 years of age, 64% were females, and 64% were unmarried. 60% of the study subjects stayed away from home in a hostel, and our sample had an equal distribution of house surgeons, postgraduates, and nurses. And 8.3% of the study subjects had family history of psychiatric illness. The mean age of the study participants was found to be 27.43, and mean WEM-WBS score of the participants was 50.51 plus or minus 10.23. Mean scores of the male subjects was found to be 55, whereas those of the females was 48. Participants residing in home had a mean score of 53, which is higher than those residing away from home. Coming to profession, nurses scored significantly higher than postgraduates and house surgeons with a mean score of 56. Mean score of those who had family history of psychiatric illness is 42, which is significantly lower than those who had family history. Mean score by age group and marital status had showed no much significant difference. Coming to individual items of WEM-WBS scale, the highest mean score of 3.8 was found for the item I have been feeling good about myself, and the lowest mean score of 2.7 was found for the item I have been feeling interested in other people. Coming to the discussion part, mean WEM-WBS score in our study was found to be 50.5, which is almost equivalent to the 2017 study done on general practitioners by Anna Murray et al. This average score is nearly close to poor mental well-being, and this might be attributed to prolonged working hours, academic stress, job strain, effort-reward imbalance, and organizational injustice. The statistically significant difference is considered as P less than 0.05. So our study found statistically significant difference between mean scores of males and females, where males scored significantly higher with a p-value of 0.001. And this inequality has been observed globally, which tells that males had higher mental well-being than females, and that females need to stress more in inculcating certain activities which promote their mental well-being. And also statistically significant differences like P is equal to 0.002 was also found between participants residing at home and hostel, stating that those residing at home had higher mental well-being, and this might emphasize the need to improve hostel facilities. And family history of psychiatric illness also showed significant difference in Warwick-Edinburgh mental well-being scores, where patients with no family history had higher mental well-being compared to those who had family history. This point highlights the need for the people with family history of psychiatric illness need to be more vigilant in taking care of their mental health, mental well-being. Coming to profession, nurses had higher mental well-being than postgraduates and house surgeons with a p-value of 0.006. And this needs further investigation as to what factors might be the cause of poor mental well-being among house surgeons and postgraduates compared to nurses. And there are no statistically significant differences observed between age group less than or equal to 30 and more than 30, and also between married and unmarried participants. This is in contrast to several other studies, and especially for the case of marriage, our study findings are against the statement that marriage is a productive factor for maintaining higher mental well-being. Coming to the conclusion and implications, our study concluded that overall score is near to poor mental well-being, which highlighted the need to prioritize or promote mental well-being in medical professions, which until now has been overlooked due to decrease of no awareness, decrease of no personal time due to their prolonged work hours, culture that prevents doctors from seeking medical help, and also the medical fraternity framework. This study also concluded that male participants with no history of family illness, participants residing at home, and nurses had higher mental well-being than others in the study. Certain individual and organizational level interventions like mindfulness and yoga, and organizational level interventions like setting reasonable working hours, increased salary to promote effort-reward balance, connecting mental health awareness programs to create awareness among medical fraternity. These interventions can help promote mental well-being in medical professionals, and this can improve quality of healthcare services. Coming to the limitations of my study, the nature of cross-sectional study could be a limitation, and sample size also might be too small. These are my references. Thank you.
Dr. Nandini has completed her presentation. Now it's open for discussion.
Thank you, Dr. Nandini. So one question. I did not see that in your limitations. You think that the questions that you use, the questions that they are there, are they valid for Indian doctors, Indian professionals too? Because I see certain things such as working hours. Working hours in Europe or in the US may not be the same. The kind of stress will be different. Second is the reward thing. You don't expect rewards in India, as such.
So that's a common notion, sir. That
so are these questions really valid to Indian context?
Yes, sir, it is, because the mental well-being in our profession, which needs to be taken care of, we have to take care. We are going to serve the patients and nurses.
No, I'm not saying that. I think with better questions, our rates would have been much lower. We will be having more stress.
Okay. Maybe, sir, that might be. But I have used this scale. Maybe I can use some other scale which can measure more proper stress levels and anything in the future, sir. In future studies or something.
Thank
you. Your average score was around 50.2.
50 point, yes, sir.
Is it poor?
Actually,
above 50
sir,
is
less than or equal to 45 considers poor mental well-being, sir. It's nearly to poor. I mean, around 60s is considered like average or good 60s. It's near to poor, sir. I mean.
Okay. That's fine. Because I was really worried about it, because everyone who is working there is really not of such a good mental well-being. So how many of these in your study had scores suggestive of clinical depression?
Around 20% of my study sample.
So
yes, sir.
So what did you do with them actually?
I actually, while taking the sample, I did not, this was my study, sir. I am taking data, but I already told them like to practice some non-pharmacological interventions. If it is not, in their hands with those interventions, I also recommended blood testing for pharmacology.
Evaluated in detail and diagnosed depression.
I haven't, sir. Actually, I should have done that.
What is well-being and why you excluded mental ill patients and history of mental ill patients? Why you are excluded?
Sir,
maybe there are more well-being, I think.
Sir?
Maybe there is more well-being for mental ill patients.
More well-being for mentally ill patients.
Why?
Sir, mental well-being is in contrast to mental, illness or ill-being.
Anywhere that is depression is good.
No, sir, it's a broader term, sir. It's having.
Health is disorder plus well-being.
Yes.
Whoever have a disorder, separate, both are separate. Now, as per the definition.
But I don't want to make such confusion here. I excluded them in order to have clarity, because whoever is having mental illness and whoever are on psychotropic drugs, they might be false positive results might be coming. I just want to avoid that confusion. Thank you.
Thank you. I invite next speaker, Dr. Anna Sai Krishna Yadav. Esteemed psychiatrists and my fellow postgraduates. So, imagine a world where virtual adventures are more compelling than real life interactions. Imagine a world where the lines between living and gaming blur. Imagine a world where there is a profound burden on mental health and functioning of young adults. This is the reality for millions of young adults globally. So, myself, Dr. Sai Krishna, final year postgraduate from Kamneni, and I'm honored to present this research topic to all of you. The title of my research is Aggression, Impulsivity and Functional Impairment in Young Adults with Problematic Online Gaming. These are my contents. I'll start with the introduction. Emerged in the 1990s, gaming is now a popular global recreational activity irrespective of age, gender and culture. By 2012, over 1 billion individuals played computer games. In response to its growing prevalence and addictive nature, it has been incorporated into the appendix of DSM-5. In May 2019, gaming disorder has been officially recognized and added as a diagnosis in ICD-11. So, internet gaming addiction is a behavioral problem, and several research teams made efforts to define its prevalence. Some studies have reported it to be 1 to 2%, and some studies as high as 14 and even over 20%. There is relatively less Indian data on problematic online gaming and the effects it has on individuals' psychosocial health. Aims and objectives. The study aims to investigate the prevalence of POG in young adults and its associations with impulsivity, aggression and functional impairment. My objectives are to investigate its prevalence in young adults, to analyze its relationship with impulsivity, to examine its association with aggression and to assess its impact on functional impairment in young adults.
Coming to methodology, this study was conducted at Department of Psychiatry, Kamini Institute, Narketpalli, among various undergraduate colleges in the Nalgonda district. It is an observational cross-sectional study conducted between June 2023 to March 2024. My sample size is 732 and it was approved by the Institutional Ethics Committee. The participants included in the study are individuals aged 18 to 25 years of either gender who have given written informed consent, and those who are excluded are individuals with any known psychiatric disorders and conditions where interview was not possible due to any reason. These are the instruments of use. These are standardized rating scales and psychometrics. The study procedure, this cross-sectional study was conducted among individuals from UG colleges in Nalgonda. Written informed consent was taken from study participants by assuring them confidentiality of their identity. Socio-demographic profile was obtained using semi-structured proforma, and standardized rating scales were used for data. For statistical analysis, TSPSYCON 2024 was used. Moving on to results and discussion. Table 1 shows socio-demographic profile. So, in my study of 732 study participants, the problematic online gaming was found in 70 subjects, that is 9.3%. This is 1 in 10 young adults. So, majority of my study, that is 38.7%, belong to 20 to 21 year age group, 61% were females, and problematic online gaming was more among 18 to 19 year olds, and it was clearly more in males than females, and by using chi-square this relationship was found to be statistically significant. These prevalence results were on par with the studies done on a national representative sample in United States as well as a Singaporean study which reported approximately 9% prevalence, and other studies by Gentile et al., Rebhan et al. And Van Ruiz et al. Found the prevalence to be 0.6 to 11.9. The male preponderance was consistent with the findings of Chi Hanko et al. And Watmer et al. Moon et al. Reports that the possible reason for male preponderance could be the feeling to pursue the feeling of achievement, to make social contacts and enhance self-esteem. Second table, it shows that in our study 71.3% were from urban background, 81.4% belong to nuclear families, and 64.1% from upper middle socioeconomic status. Problematic online gaming, POG was higher among rural individuals from extended family, that is 27.3%, 18.3% with POG were from lower middle socioeconomic status. While domicile and family type showed statistical significance, socioeconomic status did not. The reason for higher prevalence could be fewer restrictions imposed by parents and disseminated availability of smartphones and online games, even in rural backgrounds among all socioeconomic statuses. Table 3 shows that mean scores of impulsivity were higher in those with POG than those without, and this was statistically significant using independent t-test. Among the subdomains, impatience showed statistical significance while the other two did not. Increased impulsivity may lead to passive aggression in daily life, affecting family and friends, resulting in relational disturbances and functional impairment. Our study findings were on par with Brunberg et al. Table 4 shows that aggression, the mean scores were higher in those with POG than those without, and this was statistically significant using t-test. Among the subcomponents, auto and physical aggression showed statistical significance with POG, while the other two, verbal and aggression against property, did not show any significance. These findings align with meta-analysis done by Lee et al. And the increasing stress levels may be the potential reason. Table 5 shows that functional impairment was more among those with POG than those without, and this was statistically significant. This is on par with a study done by Milieu et al., who said that playing excessive video games can lead to functional impairment. All of this data suggests that there is positive association. Limitations, since our study was a cross-sectional design, there could be recall bias, and since it was self-reported, there is possibility of social desirability bias. Moving on to conclusion, in this internet era, it is essential to conduct more research and incorporate questions related to POG into routine assessments of young adults to ensure comprehensive evaluation and management. There is an urgent need to implement mass awareness programs for students and their parents about the growing prevalence of POG. These programs should address its psychosocial impacts, emphasize the importance of parental supervision over content, screen time, and to promote healthy lifestyle practices. These are my references. Thank you.
Sai Krishna has completed his presentation. Any doubts, any queries?
Thank you, Dr. Sai Krishna. I'm assuming the scales that you use are all in English?
Yes, sir. And also translated them into Telugu.
Translated them into Telugu?
Yes, sir.
Because you did not mention that in the presentation.
I'm sorry.
And I was expecting that it's in English and all the undergraduate colleges are all English medium.
They were, sir.
Did you use a standard procedure to translate them?
Yes, sir.
Yeah, so I was asking how did you translate those? Translation. Translation and translation.
So actually did not use the proper way. Sorry.
Okay, if there are no questions, I invite the next speaker. Thank you.
Thank you.
Dr. Shweta Jambi.
A very good evening to everyone. This is Dr. Shweta Jambi, final year postgraduate from the Department of Psychiatry from MNR Medical College. The topic of my research is hypochondria, to assess the severity of hypochondria among medical students using the hypochondria severity scale. Hypochondria is a modern phenomenon characterized by excessive and compulsive online searches for health-related information, often accompanied by heightened anxiety and distress. This behavior is frequently characterized by a persistent preoccupation with illness and ongoing health concerns that remain unresolved despite medical examinations or diagnostic tests. The term hypochondria was coined to describe the specific behavior of excessive online health-related searches, which can lead to increased health anxiety and potentially interfere with daily life. Research has identified several key features of hypochondria, including compulsive searching. Here, the individuals with hypochondria engage in excessive and compulsive online searches for health-related information, often at the expense of other activities. Distress and anxiety. These searches are often accompanied by significant distress and anxiety, which can interfere with daily life and relationships. Reassurance seeking. Hypochondriacs frequently seek reassurance from medical professionals or online sources, which can further exacerbate their anxiety and health concerns. Mistrust of medical professionals. Some individuals with hypochondria may develop mistrust of medical professionals, leading them to seek alternative sources of information and potentially delay or avoid seeking professional help. The aim was to evaluate severity of hypochondria among medical students using the hypochondria severity scale, and the objectives to quantify the severity, that is to measure and categorize the severity of hypochondria in medical students based on the hypochondria severity scale, identifying the proportion of students who are severely, moderately and not affected. In the component analysis, and to analyze the individual components of the hypochondria severity scale, that is the mistrust, excessiveness, distress, reassurance and compulsion, to determine which aspects of hypochondria are most prevalent among medical students. It is a cross-sectional observational study, and the study was conducted over a period of 1 month, that is in December 2023, in the medical undergraduate students attending MNR Medical College and Hospital, Sangareddy. And the sampling method was convenient sampling, and a total of 100 students who were willing to participate were enrolled, and the scale used was hypochondria severity scale, and it was analyzed using the SPSS software, that is version 23. The hypochondria severity scale measures severity across the 5 factors, that is compulsion, distress, excessiveness, reassurance seeking and the mistrust of medical professionals. The medical students who were currently enrolled in a recognized medical institution were taken into the inclusion criteria along with students who aged above 18 years and older. Students who also provided written informed consent and who were willing to participate in the study were taken into the inclusion criteria. Students who did not wish to consent to participate or who were diagnosed with a mental disorder that may confound the results, that is anxiety and hypochondria, were excluded. Students who were not fluent in the language were also not taken into consideration. Students who have participated in a similar study in the past 6 months were also excluded to avoid the bias from prior exposure, and students who are not regular to college were also excluded. In the results, the demography, that is 100 students were taken, out of which 50 were male and 50 were female, and the mean age was 20 years. 46% of the people were scored in the excessiveness who were severely affected, and 38 were severely affected in the reassurance domain, while in the moderately affected, distress was scored higher and compulsion was scored higher. And in the total burden of hypochondria, that is in the overall, severely affected were 32.73, moderately affected were 60.04, and not affected were 7.23%. The results of this study provide a comprehensive understanding of the impact and prevalence of hypochondria among a cohort of medical undergraduates. The compulsion construct can negatively impact the social, professional, and academic lives of people. This compulsion to repeatedly check for health-related information online was found to affect 66% of the participants moderately and 18% were severely affected. Similar results were also found in the studies conducted by White and Horwitz and McElroy and Shevlin. The distress construct is more subjective and suggests that there is a feeling of distress associated with online health research. Such a finding was observed in 92.97% of the participants in Degard et al. Singh and Brown also found a positive correlation between anxiety and searching for illness and wellness information. The most common health searches were about possible causes of symptoms, information on diagnosed medical conditions and treatment options. The majority of participants fall into the moderately affected category, that is 73%, for distress, highlighting the emotional burden associated with hypochondria. In the present study, excessiveness construct was reported by 99% of the participants, and the reassurance construct indicates that the individuals with hypochondria seek information from doctors about the conditions that they have read online, and such findings were reported among 96% of the participants. The mistrust construct indicates a lack of trust in online health information, and in this study, 38% of the participants were severely affected, 49% were moderately affected, and 11% were not affected. This is in contrast with the other studies where the results shows 19.29% of the participants, while 80.7% of the participants got reassured after discussing their online health research with their medical professional. This study underscores the substantial burden of hypochondria among medical students, with a total prevalence rate of 92.77%. The findings indicate that the majority of the students are either moderately or severely affected by hypochondria, with significant impacts on their mental health and daily functioning. The analysis of the hypochondria severity scale components reveals that excessive online health searches, distress, reassurance seeking, and compulsion are particularly prevalent. Addressing hypochondria requires a multifaceted approach that includes mental health support, educational interventions, and robust support systems. By raising awareness and providing resources to manage hypochondria, medical schools can help students maintain their mental health and academic performance. Future research should explore the effectiveness of various interventions and continue to monitor the prevalence and impact of hypochondria in different populations. These are my references. Thanks.
Nita, you have completed well in advance. Good timekeeping. Any doubts, any clarifications from our audience?
Seeing your presentation, 2-3 presentations from the past, I'm really worried that medical students are suffering from majority of the disorders. And even in your disorder, you projected it as somewhere around 92 to 93% as hypochondria. So how significant it is it necessary for us to intervene even without studying, based on your study?
Sir, I feel it is very important because in the post-COVID era, people have started searching for information online. And also when a medical graduate, medical student enters into the medical profession, they are very inquisitive to learn about new things and about the health-related problems. So when they are just starting out, they may have multitude of sources from which they might learn.
But
and
what exactly hypochondria is, if they are experiencing some symptoms, they should search for themselves, not to learn something.
Yes, sir.
So
but
if it is for learning something, suppose a patient has these symptoms, what symptoms, if I need to Google it or find it on the net, does it come under really cyberchondria?
Yes, sir. I agree with your point, sir. But since I restricted my study to undergraduate medical students, this places them at a higher risk for having cyberchondria, sir. Because when they are learning about stuff, they might feel that they are suffering from a disease or a disorder.
Does the scale tells that the items tell that do you Google it for your symptoms?
Yes.
Does it say?
Sir, yeah, essentially it means that, sir, because they want to clarify and satisfy themselves whether they are actually suffering from the disorder or not. And they might also consult many medical professionals in order to confirm whether they do actually suffer from it or not,
sir. Thank you, Dr. Sweta. Next person.
Why are chosen medical students?
Sir, because they are at a higher risk for developing cyberchondria, sir.
In the literature like that, higher medical students, previous studies in this.
Sir, there were studies, sir, that were conducted in Kolkata and Chennai also, sir. Because medical students are very inquisitive, they want to learn, and whenever they learn something, they usually apply that information to themselves. And this is why they develop anxiety and distress. And this is when they approach medical professionals and online help and do online searches so that they can understand whether they do actually suffer or not. So this is why they are at a higher risk, and that is why I wanted to conduct the study on them.
Compare otherwise, other college students with medical students.
Sir, other students are usually not in touch with medical information as much as medical students, sir. So that is why. Yes, sir.
Comparative study. What is that scale?
Cyberchondria severity scale,
You
sir.
can describe the scale.
Sir, this was developed by McElroy and Sheldon, sir, in the year 1963. Earlier it had 33 questions, sir, but since it was very extensive, the questions were reduced to 15, and it consists of questions where they are asked whether the online searches will disrupt their personal life, will disrupt their other online searches, or their studies.
This is the severity scale I mentioned.
Yes, sir.
Scale or scaling scale?
Severity scale, sir. And it also has the anxiety component, the compulsion component, the distress component, the excessiveness component, and the mistrust component.
Already psychocampus is present, then we go for severity. Like that, the scale will differentiate who are having cyberchondria, not having cyberchondria. Like that, it differentiates.
Sir, there is no such diagnostic criteria for cyberchondria as of now, sir, because it's not mentioned in ICD and DSM. It's just an emerging health concern, but this scale measures whether the person has, how severe the cyberchondria is in that person.
Cyberchondria, not we don't know with your study.
Yes, sir.
Okay, thank you, Dr. Smita. Now I invite.
One more question. Is it a pathological condition?
Sir, currently this has not been classified into ICD and DSM-5, sir. So currently there is no it has not been told as a condition. But in cyberchondria, the people are obsessed and have this compulsive feature of doing online health searches. And in spite of having many negative results, they continue to seek online help, sir.
So is it causing dysfunction to them?
Yes, sir.
So can it be called a disorder?
It can be called as a disorder, sir.
So how is it different from hypochondriacal disorder?
Sir, in hypochondria, cyberchondria is a transdiagnostic syndrome, sir. It is similar to hypochondria. Even in hypochondria, there is a component where they have this feeling that they have some disorder. But the main feature differentiating is that in cyberchondria, they do excessive online health searches, sir. That may not be there in hypochondria, sir.
Or can we say it's a subsyndromal kind of hypochondria?
Yes, sir, we can.
Where it is not a pathological?
Exactly, sir. It's a transdiagnostic syndrome, basically, of hypochondria and OCD also.
So as of now, it is not pathological?
Sir, as of now, it's not put into any diagnostic criteria, sir. It may soon be included because of the emerging health concerns, sir, and the risk that it poses.
We we are already running out of time, and we are left with the 2 presentations. I invite next speaker, Dr. Sharada, to please come.
Relationship between serum electrolytes and hepatic enzyme level in oncology patients with and without delirium tremors. It is a comparative study. I am Dr. Sharda, Visitor Psychiatry from Kings, Telangana, under the guidance of respected Dr. Bhanukumar Kulkarni, HOD, and Dr. Preeti and Dr. Ravi, Associate and Assistant Professor from Kings, Telangana. The contains a background, introduction, aims and objectives, methodology, results, discussion, conclusion, and future implications. Coming to background, alcohol withdrawal is a serious condition in patients who abruptly stop drinking or reduce drinking. Delirium tremors is a severe form of withdrawal affecting less than 2% of the individuals with alcohol use disorders. Early treatment with measures are crucial for reducing the symptoms of seizures and delirium tremors. Mortality rate without intervention is considered to be 20%, and with intervention and prompt diagnosis, we can reduce it up to 1%. This study analyzed data from alcohol-dependent patients using abstinence and reduction, and I compared between the delirium tremors and uncomplicated withdrawal. And in this study, concluded that intervention and consistent treatment protocols are essential in managing withdrawal symptoms. Coming to introduction, according to WHO 2018 Global Status Report on Alcohol and Health Statistics, alcohol misuse leads to 3 million outlays and 5.3% of all deaths, and 132.6 million of disability adjusted life years, and 5.1% of all ALYS. Nearly 48% of alcohol-related ALYS contribute to non-communicable and mental health conditions. Delirium tremors is the result of alcohol withdrawal and intoxication. The symptoms of delirium are disturbances in the attention awareness and coordination, abnormal perception, agitation, insomnia, and hallucinations. Progression and fatality rate is rapid development and appears 2 to 3 days post-cessation. And peak on 4th or 5th day, the current fatality rate is less than 1%. Monitoring alcohol withdrawal by CYAR. CYAR is a 10-item scale ranging from 0 to 67, and these are the 10 items. And scoring below 10 is mild withdrawal, and between moderate withdrawal, over 15 to severe withdrawal. Exam objectives are estimate and compare serum electrolytes, sodium, potassium chloride, and hepatic enzymes, ALT, AST, and GGT in alcohol withdrawal patients with and without delirium tremors. Methodology is a cross-sectional study from April 2023 to 2024 from the Department of Kings, Karnataka. 100 participants with alcohol withdrawal were taken, and patients with delirium tremors are considered as group DT, and without delirium tremors considered as non-DT. And diagnosis was using Day-2 criteria and CYAR scale. All the patients' socio-demographic data was collected, and age and sex were matched between the 2 groups. Data collection, 5 ml blood sample was collected from all patients and sent to the biochemistry laboratory of the Kings, and values are analyzed between the 2 groups. Important early identification, management of alcohol withdrawal symptoms are crucial in improving patient outcomes. Inclusion criteria: patients are aged between 18 to 65 years are taken. All patients, male and female, who given written consent or the proper attendant consent were taken. Diagnosed case of alcohol withdrawal according to DSM criteria, and delirium according to DSM criteria were taken. Exclusion criteria: individuals with a history of other diagnostic psychiatric conditions, substance abuse, except nicotine. Patients above 65 years with chronic debilitating illnesses, and diagnosed with delirium due to other causes than alcohol withdrawal. Assessment tools are DSM-5 CYAR. Procedure I already explained. Data analysis and interpretation. Data entered into Microsoft Excel. Analysis was performed using SPSS software. Descriptive statistics were calculated. Variables are analyzed using Psychiatri test, and compare means of quantitative variables between the study groups by alphabet t-test. Visual presentation with bar charts and pie charts, level of significance, point of results. In my study, 37.5% of the male-aged alcohol individual patients had delirium tremens, and no cases were observed in young patients. Out of 100 patients, 32 patients developed delirium tremens, and 68 patients did not develop delirium tremens. Both the delirium tremens and non-delirium tremens patients show strength towards hyponatremia, hypochloremia, and potassium levels were not much change. Elevated hepatic enzymes were observed in all patients. AST levels and GST levels are more in case of delirium tremens compared to non-delirium tremens patients. Hyponatremia was significantly present in the age group of 30 to 53 years in case of delirium tremens patient, and elevated enzymes more in case of a delirium tremens patient in the age group range of 52 to 53, and in case of non-delirium tremens, the age range is 30 to 41. Here, blue box. The blue ones are delirium tremens bars and the red ones are non-delirium tremens bars. Here, 40 to 53 is the age range patients develop delirium. Electrolytes shows hyponatremia and hypochloremia. Hepatic enzymes AST and GGT are elevated. Sodium levels, about 50% of the individuals develop delirium tremens containing hyponatremia. Hypochloremia is present about 50% of the individuals with discussion. Raman et al. Study found that delirium tremens are strongly linked to delirium tremens. These findings are similar to my study and future implications. Developing enhanced predictive models integrating serum electrolytes and hepatic enzyme levels. Exploring targeted intervention for correcting electrolyte imbalances and management of the hepatic enzymes, especially in the delirium tremens. Advancing biomarker discovery for early warning signs of delirium tremens, and utilizing technology like machine learning to improve predictive models. Encouraging interdisciplinary collaborations to enhance understanding of alcohol withdrawal syndrome. Continuous study of electrolytes and aquatic enzymes is crucial for improving prediction, prevention, and management of delirium tremens in alcohol withdrawal patients. These are the references. Thank you.
Dr. Sharda, thank you. Dr. Sharda has
battery.
completed her presentation.
Thank you, Dr. Sharda. Dyselectrolytemia and hepatic dysfunction has been known to be a factor as well as is a consequence of delirium tremens. Yeah, it's been known for ages.
Associated.
So why did you want to study this?
Because to prevent, along with the detoxification, electrolyte imbalances and hepatic enzyme correction also helps to prevent delirium tremens.
It is an integral part of the treatment guidelines of DT.
So, but more prone for delirium tremens, altered disturbances and altered hepatic enzymes.
In the guidelines, when you look up guidelines to treat delirium tremens, they say apart from benzodiazepine replacement, we have to look for treat dyselectrolytemia and hepatic dysfunction.
When was the patient taken into the study? Suppose the alcohol dependent patient may come, or for patients with delirium tremens, you have taken the patient after the patient has developed delirium, or is it before?
All alcohol withdrawal patients and who developed delirium.
But after you have taken into the study, they develop delirium, or before only?
At present, after alcohol withdrawal.
So during the course they develop delirium. And then my doubt
At
is
point of presentation.
at the point of presentation. So patient who has presented with delirium to the hospital is taken into the study.
Yes, sir.
Not before when you are correct.
I've taken alcohol withdrawal patients also, sir. Without delirium tremens also taken.
Yeah, they present without delirium. So was there any assessment regarding the severity of alcohol dependence? Severity of alcohol dependence.
I applied CYA.
CYA is for withdrawal.
Yes.
Severity of alcohol dependence was taken in anything?
No. Withdrawal.
Okay, thank you, Dr. Sharda. We have a last presentation for this category. I invite Dr. Pratyush.
ఇది ఇంకోటి ఉందా ఇంకా నడుస్తుంది వేరే 18 minutes ఉంది ఇది ఒకటి అయిపోతుంది మళ్ళీ డిస్క్రిప్షన్ అది కానీ కొంచెం అదే దానికి కావాలి సరిపోకుండా ఇబ్బంది
Good evening everyone, my name is Dr. Pratyush from Bhaskar Medical College and my title is Factors Influencing Toddy Consumption in Rural Area of Telangana. Introduction. Palm wine is a fermented sap of various palm trees, especially the palm. And palm wine can be obtained in the young influence either from male and female. And palm wine is an alcoholic beverage that is made from fermented sugary sap from the various palm plants. It is collected by tapping on the top of the trunk, and by pouring a hole in the trunk, it is cloudy white beverage, and it is a sweet alcoholic taste having a short life, shelf life for only 1 day. And the wine is consumed in the variety of flavors varying from the sweet, unfermented to sour, and fermented and vinegary. And the palm wine is particularly common in parts of Africa, South India, Myanmar, Mexico, and locally it is known as Kallu, and even in other countries it is known as Emo and Ogoro. And palm sap is fermented and processed in the alcoholic beverage. It is need to correct amount of yeast temperature and even the process conditions. And throughout the world it is made from the juices of locally grown plants including coconut, palm, pambra and wild date palm. And wine is an excellent substrate for microbial growth, and the fermentation starts soon as the palm is collected. Within an hour or two, it becomes reasonably high in alcohol content. Up to the alcohol content is around 4%, and it is allowed to continue to ferment for more than 1 day, and it is transferred turning into vinegar. And the sap should be collected from the growing palm and collected by tapping the palm. It involves making a small incision in the bark 15 centimeters on top of the trunk, and the clean cord is tied to the tree, and the sap is collected in it. And the sap is collected each day and should be consumed within 5 to 12 hours of collection. And the fresh palm juice is sweet and colorless, and juice contains around 10 to 12 sugar. The toddy is local alcoholic beverage consists of fermented palm juice. And mostly the toddy is consumed by the low socioeconomic groups in the rural area. According to the National Sample Survey 2011 and 2012 data, the toddy is the most commonly consumed alcoholic beverage by rural India. The data also reveal that Andhra Pradesh, Assam, Bihar, Jharkhand, Arunachal Pradesh, Kerala were among the biggest toddy consumers in India, and it could be due to various reasons like being part of local culture, and it is an hypnotic due to, and major reason is due to peer pressure. The toddy consumption has even effects of is frequently found in the psychiatric practice in the part of the country, including women also, and and it is a very few studies were done in the toddy consumption in rural, along with the rural women in India. And many studies conducted till date are subjected to hospital-based studies, where this study is unique, and the study is community-based study. And the aim is the study of the factors including the toddy consumption among the rural areas in the Telangana region. And materials and methodologies, it is a cross-sectional study. Then study is conducted in Yankapalli village, Nizamabad Mandal, Rangareddy district and Telangana. And consent of this, we have taken the consent from all the subjects, and the number of subjects is around 100 individuals recruited in the study after taking informed consent from them, and it is visited in the respect to residents and interviewed. The subjects are assessed using the following questionnaires, and the subjects are assessed using the following questionnaires and checklist of preserved factors including toddy consumption and ICD-10 SADQ scale. Inclusion criteria: males and females aged around 18 years or above, patients meeting the criteria of alcohol dependence syndrome. Exclusion criteria includes not giving consent and individuals with any neurological disorder. And the study of analyzed by TSPSYCON-2024, and then in frequency table we see that in the age of 30 to 45, frequency 32, and 46 to 60 age in the frequency 32, and 61 to 80 it is 36. And in the majority are male, and it's around 78 out of 100. And majority in this study, majority of the subjects are all married, that is 100%. And education is around mostly uneducated, it is 74%. In the study among mild dependency group, 67.7% were males, and in the moderate dependency group, 92.9% were males, and severe alcohol dependency were 100% males. And performing ICS test, so it is one statistical segment. In the study among the mild dependency group, 81.8% were uneducated. In moderate dependency group, 50% were uneducated, and in severe alcohol dependency group, 100 were uneducated. On performing it is always statistical segment. In 30 to 45 years group, 43.8% started peer pressure as a cause of toddy consumption, and 18.8% started decreased sleep and tonic for health. And in the 46 to 60 years age group, 56.3% stated peer pressure and cause of 12.5% each stated decreased sleep and physical fatigue and tonic for health and causes for toddy consumption. In 61 to 80 years the age group, 27.8% stated peer pressure and cause 22.2% and stated physical fatigue and cause of 16.7%, and each stated easy availability and tonic for health as causes. On performance as well, it is significant. In discussion in our study, most of common cause of toddy consumption is peer pressure, that is around 42%, and followed by tonic for health, that is 16%, and physical fatigue and decreased sleep each constant of 14% and 14%. And other minor causes include easy availability, that is 6%, and stress, that is 4%, and family pressure 2%, and prevalent around 2%. Another study by my Yu et al., which is conducted in high school in Taiwan, reported the peer pressure of psychological stress was main factor maintaining toddy consumption. In other study, Sumit Chawla et al., it is reported that the peer pressure influencing factor of alcohol consumption in men. And in similar study conducted by Padmavati, it is reported that common factors alcohol is sleeplessness, and other causes reported are stress and easy availability. And in other studies, 66% had mild alcohol dependency, and 28% had moderate dependency, and 6% had severe alcohol dependency. In a study conducted by Kusman et al., found that 57 participants having mild dependency and 43 having moderate dependency. Among mild dependency group, majority 45% were in age 61 to 80 years. In moderate dependency group, majority 42.9 each, and were in 30 to 45 and 46 to 40 years group. In severe alcohol dependency, majority were 66.5 were in the age group of in 30 to 45. And in our study, among mild group, 69.7 with the males, and the moderate dependency group is 92.9. And this study, all individuals are married, and in the conclusion, it is due to peer pressure, and it is and then followed by tonic for health, and subjects are consuming toddy, and it is progressively dependent. And the withdrawal symptoms is insomnia, and the main reason for continuing of the toddy. And it is a unique study carried out in the Uran community by visiting the study population in their residence. And however, the sample size is limitation in the study, as a study recruiting a much larger sample is recommended in further. In order to be a greater unity of your community and plan effective interventions in tackling the rampant addiction. Okay, reference. Thank you.
Any questions?
Question is, where did you get the questionnaire? Is it self-designed or does it have any references?
Questionnaire we have taken from scale SADQ according to the severity and even the cause. We directly ask the patient what is the cause of first.
SADQ agreed regarding factors which influence the intake of tonic. You asked peer pressure, family pressure. That questionnaire, how did you, was it self-designed or was it used in the past by someone?
And even we checked in the past, ma'am, and it is very few, and we kept in a checklist, ma'am, like a tonic for health, peer pressure, and prevalent.
Was it self-designed, self-prepared by you or you?
Not self-driven, ma'am. We have taken from other past previous papers, and we kept in the overall group in one checklist, ma'am.
Authors? Who are authors?
Ma'am, authors are Chandrasekhar. Our authors, ma'am, other authors.
That you use. Who are the authors?
Ma'am, authors were Chandrasekhar and Srivani, and others Sumit Chawla, Padmavati, Prasadji, and Mane S.K. Kadam, etc.
Is it free to use? Standardized? Is it free to use? Licensed?
Ma'am, actually we have taken the consent, ma'am. Actually our target of the patient were around 200, but the patient didn't give the consent, ma'am. So we kept only around 100, ma'am. So we have taken the consent from the patients, ma'am.
Any more questions? If there are no questions, we'll end the session. Thank you everyone. Thank you, Dr. Pratyush.
Thank you, sir.
Now to felicitate chairpersons, I invite Dr. Lokesh sir, IPS South Zone Secretary, Dr. Shanti Mohan sir, DMHP Program Officer.
Madam, sir. Right. Okay, ready, sir? Okay, ready, sir? Cultural program start 1 hour ఉంటుంది 8 cultural program start అవుతుంది 1 hour ఉంటుంది టైం ఎంత 7:30 అవుతుంది 8 స్టార్ట్ అవుతుంది బ్రేకా